Yes, we can. Yes.
1 second. All right. Okay, so good to see you again. And for the access to latest treatment and prevention drug resistance, to me, I can see like clearly the drug resistant and for tuberculosis and people who are living with HIV. Of course, drug resistant for tuberculosis is often associated with higher mortality rates in PL-HIV, meaning that it's better integration of HIV and drug-resistant tuberculosis patients. Early diagnosis of drug-resistant TB and HIV from initiation of appropriate second-line anti-TB drugs and antiviral treatment or ART, which is it's our patients support and also strong infection control measure or essential components in the management of drug-resistant tuberculosis in people who are living with HIV. As I said before in the beginning, it's like what MPLUS do, try to close the gap for the late TB and HIV treatment. We reach out to them, we recruit to them, we go there and test them. We retrain and prevention, but it seems like it's not enough because according to the tuberculosis situation and operation in Thailand that I said this morning, so I'm going to show you this one. All right, let's go. According to like the current geographical in Thailand and also the population almost like 71 million. And so I look through like Thailand, it's between has a border between Thailand and Myanmar, Thailand and Laos, Cambodia, and some Malaysia. And also in Southeast Asia, people we migrate a lot, and also people right now today we travel so quickly. So we think like what we should do. As I read to the Thailand Thailand Public Department Health. We also plan to create a universal health coverage system to the migrant population as well. And also, what MPLUS do right now, people who actually have lower income, they do have some sort of like internal stigma, and also they're afraid, according to their poor of like education and also obstacle of timing to get into treatment. We also need to like close this gap and also create more mentality of healthcare support and literacy to all people, all genders, all over the country, including people who are coming as a tourist or refugee or migrant to Thailand. So the other ways to close the gap, as talking about medication resistance, the more they stuck with an obstacle that we cannot close the gap, that's more likely like they're gonna have like a later to come to the facility or hospital or CBO clinics to get tested. So we should perform provider-initiated HIV testing and counseling in all clients or patients with presumed or diagnosis drug resistant on TB and HIV. Testing for all patients or people, both of it could be like Thai citizen, local people, and also migrant people undocumented. The second is initiate ART promptly in drug resistance of TB and HIV patient. ART should be start promptly in all HIV infected patients with MDR TB, regardless of CD4 count. Second line anti-TB drug resistant should be initiated first, followed by ART as soon as second line anti-TB medication tolerance. Generally, this should be within the first 2 weeks of initial MDR-TB treatment. And moreover, every visit for people who are living with HIV, right? They do have to come back and get viral load tests, CD4 tests, or other STI tests. We should provide the TB test as well. And we forget one thing. We not just like pay attention onto HIV with the tuberculosis focus. We should test for non-HIV for the TB screening as well. And also for people who migrate here or doesn't have any a document, they should have a TB screening at least once a year. And also like either can be the record as a digital book or booklet that they can keep itself. This is going to be another intervention that can help reduce TB and TB and HIV cause death. Moreover, not just about like testing and pre-screening, literacy education too. It's also very important. And also, if you're able to guideline to them, to let them see the benefit of health checkup is part of self-care, and also to let them view what is pros and cons, what will be happened if they are late for treatment, and also like a basic pre-screening for them. If one of their family or one of your loved one has some sort of like symptom of fever and things, so they can do screening of self by themselves as well. The other here's the thing, like the facility to treatment for people who are in contact with the TB or people who are living with HIV and also connected with TB. I feel like the emphasis has to be given into the implementation of proper infection control measures throughout health facility in high burden setting to minimize the risk of nosocomial spread of drug resistance TB to immunosuppressed people living with HIV. Also during under tuberculosis treatment, patients should get mental health support, health literacy, and spiritual lift-up support as well. Integrated delivery of services supports early detection and treatment of undiagnosed infection TB, including drug resistance TB, and may result in a reduction of TB risk compared with a separated service. MPLUS Foundation located in the north of Chiang Mai. We not just like doing service to like local people, and also we welcome for all. What we can do, we don't have a facility to like treatment for people who are like contact with tuberculosis. We mainly focus to prevention. I feel like prevention is the best obstacle to like prevent drug resistance. We do both for PL-HIV and non-PL-HIV screening every single time when they come and visit or do some tests or get some consulting in class. Especially as for people who have some HIV, this can result in misdiagnosis or delay in diagnosis and turn to higher mobility and mobility. We do TB X-ray only first time before taking medication, but we forgot that it can be people who have a family members or people in their household who actually contact TB from outside and able to bring it back to them. So I think to do like pre-screening every 6 months for PL-HIV or non-PL-HIV and including migration and refugee should also do TB screening once a year at least.
Yeah, thanks.
So this is about like MPLUS Foundation, that's what we do for prevention and also referral to what is really appropriate for them as well. And I would love to thank you for this meeting, because as I work for the CBO and CSO, we don't have fully ability to prevent or treatment as well. So we have to like working together and cooperate each other, like CBO, community, hospital, and also like we not just work like in the regional, we work as a region and international. So I'm really grateful to be here and able to like giving feedback or reflect what we are dealing right now. If you want to go to hit to the point of HIV and TB, 100, 100, 100.
Yeah,
you have
thank
to
you.
work together.
Thank you, Ray.
So much.
Yeah.
Yeah.
Ray, thanks a lot. MPLUS Foundation has really played a key role in, in demonstrating how effective our community-led interventions and what such an important role communities are playing in delivering services in Thailand, and which is an example for so many regions, but of course it stands out in context of pre-exposure prophylaxis and so many other services where MPLUS Foundation is really a cornerstone example, along with other community groups like Swing and others in Thailand too. Thanks a lot, Ray. Because of time issue, we will definitely come back to this. We need to move forward. We have Keitho Angami amongst us. Keitho Angami, welcome. Keitho is going to tell us about the very important campaign, so 146 by 24. So Keitho, please let us know what is 146 by 24 and why it is so important in context of today's meeting. Welcome, Keitho. And thanks a lot to Treatment Action Group and TB-CAP for helping support Keitho is here because of them. Thanks a lot, Keitho.
Thank you very much for that introduction. And at the outset, I'm very happy to be here to express my concern as well as speak a little bit about the 146 by 2024 campaign is concerned. Now is the mid of 2024, and despite the launch of this campaign that happened in the year 2022 during the AIDS conference in the month of July, but the progress that has been made up till now, as far as this is concerned, is not up to the mark. And therefore, today I take this opportunity to lay out certain areas of concern as far as this campaign is concerned. And I believe this campaign is all about the race to end TB, and it's absolutely in line with the country targets, absolutely in line with the UNHLM targets as well. Now, just to give a gist about the background of this 146 by 2024, as I mentioned earlier, that it was launched in 2022 during the AIDS conference, and it was, of course, initiated by the Treatment Action Group, the PIH, and MSF. For many years, or rather 2 decades, we have been longing the community of people living with TB, and all of us alike working in the field of the TB response have been longing for such a blockbuster regimen. It could be in terms of prevention, it could be in terms of treating the drug-sensitive TB as well as the DR, form of tuberculosis. So we've been waiting for this long. But despite the fact that now we have a better regimen that can treat TB in a shorter span of time, that will also in turn save costs, save millions of lives across the globe. But the reality is of where we stand today is that it has not been accessible, nor has many of the country government adopted this in their national guideline. And these are various reasons that has resulted in numerous challenges. Therefore, unfortunately, despite having this kind of a latest technology resulting out of the research and development, it is unfortunate to see that we hear of it, we know of it, but the actual reality is that people who are in need of this are not receiving this. I believe only few countries, even as we speak today, have rolled out, not necessarily all the 146, in different categories. Countries like, for example, Malawi or India, for that matter, my country has introduced the 3HP, whereas 1HP is yet to be heard as far as the Indian chapter is concerned, but also across many other countries. I only heard about this 1HP in the country of Zambia, for example. So that is the unfortunate side of the story, and that is where people like me, the anger, the frustration builds up, and therefore we actually want to get into this kind of space so that the massive campaign to promote this, to generate demands, to ask the country to roll out these various treatment regimens for treating LTBI, for treating the drug-sensitive TB, as well as for treating the DRTB is concerned. Just in case some of us are not very familiar, though I'm also not necessarily the expert on this, but still one stands for the one month of TB preventive treatment with a course of isoniazid and rifampicin, 4 months for the drug-sensitive TB, where the treatment duration is shortened by more than 2 months. And the 6 is for the 6 months to treat the DRTB, where treatment is shortened by more than a year relatively. So that is the beauty of this campaign, and that is therefore the need to further promote this. I say this again, that long-acting technologies such as all these have has proven efficacy and has got the WHO's recommendation as well, because it is better cure rate, it is better, friendlier, lesser pill burden, shorter duration, and in the long run, it can even save millions, even 110 million US dollars is something that research also has shown. But ensuring this on the human rights perspective, the right to treatment, the right to science has not been delivered, and therefore the reason could be because of the regulatory issue. The reason could be because of the nexus of the innovators that are holding on to this drug just for the sake of profiteering, and that is something that is very untoward and should never happen. In this combination of all these drugs, we happen to also see that the drug bedaquiline and pretuminate is also part of the package of the BPAL regimen. But if I'm just to cite an example of my country, we have had a series of meetings to urge upon the Indian government to roll this out. But unfortunately, despite having the US FDA approval, the WHO recommendation, etc., and the HTA, the Health Technology Assessment, being approved, despite that, the unfortunate story is that it has not been part and package of the revised treatment guideline. Way back July 2021, the NTEP had a revision of the treatment guideline, where, of course, we are in one way happy that for so long 3HP has been incorporated, but despite this, the BPAL regimen also is still missing. And if we are to talk about India again, the highest TB burden of sensitive TB cases, the highest DRTB burden across the country is in India. Across the globe is in India, sorry. But I don't know what is pulling the policymakers back to not incorporating this kind of an initiative. And for sure, we all are aware that the Indian TB elimination program aimed to eliminate TB by 2025. But now it is 2024, 25 is just next door. And despite that, there is a discussion from the Indian government about they need to further revise it by another 2 years or 3 years so that TB can be eliminated in India. And that is the progression that is going on, which is not satisfactory. Will be losing hundreds, thousands of lives. What I also see is the hiccups resulting in all this is, I believe, more to do with, in one way, the lack of proper diagnosis system. I'm very apprehensive of even introducing or promoting 3HP in the 3HP or 1HP, for example, in the absence of IGRA and TST. Just relying on the verbal screening of the 4S is something very questionable. Despite me working with Treatment Action Group under the Impact for TB grant project and working on promoting and advocating for 3HP across the country, the proper diagnostic tools seems to be missing, and therefore it is also a very dark gray area to go on full gear as far as advocating 3HP or 1HP for household contacts or for pregnant people, etc. So those are something that I want to lay out to everyone today. Therefore, we have also initiated this campaign as soon immediately after we dispersed from the Montreal conference. Treatment Action Group, along with our TPCAT, we have been discussing about how to further this initiative to an in-country advocacy level initiative. Accordingly, we have written a group of Indian civil society treatment activists and health advocates, along with partners, have written to the Indian government urging them, the program, to update the guideline so as to support access to this shorter regimen as a human rights approach in India. And we did that on the 21st of October 2022. But sad to say that there's been no response, and then the discussion continues to it just continues without any result. And therefore, as I express my deep concern for us to collectively work towards promoting this campaign and holding our government accountables. Otherwise, I believe that this is like a direct infringement and underlining of the UN high-level commitments. The countries has to initiate all this. My last point is just a quotation to end it. To end this, I want to thank you all for your time and your patient listening. I just want to leave us this with a quote that the day we give up should never come. The day we give up should never come, else we will all die together. Thank you very much.
Thank you very much, Kito. And thank you for emphasizing upon upfront DST, drug sensitivity test, and drugs that are working or drugs to which the person is resistant. And that brings up the very important point of antimicrobial resistance. And is drug resistance stealing away the gains made in the fight against HIV and TB? And we are really happy to see the work which WHO is doing to educate. In fact, it is this year's theme of the World AMR Awareness Week: educate, advocate, and act now. And part of that, an important part of acting is knowing, curbing drug resistance and curbing it early on. So I would now like to invite Dr. Philip Matthew, Technical Officer of the Antimicrobial Division, WHO Headquarters, to please speak on this.
Thank you so much, Shobha, and thank you for inviting us here. I hope I'm audible.
Yeah, very audible, yes.
Thank you. Thank you. And thank you so much for projecting the theme for this year's World AMR Awareness Week. And I hope people will take notice, and then the TB and the HIV communities will also come together to celebrate or commemorate this, because this year is a very important year for antimicrobial resistance, primarily because we have two high-level meetings happening. One is the UN high-level meeting on AMR in September, on September 26th. And then we have the fourth ministerial meeting on antimicrobial resistance, and hosted by Saudi Arabia in Jeddah in November 15th and 16th. So we are hoping that there will be a certain level of political capital generated through these meetings, and it will translate into sustainable funding and policy action downstream. So I'll just share my screen and briefly outline the importance of addressing antimicrobial resistance also while we are discussing tuberculosis and HIV. Let me just share my screen. I hope my screen is visible.
Yes.
Okay, the topic given to me was is drug resistance stealing away the gains made in the fight against HIV and TB. I think the one-word answer is yes. It is stealing away, but I'll just go through some things. Like, these are all often cited figures that most of the people on the call would be aware about. We had a very rapidly increasing rate of prevalence of NNRTI in HIV, and that was something which was evident in all the regions of the world, WHO came out with a global action plan on HIV resistance, which was well aligned with the global action plan on AMR. And subsequently, a lot of, or most of the regions of the world have shifted away from NNRTI-based regimens to DTG-based regimens. If you look at the figure on the left, basic forest plot from meta-analysis done looking at drug-resistant associated mutations, pre-treatment drug resistance associated mutations. You can see that the rates are quite high. In some cases, significantly above the 10% threshold recommended by WHO. So that means drug resistance is a problem in HIV itself. And even for DTG-based regimens, we don't have good quality data on pre-treatment drug resistance. But there is a lot of anecdotal data available in the literature saying that the rates, the failure of viral suppression is quite high, up to 4.8% in some cohorts, and significantly higher in patients who had heavy prior treatment experience. Again, just from the report published by WHO in 2024 on HIV drug resistance, you can see, it was a limited survey done in a few countries. In that, it's clearly evident that viral suppression, failure of viral suppression is actually a reality in many countries, and in some cases significantly low, in the range of 70 to 80%, which is quite concerning. And in all the regions, DTG-based regimen seems to be doing slightly better than the conventional NNRTI-based ART, which is a good thing, but we don't have good quality comprehensive data on this. Again, TB, I think all of us are very familiar with these numbers, so I won't go into the details of it. We know for a fact that the drug-resistant tuberculosis incidence was actually coming down, but again, after COVID, it kind of slightly flattened out, probably because of the increase in incidence of tuberculosis during that time. And again, 3.3% of people, of new patients, and 17% of previously treated patients had drug-resistant tuberculosis. And this is significantly lower than the 2015 figures, which are 4% and 25% respectively. And as my previous speaker was saying, India has the highest burden of drug-resistant tuberculosis. And if you look at it, it kind of coinciding with the socioeconomic and the health system strength, the indicators for health system strength in the countries. Coming on to the question about why should we be concerned about acute infections and bacterial AMR. I think this is again from a systematic review. It's quite evident. People, if you look at HIV, people living with HIV has a higher likelihood of colonization and infection with drug-resistant bacterial infections. If you look at Staphylococcus aureus infection, the pooled prevalence of resistance is actually much higher than HIV negative individuals. Similarly, colonization and infection, this case of strep pneumonia is also quite high. So summarizing this particular table, 2.12 higher odds for colonization and 1.9 higher odds for infection with MRSA, methicillin-resistant Staph aureus. And there are a lot of studies in the literature which show that there is a higher probability of bacterial co-infections in tuberculosis, especially with drug-resistant gram-negative organisms. A lot of risk factors. TB patients tend to go to a hospital much more frequently than somebody from general public. A higher likelihood of healthcare-associated infections, higher likelihood of exposure to other forms of drug-resistant infection or colonization, which can be precipitated by association or interaction with healthcare workers and all of that. So there's a huge body of literature in the available online about superinfection or co-infection in the case of tuberculosis. Again, but then when we consider resistance in chronic infections like HIV and TB and resistance pathways for acute infections, even though the overall drivers and risk factors are very similar, there are some subtle differences also. For example, in the case of chronic infection, a lot of resistance is actually precipitated by undertreatment, people defaulting on treatment, people are diagnosed very late. All of that is treatment. pre-treatment resistance is a totally different ballgame. But in the case of acute infections, it's more, we see that over-treatment is a risk factor in many contexts, even though there are issues in generalizing it, especially considering the low rate of antibiotic use in several parts of sub-Saharan Africa and the higher rate of incidence in there. But overall, the over-treatment drives most of the resistance in case of acute infection, while under-treatment drives that in chronic infection. But at the same time, the strength of the health systems and access to diagnostics and treatment options is a common risk factor. It kind of precipitates or drives resistance for chronic and acute infections. So there are a lot of commonalities, but at the same time, we have to understand there are some subtle differences. So what is the difference between resistance in HIV and TB and broadly what we consider as bacterial AMR? I think the most stark difference is that AMR is a very One Health problem. It is a One Health problem, and it actually needs a One Health approach to actually solve it. Why? Because antibiotics are used and misused and overused in human healthcare, in animal health, in plant health, and a lot of other things which is not the case in HIV and tuberculosis. And if you actually see environment, the role of environment, I think it plays a big role as a disseminator and an amplifier for resistance in the case of bacterial AMR. So resistance has a lot of association with, or a significant association with poor environment management practices and in healthcare facilities, and also in farms. A lot of antibiotics are actually used, not just in animal farms. It can be there in aquaculture farms also, as we see in several parts of South Asia and Southeast Asia. And antibiotics, as I mentioned before, are used quite heavily in the case of agriculture. Antibiotics are used for disease prophylaxis. People don't want, or there's no incentive for farmers to invest in infection control facilities in farms, what we generally call as biosecurity. And so antibiotics or antimicrobials are used as a substitute, as a cheaper substitute. And for growth promotion purposes, because there is evidence that actually antibiotics marginally increase the feed conversion ratio. So you can actually manage with the lesser money for feeds. So all of that is a huge problem. And the complexity of this is something which is quite startling. And this complexity has prevented us from fully moving forward with the global AMR agenda, because there are pushes and pulls from different directions. So what we need is actually a One Health approach, which is essentially an integrated, unifying approach, which considers the health of people, health of animals, and also the health and sustainability of our ecosystems. Again, if you look at bacterial AMR, I'll just introduce the topic of bacterial AMR a bit more. We have, the latest data that we have from 2019 shows that it is associated with 4.95 million deaths, and is actually directly responsible for 1.27 million deaths. But unfortunately, in many cases, people, even the very close relatives of people dying with antimicrobial resistance won't know it, because it's usually labeled as a pneumonia or a urinary infection or a sepsis. But at the same time, in many instances, it will be AMR which is killing the patient than pneumonia or sepsis. So mislabeling, not diagnosing it properly, or not discussing the diagnosis with the patients, a lot of public relations related problems as affecting people's understanding about AMR and the gravity of the situation on the ground. And if you look at the impact of AMR, it's again multifaceted. There are certain health system impacts like higher healthcare expenditure. One study done in India which showed that for an ordinary daily wage laborer, the difference between a susceptible infection and a drug-resistant infection for an admitted patient, it was 445 days of wages. So if a daily wage laborer had had his wife getting admitted to a hospital for a drug-resistant infection. He has to work for 445 days more to actually pay for the extra expenses associated with the drug-resistant infection, which is something depressing, and it's quite a remarkable statistic to kind of drive this notion forward that this is something which is affecting the financial health of people. Of course, longer hospital stays, and the worst part is longer intensive care stays. So saturation of health systems or saturation of intensive care facilities is a real challenge. Poor health outcomes, I think it's very evident from the mortality, morbidity figures. And again, what we saw in COVID, there is a lack of trust. This will reduce the trust in healthcare systems, the trust in medicines, and it will also result in poor quality of care. And this is also a vicious cycle. Poor quality of care leads to AMR, and AMR leads to poor quality of care. Again, the real challenge here, just as in HIV and TB, is that there's inadequate investment in the R&D pipeline. But in the case of antimicrobial resistance, it's much worse. We are effectively running out of antibiotics. In many cases, there are pan-resistant organisms floating around. So, and if you look at the companies actually investing in antimicrobial R&D, it's the smaller or the micro enterprises. The larger companies have mostly exited or in the process of exiting this vertical, primarily because of a market failure, because the perceived value or the actual financial value of investing in R&D has come down significantly, primarily because of stewardship measures in place and inadequate demand. So that's a real challenge. How do we address the market failure? There are a lot of discussions about incentivizing R&D, even government subsidies and grants, and pull and push incentives. I think that's a separate topic altogether. But the fact is there is a market failure. So larger firms are exiting, and antibiotic R&D is actually dominated by smaller firms, and there's a problem there. The problem is that the smaller firms may not have access to clinical trial platforms. The registration process in countries may be totally inaccessible because it's a very, very expensive process. So a lot of inherent disadvantages with the micro and small enterprises, but and the larger companies don't find it very interesting. So that's the reality. So we have drug development concentrated in high-income countries, and so the priorities also become very high-income country focused. For example, more research into gram-positive organisms as compared to gram-negative organisms. So the high-income country priorities kind of is reflected in the R&D process also. So we are at risk of going back to the pre-antibiotic era when even simple infections were fatal. So I'll just give you a very anecdotal thing. We were actually shown a slide of a medical textbook in the 1920s, which says, they're describing pneumonia, and finally they say this condition is generally fatal. Okay. From a lack of options to treat even a simple pneumonia, we've come a long way. Now we have fantastic products to treat anything from pneumonia to sepsis, but then we by and large these so-called fantastic products are actually slowly becoming redundant and ineffective, and we don't have a pipeline to replace them. And again, as tuberculosis, as HIV, as many other infectious conditions, the impact of AMR is disproportionately larger on developing country contexts. This is again a study published a couple of years back from 2019 data, which we can clearly see that the deaths per 100,000 population is significantly higher in sub-Saharan Africa and in South Asia and in Southern Latin America as compared to the high-income regions of the world. Even if we take Europe, for example, you can see that the Eastern European countries have a significantly higher burden, which is also reflecting the health system strength or the GDP or the other socioeconomic indicators. So definitely this is a problem. And primarily this is driven by higher load of infections, lower healthcare capacity, and the quality of healthcare issues. So how do we solve it? That's a real question. When it's a developing country problem, in spite of many of the developing countries not using as much antibiotics as high-income countries, the mortality tends to be much higher. And my last slide is, we can solve it. The quadripartite technical group on economics of AMR, not published yet, but they have come out with a very clear outline of how much does it take to actually solve this issue. So look at it, it's expected to cause a loss of 1.8 years of life expectancy globally by 2035. And the cost is close to 1 trillion per year, 1 trillion per year. Direct cost will be around 412 billion annually, and productivity losses will be around 443 billion annually by 2035. But if you look at it, they did a costing of a global package of interventions to across sectors to actually prevent and mitigate antimicrobial resistance, and it comes to $46 billion per year, which is a huge number when we compare with TB or HIV. I've seen some of these costing-based studies showing that the numbers are much lower, but in the case of antimicrobial resistance, considering the complexity of it and its impact on human health, animal health, and also food security, it comes to around $46 billion per year. And then there is significant value for money for investing. The return on investment is quite good because for every $1 spent, the return will be around 7 to 13. So it shows that there is definite value in actually investing in antimicrobial resistance. But the reality, coming back to the question forward, AMR can take away a lot of successes or the small wins that we had at HIV and tuberculosis, and that's a reality. So unless we actually start investing in AMR and consider this as a broader platform, we cannot have disease-specific narratives and projects anymore, because a lot of drivers are actually common between several disease verticals. So we have to take a more unified, integrated approach, and there has to be cross-sectoral or cross-domain conversations happening just like this. And I thank Shobha and Bobby for organizing this and the entire CNS team. Thank you. Over to you, Shobha.
Thank you very much, Dr. Matthew. And thank you for pointing out that connect, which is so very obvious, that how drug resistance is affecting HIV and TB treatment. And going on to the second and third line drugs, and how multi-drug resistant TB, and we also have extra drug resistant TB. So all this again has such a direct connect with antimicrobial resistance. And it is good you have pointed out that poor quality of care and AMR, that's a two-way traffic. One leads to the other, and one is fueling the other. As well as very often we associate antimicrobial resistance, more commonly antibiotic resistance, due to overuse of it, but it is both overuse and underuse, which means improper use or irrational use of medicines, which you have pointed out so well. And that is why there is so much of emphasis on doing drug sensitivity test upfront when we are diagnosing tuberculosis. And that is where diagnostic stewardship in the context of AMR comes into being. So I think diagnostic stewardship is the first important step, which of course will lead to antimicrobial stewardship, and that is proper use of medicines. So, and good also to point out the financial benefits. $1 spent giving a return of $7. That's huge. In today's world where we are always talking of lack of funds and lack of resources, but what we have, we are not able to use it properly. So thank you very much for that. And now I invite Dr. Kamini Walia, Senior Scientist at Indian Council of Medical Research, who is currently coordinating the antimicrobial resistance and diagnostic initiatives at ICMR. Over to you, ma'am.
Thank you. Good afternoon, good morning, wherever in the world you are. And I congratulate CNS, Bobby, and Dr. Shobha for organizing this very important discussion. And especially, it was while I coordinate mainly the AMR initiative, but while preparing for this presentation, I was trying to go through how the AMR in general for the gram-negative or gram-positive infections and HIV and TB intersect. And I came to know of many new things which I didn't know earlier. And thanks for this opportunity. I would just present my slides, and please let me know if you are able to see my slides in the presentation mode. Are you able to see that?
Yes, we can.
Okay. So, and thanks to Dr. Philip Matthew for giving a very global and highlighting some of the very important issues related to antimicrobial resistance. Antimicrobial resistance is actually compromise the advances that we made in the control of infectious diseases and continues to threaten so in the years to come. It causes significant global public health burden, which is both in terms of morbidity, mortality, as well as the economic burden, which Dr. Philip very eloquently described in his talk, so I will not repeat it. But one of the studies which actually came out 2 years back, which gave us the estimates from 2019, were very alarming, which was like 4.95 million deaths were associated with AMR in 2019, and out of which 1.27 million were directly attributable to AMR. And this was way above, the HIV or TB deaths individually. In India, what we see is that there is almost 30 to 50% mortality in patients with drug-resistant infections, and these are mostly hospital-acquired infections. So every single cesarean section or a joint replacement surgery, which are otherwise considered to be a clean surgery, now threatens to become unmanageable because the infections that you acquire in hospitals are also multi-drug resistant. So in Indian studies, what we have found is that there is a 40% more incremental cost to treating drug-resistant infection in government hospital in India as compared to infection by same drug-sensitive pathogens. So we are seeing a huge load of hospital-acquired infections, which are mostly caused by drug-resistant pathogens. As you would have noticed from Dr. Philip's talk, AMR is a multi-dimensional problem. It is the clinical side of AMR is only the face of the AMR, but there is a social inequity, poverty, economic, regulatory, and many policy issues which are underlying and which actually make it a multi-dimensional problem, and that's the reason why it is so unmanageable. Antimicrobial pressure is the only driving force for AMR. But can we really do away with the antimicrobial pressure? I don't think so, because in country like India and many other LMICs, the investments in healthcare system have been suboptimal. That has led to poor diagnostic stewardship, as Dr. Shobha was pointing out. There is a poor infection control, sanitation and hygiene practices, and to compensate for it, we are prescribing a lot of broad spectrum antimicrobials, and we also have the dearth of skilled human resources. Then there is unregulated sale of antibiotics, which is available over the counter. Also, the rising incomes, although it is considered good that the incomes are increasing globally, but that is also contributing to increasing antimicrobial use because of the increased buying capacity. And the most important is here the poor perception of the threat. One wrong dose of antibiotic that we use today, how it impacts the overall dimension of antimicrobial resistance in future, we don't understand it well, and neither have we done a good job of communicating it to clinicians or our community. So this is somewhere we can equate it to the crisis of the climate change. It is not really easy to fathom what kind of impact it will have. One carbon footprint that we have today will have over on the climate change in future. Similarly, one wrong dose of antibiotic, how it impacts AMR, it is not easily comprehensible. These were some of the trends in the past, which documented that how drug resistance is actually impacting all the infectious diseases which are important for a country like India, whether it is TB, whether it is malaria, whether it is gonorrhea. The prevalence of MRSA is almost 20 to 40%. We see a lot of expanded spectrum beta lactamases in Enterobacteriaceae. We see a lot of metallo-beta lactamases now. It is almost 80% in the ICUs from data that has been published from India. Also, as I mentioned previously, we see a lot of drug-resistant infections with Acinetobacter baumannii or Pseudomonas, and all these actually point to compromised infection control processes and poor diagnostics availability in our hospitals. Coming to the tuberculosis in India, we all know India has the largest number of TB cases. In fact, it is one of the countries among the 6 or 7 countries which have the largest number of TB cases, and our case fatality ratio is about 12%. We have 2.8 million TB cases. The number of deaths in India from TB was 342,000 among the HIV negative and also 11,000 among HIV positive patients based on the data which has been reported. 4% of these patients are actually rifampicin resistance, and 3.4% of new TB patients and 80% of the previously treated TB patients have the MDR TB. So 18% of 2.8 million is a huge, huge number. MDR TB treatment is difficult because it requires prolonged treatment, mostly with injectable second-line drugs, more adverse effects. Sometimes it is suboptimal treatment outcomes and also has a higher risk of mortality as compared to the patients with drug-sensitive TB. So it is a huge burden on the individual patient as well as on the healthcare system, because government is providing most of the TB treatment to the patients through different mechanisms of using government hospitals, public-private partnerships. So there has been a lot of focus, and if a TB patient fails treatment, it is a lot of burden on the healthcare system. Then there is patients are also lost to follow-up, and there are treatment failures in drug-resistant TB patients. And all this also compounds into more disease transmission cycle in the community. For a long time, we thought that the drug-resistant TB is not as transmissible as the drug-sensitive TB. But now the recent research shows that the drug-resistant TB is also very highly transmissible. And that's why we see so many hotspots in India. For example, Mumbai is a hotspot of MDR TB. Even the patients who are first reporting to the healthcare system are actually being diagnosed as having drug-resistant TB. So drug-resistant TB has existed in India almost at the same time when the anti-TB drugs were introduced, and ICMR has conducted many surveys to document in the last 40 years. Resistance to rifampicin, streptomycin, and other anti-TB drugs have been detected for decades. And MDR TB was also seen in earlier surveys, although different levels depending upon where, place, and time you are testing it. So the increasing burden of drug-resistant TB actually introduces new challenges for the TB control program. Dr. Philip already shared this, so I will not spend time on this slide. I will spend some time on this table, which actually gives a strategic plan and how the TB program in India has unfolded in last few years. And as you can see, there has been a lot of focus on bringing the new diagnostics in, bringing in the new therapeutics in a timely manner. So the government of India was aware, has always been aware of the fact that drug-resistant TB will be difficult to treat, and we have to bring in the requisite diagnostics and therapeutics in time. So RNTCP2 was launched in 2007, which also had programmatic management for drug-resistant tuberculosis to improve the DRTB care in India. This was followed by introducing a new molecular-based test. There was a line probe assay which was introduced. Then there was a cartridge-based test which was introduced. Then there were specific guidelines for management of drug-resistant TB, which was released by government in 2010. CBNAT introduced in India in 2011. Then TB was made TB was made a notifiable disease, and for this there's an online platform called NICSHE which was introduced, and complete coverage for MDR TB was achieved in 2013. First national drug resistance survey was conducted by government in 2014, and then we launched MDR regimens with bedaquiline, which were piloted in some states. Following this, there was revision in the National Strategic Plan and decentralization of drug-resistant TB services by implementation of PMDT to improve quality of TB services in private sector, and efforts were made to boost public-private partnership. So then in 2018, WHO consolidated the guideline for DRTB, and we implemented TrueNAT, which is a rapid molecular assay for detection of TB as well as the drug resistance. And new guidelines for PMDT were again released based on WHO recommendation in 2019. So ICMR is now doing the drug resistance survey, and the recommendation is that there is the universal drug testing is replacing the conventional DST, which was practiced earlier. So as per the latest report, which is from 2022, 76% of bacteriologically confirmed TB cases were tested for rifampicin resistance, and 80% was in the previously treated cases. Laboratory confirmed cases, the absolute number for MDR and RRTB was around 52,000, with patients started on treatment 48,000. Lab confirmed cases, pre-XDR-TB 12,000, patients started on treatment 11,000, and MDR RRTB cases tested for resistance to any fluoroquine around 23,000. So these numbers, although are small, but then they are there is a good amount of focus on detection of drug-resistant TB all across the country. I also found that TB patients being immunosuppressed, they are also, they succumb to the fungal infections, because TB is a long-term treatment with the TB drugs. And what we found was that there is a, in India, we see a lot of Candida species in, this is reported in by one of the studies which was conducted in one of the hospitals in India. We see that a lot of drug-resistant, a lot of TB patients also have co-infections with fungal infections. Candida species, Candida albicans, and glabrata around 10%. So, but then we need more studies on this, because this is only data from one hospital. Similarly, in Iran, they have reported loss of Aspergillus, histoplasma, and cryptococcus infections in lungs of the patients affected by pulmonary tuberculosis. Since we are now also seeing increase in the use of antifungals, the resistance to drugs like fluconazole, voriconazole is also increasing, as has been reported by the ICMR India network as well. So if we are going to have a lot of patients on TB treatment, they are more likely to be infected by fungal infections as well. So this is something that we need to watch out for if we really want to achieve the elimination gains. And other countries who have a larger pool of TB patients should also be looking for these co-infections. Coming to HIV, which I think Dr. Philip has very explained in a lot of detail. In India, we don't see a lot of HIV drug resistance, and so far ARB has been quite effective. But whenever there is a drug resistance, it can reduce effectiveness of ARB and lead to high morbidity and mortality. WHO also recommends oral PrEP as a prevention option. WHO recommends HIV drug resistance monitoring and surveillance as part of ART and pre-exposure prophylaxis. The problem is that there is a overlapping regimen for both PrEP and ART. So the more you are going to use PrEP, there is a chance for emergence of drug resistance, HIV drug resistance. And the primary drug resistance, which was detected in India in one of the hospitals, is around 16% in the naive HRGs. And this qualifies India to be between low and moderate level of drug resistance as per the WHO scale. So monitoring resistance outside clinical trials is crucial for effectiveness of PrEP programs and to support the national, regional, and the global guidance for treatment of HIV among people acquiring HIV while being on PrEP. The other very important study, which Dr. Philip also mentioned, was people living with HIV are also at increased risk of infections with resistant organisms. And this includes MRSA, this includes Streptococcus pneumoniae, and this includes E. coli and Klebsiella pneumoniae. Since this has already been discussed, I will not spend more time on it, but patient being on HIV, acquiring drug-resistant E. coli is the worst situation that you can imagine for the patient, and the risk of mortality goes very high in this kind of a situation. So to summarize, I think we really need to sustain this momentum as a country, which we have created on TB and HIV. Added to that is the complexity and the intersection with the AMR, which includes your fungal infections, which is very important for this population, both TB and the HIV patients, the gram-negative pathogens, which are just in abundance in our country. So national programs should continue to monitor TB and HIV drug resistance population. The level of drug-resistant TB otherwise may hamper our progress towards TB elimination. We really need to watch out for fungal infection in both HIV and TB patients. And the focus for our country should be to reduce the broad spectrum use, because many of the drugs like ofloxacin is very important for TB treatment. Then linezolid is very important for TB treatment, but both the drugs are misused so much in general practice that if we run out of these drugs, these could have a very major impact, especially linezolid, which is used for MDR TB treatment, can have major impact on MDR treatment if the linezolid overuse is allowed to continue. So the need of our is to understand ARV drug resistance development as well for us to effectively combat in future, because resistance among IDUs is a new challenge that needs to be first understood and then addressed. So with this, I come to end of my talk. And once again, I thank the organizers for giving me this opportunity. And this dialogue is actually very, very important to continue to continue to prioritize the efforts done so far in both HIV and TB, as well as escalate the issue of AMR at the highest level in UNHLM. Thank you.
Thank you very much, Dr. Walia. Indeed, it is we who need to thank you for a very, very lucid and informative presentation. And yes, thanks for pointing out that there is very poor perception of the AMR threat. Not only in the common public, but also in the medical fraternity to a large extent. So more awareness needed everywhere. And in fact, you were talking of drug-resistant tuberculosis. And recently I spoke to an XDR TB survivor, extensively drug-resistant TB, who had directly acquired it. Very often very often we blame it on the patient, that patient is not completing the treatment or is not very regular with the treatment. But you have rightly said, these cases are there where she had no history of tuberculosis ever, and she was diagnosed with extensively drug-resistant tuberculosis. So we need to be wary. And also about hospital-acquired infections, we ask the public, of course, IPC is again, as you have said, in terms of hospital-acquired infection. And then we give antibiotics to cover up for those infections. So these are some of the points. All of us have to look into it and join this fight, because as AMR increases, so will the gains in HIV and TB be lost, and they will become less. Thank you very much. I now invite Dr. Ishwar Gilada to chair the next session on the chasm between TB and HIV continues and why. Dr. Gilada is the longest serving HIV medical expert in India who has established India's first AIDS clinic in 1986 when the first HIV case had got diagnosed in the country. He is governing council member of the International AIDS Society and is on the organizing committee of the 25th International AIDS Conference. He is also President Emeritus, AIDS Society of India. Over to you, sir.
Thank you very much, Shobhaji. It's my proud privilege to introduce a stalwart in the field of HIV/AIDS, Dr. Iman Murphy. I have known him for a couple of years. He is a current regional director at the UNAIDS and sitting in Bangkok. He has been on several positions in government of Australia, including AusAIDS and Director of Health Services there. And he has been such a pillar of support that whenever we call him for any talk, any session, any organizing committee, he's always willing and always ready. Over to you, Iman. He's going to speak on the TB and HIV collaborative efforts and what are the gaps and how do we overcome those gaps.
Thanks very much, Dr. Gilada and colleagues. The chasm between TB and HIV is interested in Dr. Walia's presentation and some of the other discussions we've been having across the region. My background is public health. I started out as Director of Communicable Diseases in Australia. We didn't have the separate programs, albeit the HIV and TB were under the one department. We had teams, but we always looked at the intersection of the diseases. Over time, and it's partly, I think, because of resources or lack of resources in some cases, we've seen a separating of programs in many places, and then they become siloed. And even from a patient point of view, these silos become greater and harder to navigate between. And this is why we need to be looking at the chasm between TB and HIV. We are going into a period of tightened resources domestically, internationally, and we really need to be significantly changing our approaches. So let me move into the slide. It's a great pleasure to be with you all today, and I really appreciate the invitation to talk about this important issue. And I'm coming at it from the public health, as I said, not just from HIV. What both programs, HIV and TB, often have to learn from each other and make adjustments each. So why do we talk about TB and HIV? There are obvious reasons that we all know about, but this includes that 1/3 of AIDS-related deaths are due to tuberculosis. TB remains the leading cause of death among people living with HIV across the world. And those living with HIV are 16 times more likely to fall ill with TB. But the underlying truth is that these colliding epidemics point us toward the people who continue to be left behind. The key populations, the vulnerable populations for both diseases are frequently the same groups, with many of the same risk factors and the same lack of access to all prevention, testing, and care services that they should be able to access. We know from 4 decades of responding to HIV that vulnerability springs from an intersection of dynamics. There are social causes like stigma, exclusion, discriminatory policies, and even violence. There are individual issues, including income levels, poverty, malnutrition, health status, including mental health. And there are certainly health system factors, including lack of access to, and the issues of healthcare workers who are uninformed, unfriendly, or both. When we speak about TB risk factors, such as living in crowded areas, income levels, poverty, homelessness, and including alcohol and intravenous drug use, we should see the clear overlap with the HIV response. The commonalities of issues are the same. This includes the vulnerability of people who use drugs, and people in prisons and closed settings are particularly strong risk for TB. We've seen in many places, as a result of other programs, an overcrowding in these settings, and COVID was shown to be highly transmissible during the its peak in a number of the countries in these closed settings, as is TB. I was in the Philippines and we saw rooms that had more than 10 times the number of people who should have been in them. So you can imagine how close they are in proximity and at risk. But we're also speaking about the wide range of people with inadequate access to health services due to the confluence of social, economic, and policy factors that are beyond their control, and in some places have been exacerbated in a post-COVID world. We dare to imagine a world where we find all TB, treat all TB, and prevent all TB among people living with HIV, as we would like to see an eradication of TB as a public health threat globally as well. And also, we dare to dream of a time when AIDS itself is no longer a public health threat. These are not empty promises. In fact, we have made significant strides. We have seen a 70% decline, a drop in TB-related deaths among people living with HIV between 2010 and 2022. Globally, we set the goal of achieving an 80% decline in TB-related deaths among PLHIV by 2025. That target is well within reach. I should note here, though, that progress has somewhat plateaued, particularly since COVID service interruptions, and only 46% of the estimated 703,000 people living with HIV who developed TB in 2021 were able to access antiretroviral HIV therapy. This is far below the 90% target. So we have some significant challenges that we need to address in this as well. Worldwide, since the turn of the century, more than 13 million TB deaths were averted among people living with HIV. In fact, this graph shows that the steepest declines in TB-related deaths have been among people living with HIV. The red line represents AIDS-related deaths. The green line shows TB-related deaths among people who are HIV negative, while the orange line shows TB-related deaths among people living with HIV. You can see how the orange line closely follows the trend of the red line, particularly from around 2011. This visualizes the value of tackling both diseases in a coordinated manner, breaking down this chasm and bringing the programs together. It shows that when we get HIV services right, there is payoff for the TB response. And when we get TB services right, there is payoff for the response to HIV. How have these gains been achieved? And more importantly, how can they be accelerated as we move forward? I propose that in many respects, the priorities for responding to both diseases are not just closely linked, but identical. We need to focus on integration, modernized services, and addressing structural barriers. It's useful to put the issue in the perspective with reference to Asia and the Pacific, which accounts for 2/3 of the world's TB burden. 6 of the countries with the highest number of TB cases globally are in our region: Bangladesh, China, India, Indonesia, Pakistan, and the Philippines. In 2022, Asia Pacific accounted for 70% of the estimated new TB cases globally, 2/3 of TB-related deaths, and 1/5 of TB-HIV co-infections. While overall TB cases in the regions have not declined much between 2015 and 2022, among people living with HIV, there has been a 40% reduction. As you can see on the graph, the next slide, please. As you can see on the graph to the left, 78% of people living with HIV in Asia Pacific knew their status in 2022. And 65% of all PLHIV received treatment. HIV and testing results, however, were far worse for people living with HIV who have TB co-infection. As the graph on the right in the red shows us, 58% of people with both TB and HIV knew their status in 2022, and 45%, or less than half, were on antiretroviral therapy, a 20% difference in both cases. So what are the gaps? Here is a glaring one. 1/4 of the people diagnosed with TB in Asia Pacific in 2022 do not know their HIV status. Almost all high TB burden countries must close a significant HIV testing service gap for people diagnosed with TB. It should be standardized. India, though, is a notable exception to this, and we heard some of that from Dr. Walia. When we look at treatment, again, there are huge variations between countries. We see that in 4 of the high TB burden countries, in Pakistan, in China, Indonesia, and the Philippines, less than half of TB patients living with HIV receive HIV treatment. Serious service provision issues exist. In some contexts, this speaks to the overall. Sorry, I have a pop-up here. In some contexts, this speaks to the overall inadequacy of the HIV treatment coverage. Those same countries have poor HIV coverage in itself. Again, the importance of tackling both diseases if we want to have outcomes for each. In other countries, TB patients have dramatically reduced access to existing services. In this next slide, you'll see that in Asia Pacific, there are many missed opportunities for HIV and TB service integration. It's the way of the future. It should be the way now, but we are still talking about bringing these together in a future sense. 1/3 of HIV treatment service providers do not treat TB. 3/4 of TB service providers do not treat HIV. And just 1/4 of countries in the region include TB preventative treatment in their national HIV policies and guidelines. It should be a standard in all. We often will see someone go into a TB or an HIV clinic, get tested, get results, but then cannot in the same day go to the opposite clinic because we've usually got 2 silos going on in facilities and they may not be near each other. And if someone is paying to come once and having to pay again, often this is unaffordable, and this causes a loss to the connection into the services because they're expected to make those linkages themselves. That's not the way to go. This leads to my focus on integration. We need a synchronized response to TB and HIV for the delivery of comprehensive quality services. Simply put, all people living with HIV should be screened for TB at diagnosis and regularly thereafter. And all people with TB should also access HIV testing. If positive, they should begin antiretroviral therapy as soon after starting TB as possible. Many of the service gaps we saw earlier are due to the segregated models of care. How to address this? By putting an end to the 1 patient, 2 clinics approach that I referred to. We need renewed commitment to joint programming. That's a fully integrated model where it's a full package of services in the one place for the client. Where TB and HIV services are provided in the single facility and by the same service provider, or at least teams under the one roof, to make sure that we can have people move between the programs without loss to follow-up. Even at this stage of the game, this represents a radical shift from the linkage and collaboration models we see in much of the region, sadly. In these systems, patients are referred to other facilities or clinics, and there are sometimes not effective synchronization between them, and certainly not referrals from one service to the other so that the service provider is knowing the patient is coming and can try and connect. The loss to the follow-up is a major part of that gap when we look at testing and treatment levels. And this is something the systems can easily and should address. Now more than ever, we need this shift towards full integration. The funding landscape demands it. COVID-19 has revealed and widened health financing gaps. For us in Asia Pacific as a whole, foreign direct investments in the health sector fell by more than 1/3 since 2021 and will fall further and faster in the next couple of years. And they're already at very low levels for both TB and HIV. In a challenging macro-fiscal environment with reduced government revenues and higher debt levels, it is critical that countries prioritize the efficiency in health allocations. Again, This is why we need the integration, the full integration of the programs. We are wasting and duplicating a lot of costs in the system. They have already made the commitment to do so, of course, through the political declarations on TB, on that, to end AIDS. UN member states pledged to ensure that 90% of people living with HIV and people at risk be linked to people-centered and context-specific integrated care, such as for TB. This commitment is also key to our progress towards the goals of universal health coverage and the wider 2030 Sustainable Development Agenda. We cannot achieve these or any other SDG targets if we continue with the old-fashioned standalone programs and approaches. Next, I want to talk about the imperative to modernize our service delivery. We have a toolkit of best practices for both HIV and TB that are not being put to optimal use. Simply put, we need to reach more people with the available diagnostic, prevention, and treatment technologies we have today, which are far in advance of what we had 5, 10, or 20 years ago. For example, and I heard Dr. Walia refer to this, we have the mandate to scale up pre-exposure prophylaxis, or PrEP, to prevent HIV infections. It's an evidence-based strategy, and where it has been implemented at scale, it has significantly reduced new infections. Engaging people in the health system, we can make sure that they also engage in other parts of the systems when there is a need or an identified risk. Yet, we have just 150,000 people using PrEP in all of Asia and the Pacific. And in several countries, PrEP rollout hasn't even got national traction yet. This is significantly making us fall behind in terms of our HIV results. And we're going to see this year with the new global data, Asia Pacific's response has plateaued and fallen behind even more. By the same token, we need to scale up access to TB preventative treatment among people living with HIV. As this slide shows, there is uneven and low access to TB preventative therapy among people living with HIV across the region. We have some countries which have not yet implemented the recommended treat all policy for people diagnosed with HIV. And we have healthcare systems that are still offering antiquated TB treatment models. The World Health Organization recommends a package of screening, prophylaxis, rapid treatment initiation, and adherence support for everyone living with HIV who presents with advanced disease. The package includes interventions for preventing, diagnosing, and treating common opportunistic infections, including TB. But we're seeing an increase in the numbers of people coming in with very low CD4 count and advanced disease in the region. It says there are issues within the environment that are holding back people from accessing testing and treatment services early enough. We know so much more about what should be done, but our implementation is too sluggish to reap the individual and the public health benefits that are available to us today at much less cost than they were in the past. A collaborative effort is required between governments, the development partners, international donors, whilst they're still with us, to bring HIV and TB responses jointly into the 21st century so we can reap the benefits of the best practices now at our disposal. We've often, with the Global Fund for TB, HIV, and malaria, seen joint programs develop, joint proposals develop. But as soon as they're funded, the proposals slip back into separated, siloed implementation. This should not be happening today. We need to bring these programs together and maximize the resources that are available. They will reduce in the next couple of years. That is a given. And we cannot afford to see increasing numbers of TB or HIV-related infections and deaths in our region. Finally, I want to discuss the need to address these structural barriers. These are the barriers that hold back TB, hold back HIV programs across the region. It's not just a health agenda, of course. It's a human rights and social justice agenda as well. TB and HIV control are best achieved when biomedical interventions are joined by structural interventions. We need to make linkages with strategies that address the root causes instead of continuing to band-aid and address the symptoms from our silos in small fraction. We cannot end AIDS or TB among key populations unless we effectively address the factors that increase their vulnerability and block their ability to access services. This is why, in part, it still requires a multi-sectoral approach. It's not just a health response that's needed, and certainly not just a biomedical response. Repealing the laws that criminalize or otherwise discriminate against key populations is an urgent human rights and public health imperative for both TB and HIV. We also need joint action to address stigma and discrimination in our healthcare settings and beyond for all people living with HIV and TB. Some of the best programs I've seen addressing this facility-based stigma and discrimination start with those who are working at the gates to the compound or the clinics and work all the way through everybody involved in the settings. And this is critical because if you're arriving and you're shy and you're nervous and someone gives you negativity right at the beginning at a reception or even at security, then you're afraid to be identified, and it reinforces the negative impacts on people's health and the community well-being we're looking for. Those who perceive high levels of stigma and discrimination are more likely to delay their care or just stay away from services and support entirely. And as we just heard in Dr. Walia's presentation, this includes those with MDR-TB or extremely drug-resistant TB, because this can be directly infected. So if people are afraid of accessing the services or the reactions they'll get in those services, this is going to increase the level of this infection in our societies. In order to shape more accessible and acceptable health services, we have to involve the people who use them in their planning and implementation, how to make them more friendly for the people who need to use them. This is why communities at risk must be at this center of everything we do, from planning to implementation to evaluation and monitoring. Through community-led social protection monitoring and service delivery, we can better tackle all these challenges. This requires supporting a robust civil society response for both TB and HIV and ensuring it is at the core of all service offerings. Indeed, it should be across the board for all public health and health services. In closing, these commitments to integration, to modernize service delivery and removing structural barriers must be championed by diverse communities. We need a coming together of not just HIV and TB stakeholders, but all those working on different issues affecting young people, people who use drugs, people in prisons, women, children, homeless, or those affected by poverty, migrants, and beyond. Common issues to each. The intersectionality of all means that we have to start bringing a greater and more diverse mix of people together to call for change and better program and service provision. The more we work together, the louder our voice, the greater our impact, and the more unified our message. And that message is fundamentally that our policy, programmatic, and spending choices should leave no one behind. So I'd like to thank Dr. Gilada and colleagues for inviting me to share some thoughts. And I know you've got a lot of different speakers looking at this from different aspects. And we need to bring all these different aspects together in our thinking of how best to localize the programs and the implementation, be that at state level or at national level, and particularly at the community level, to make sure that people gain the benefits and we as a community also gain the benefits and reduce TB and HIV infection, morbidity and mortality. Thank you, sir.
Thank you very much, Iman. You made a full justice to the talk. What you have emphasized is really true, but some of us cannot speak. Some of you can speak very well. What you emphasized was inadequacy of the healthcare services, and that includes everything from diagnosis, treatment, and tools for investigations. The unequal program in TB and HIV in integration process. Then you also spoke about HIV treatment in accessing, which is much lower for those which are HIV and TB. So I think where we should have more emphasis, that is lagging. You have beautifully suggested how segregation can lead to integration. And there are a lot of missed opportunities for TB prevention. And we face day in and day out here. If we would have provided rifampicin INH prophylaxis 5 years before, we could have prevented so many infections. Enabling environment is also very important, and you showed through a very good slide. Integration with modernized service delivery, I think this is the best thing to happen, and we should all slog for it. Thank you very much, Mohammed. Over to you, Shobhaji.
There are some questions I think we can take up and ask for some questions. There is a question from Dr. Maya Joshi that in the morning we heard that using ultra-portable X-rays or other tools that are WHO approved to screen people for TB may also help us find TB and early accurately. How can we find TB amongst people living with HIV when it is asymptomatic or subclinical? And also how to find extrapulmonary TB early among people living with HIV. Would Amon want to answer, reply to that?
Imam, are you there? Yeah.
Yes, I'm here. Sorry. I didn't realize there was a Q&A as well. I think when we're talking about a technical program, there may be better people to talk about how to bring the diagnostics. I work on the program level when we look at public health programs and how we connect these. We need to have, again, the one-stop shop. We need to have where people come in and have the X-ray and then are referred same day, same visit to other services, other testings, diagnostics that they need, not referred either at a later date or to another clinic in another location. So the specifics around the diagnostic tools, I'd encourage one of the experts that you will definitely have in India, and certainly WHO could help with that as well. I saw Dr. Awari on the list, so if he's there, he may be able to talk to the specifics of that.
I would like to just add one thing.
Yes.
We must also do ultrasonography at least once in a year in people with HIV, because on that we diagnose a lot of tuberculosis cases. And secondly, if you find that sedimentation rate is high, you keep the person on radar, because sometimes we call them after 6 months. By that time, something has already developed. So in such cases where you are not able to find anything at that particular time, like in X-ray there is nothing, sonography there is nothing, but ESR is high, the person come back after 3 months and their tuberculosis is already developed.
Your parting remarks, Dr. Gilada, we would love to hear them.
Okay. No, I think I find the number of people and the class of people attending this session, and since morning, we rarely see 6 o'clock morning till 7 o'clock, or 7:30 in the evening. We are running half an hour late, maybe 8 o'clock in the evening. And we are discussing your basic idea of two things, 100, 100, 100, whether we'll achieve or not, but at least we are making an effort. And second thing is missed opportunities. So at every level, at individual level, at society level, at national level, at government level, we miss opportunities. And I think here is a learning lesson for all of us from each other. Government should not feel offended because some inadequacies are pointed out to them, because ultimately they are also there for people, public good. And integration of TB and HIV is very important. We have been talking about long time. It is not happening. So either TB people who are working in TB program, they are not well acquainted with HIV, and HIV people are not acquainted with TB. And we have several sets of people working in different fields, but they have lacked some of the things. So I think up-to-date knowledge, having such kind of sessions, having national conferences, regional conferences is very important. And at one point of time, we must have a comprehensive service where patient is a patient, a person is a person. It is not that we are doctors of spare parts, so that the person has to go for one spare part to one person, another to another. There has to be a comprehensive service delivery system, and that we must develop whether in government and private. And most of the ERT centers are in large public hospitals. They are in medical college hospitals. There you must have such kind of services where people can find out where ultrasonography can be done, where liver function test can be done, which are hardly done in ART centers. Thank you.
Thank you very much. And with this, we come to the close of this session. And thank you, Dr. Gilada, and thank you, Emon, for being there and enriching it with very, very valuable insights and things to ponder upon. Many things which we know, but we need to reinforce and re-insist on them that they actually are followed at the ground level, particularly the social inequity part, because it is just not the medical treatment or the medical diagnostics which will help us get rid of AIDS and TB, but also other related social inequity situations. Thank you very much. We move on to the next session now.
Hello, sorry for some interruption. We're looking for Dr. David. Is Dr. David there online? Dr. David Pagwesese Parirenyatwa is the president of Society for AIDS in Africa, which is the official secretariat of Africa's largest AIDS conference, ICASA. And he's also the former Minister of Health, but I don't see him online. If any of his colleagues is here, please do let us know in chat. So maybe we can open with Timur Abdullah. Timur, you are there, right?
I am
Yes,
here.
hi,
Yes.
welcome, Timur. Yeah. So who is better than you to open this session, especially focusing on reality check of 100 for TB and HIV in Africa's context. Timur and I stand by one of our friends from TB People Botswana, who sadly lost his father. So we express a solidarity, and so that is why Norman will not be able to join us in this moment of grief. Timur has played a very important role in bringing people together in several countries or high burden countries, especially to push the envelope when it comes to the TB response. There's a lot good things happening, but there is definitely a gap, and we need to push further more beyond the boundaries of our organizations and governments and so much of let's call them barriers, but we really need to push to push the risk so that the TB response is people-centered, rights-based, gender transformative, and we are really able to get not back on track, because we were never on track to end TB. So let us get on track to at least end TB in a lifetime as soon as possible, because it's a human rights imperative. So Timur Abdullah leads the TB People Global. Timur, over to you. We also need to know what inspired you to bring all of us together, and also bring different people together in different high burden countries, which is really so inspiring. They are doing really amazing work, and we see so many TB People chapters across the continent of Africa, but also in Asia, in India, in Nepal, in Cambodia, and so many places, doing excellent work, pushing the envelope as sincerely as possible. Over to you, Tim.
Thank you. Thank you very much. Good morning, everyone. Good morning, good afternoon, depending on where you are. I would say my role was a bit exaggerated. I am not the one doing this. It's really, I'm just a soldier in the big army of advocates. What brought me there is, well, TB made a mistake by attacking me, and also I'm a person living with HIV, so I'm a perfect how to say case study for this event, because I have been living with HIV for 18 years now, and I had TB twice. So first I became an HIV activist, and then I realized when I got TB, I realized that actually things are not so bright in TB. They're even worse than what I thought was very far from perfect system for HIV. So that's basically that's personal. Let's put it this way. That's very personal. And I just think that we all should make it personal if we really want to end TB and if we want to end AIDS by 2030, which I think is possible. And let me actually say that we indeed are not on track, and we have never been on track to meet the targets for ending the two epidemics. However, let me give you a metaphor. 100, 100, 100 is like achieving the speed of light in physics or in rocket science. It is possible theoretically, but our current technologies won't allow that to happen. So speed of light is unachievable. The only stuff that can achieve it is actually the photons and other particles that have no weight. We as humans, we cannot achieve speed of light yet. And that yet is a key point. It's our technology which makes the whole difference. It's really the limitation that we have. Achieving 100, 100, 100 is actually possible. If it's possible in theory, it means that there is something that prevents us from making it a reality. And therefore, the question is, what needs to happen for us to achieve it? And actually, Bobby just mentioned several of the ingredients that I had also in mind for achieving that vision of 100, 100, 100. And also it was mentioned by Dr. Murphy before in the previous session when he was speaking about one-stop shop. Why is it important? If we really want to make sure that everybody has access to services and everybody is getting access to services, we have to make sure that these services are available, but are not just available, but are also accessible, affordable, they are of adequate quality, and they're also acceptable. Those are like AAAQ, the AAAQ paradigm that is being spearheaded by health community, not just for TB, but in general, because those are the things like if we really want to make sure that people are using the services, people are getting diagnosed, people are getting treated, and they complete the treatment successfully for TB, or they remain on treatment for HIV, then we have to make sure that these services are available, accessible, acceptable, affordable, and are quality. They are provided in a people-centered manner. They are provided in a gender-sensitive, at least, but ideally in a gender-transformative manner, because we know that without tackling some of the gender prejudices, gender stereotypes, gender norms, we will not be able to really make sure that there is equity in accessing services. And that also these services and the response in general is human rights based. So I actually think that this is exactly what it takes for us. Like once we are able to make sure that everybody has access to this kind of services, that's going to be it. The only problem is that, and it's the same with the speed of light, the closer you get to the speed of light, the harder it is. We don't even need to speak about the speed of light. It's like regular cars. the manufacturers, the car manufacturers, they're struggling. Every single extra kilometer per hour on top of what has been achieved so far is a struggle, and it's becoming increasingly difficult. It's uncomparable. At the beginning, it's very easy, but then every additional kilometer per hour becomes a struggle. So this is what happens, and this is unfortunately is not factored in our health systems. When we speak about 90-90-90, you see 90-90-90 is much easier to achieve than 95-95-95, not just because it's less, but it's because also those extra 5%, they're going to cost much more than the 5% before them. Every single one extra percent that we are trying to achieve in the triple 90 or 95 or 100, it makes it more expensive. And this is actually a problem. We recently had a regional meeting, a very big regional meeting here in Tashkent in Uzbekistan, organized by the Stop TB Partnership, by WHO Europe, and by the National TB Program of Uzbekistan. And this was discussed. In many countries, NTPs are struggling because as the number of people with TB is declining, as the TB incidence is declining, the funding is proportionately decreasing. And this is wrong, because let's say we have 1,000 people, which is like for India, it's nothing, or like for South Africa, it's nothing. But let's hypothetically say that a country has 1,000 people with TB that have to be diagnosed, found, diagnosed, and treated. Out of those 1,000, let's say the program reaches 800, 80% rate. Not bad, not too bad. So 80%. Once they reach those 80%, and there is 20%, the Ministry of Finance, or whichever ministry it is that is dealing with funding for the health systems, they say, okay, so now you have, out of 100, now you have only 20%. So you get 20% of funding. And that is the stupidest thing that they can come up with. It means they have no clue how it works. It means that they will suffocate NTP, and they will make it impossible to even reach a fraction of those 20%. Because fewer people doesn't mean proportionately less money to provide the services. It's actually increasingly expensive. Every one more person, like the smaller the number, it's actually becoming much, much more expensive per person to provide those services, especially if we are really serious about providing those services in a manner which is human rights based, gender transformative, and and the services are, as I said, available, affordable, accessible, and acceptable, as well as quality. So this is a huge challenge that a lot of countries will be facing. It is happening in my region, where the incidence is declining. But this will be the case also with Africa. This will be the case with Asia, where as the numbers go down, ministries of finance will be tempted to proportionately reduce the funding. That is going to be a big, big, big problem. With all the new tools, with all the approaches that we have, this is going to basically be the key stumbling block that will prevent us from actually achieving 100, 100, 100. And this is why I started by saying, speed of light. The last percent, once we reach 99% of the speed of light, that last percent will actually require more energy than 99% before that. And this is exactly going to be the case with HIV, TB, with ending AIDS and TB. Last percent will cost more than 99%. It will take more effort than the 99% before that. This is inevitable. And we have to prepare ourselves for that. As we're approaching the 2030 deadline, and I'm pretty positive, by the way, we will end TB and AIDS. So if you don't think we will, well, let me assure you, we will, because I have other plans to do for past 2030. So it's just, we have to be prepared for the challenges ahead of us. And I can only tell you that once we realize that it will actually take more resources to reach the remaining 5% or 10% of all people with TB and all people with HIV, that's going to become incredibly difficult and incredibly expensive. So we shouldn't deceive our donors by saying that, you know, we've done such a good job. We're already, like, you know, we're discussing 95, 95, and we're now discussing 100, 100, which I love. We were discussing 100, 100, 100. So donors may think like, so, you know, you made it to 90, say 90, 90, 90. Good. So that means you need a fraction of what we have already given you. No, this is wrong. This is a very wrong assumption. Actually, it will require more to do this, but that's what it takes. And if we really want to end TB among people living with HIV, and if we really want to end AIDS, then we have to be prepared that it will be actually not so easy. And yeah, but as President Kennedy said, we have to do this not because it's easy, but because it's hard and because it's the right thing to do. They were discussing the moon. We can, you know, we can skip the moon, but we definitely have to end TB among people living with HIV, and we definitely have to end AIDS, and we have to end TB in general, not just among people living with HIV. So I know it's not very bright, not very, you know, maybe it's actually, it doesn't sound too optimistic, but in fact, it's actually not as bad, because we do have new tools coming all the time, and we get to overcome mistakes of the past. One of such mistakes is thinking that we can deal with TB, that only doctors can deal with TB, that it's you know, medical response will be enough. No, it won't. Ministry of Health will not be should not be the only one dealing with TB. It has to be cross-sectoral approach, a cross-sectoral response. We should also realize that we cannot just tell people with TB, this is your treatment, go and take it, and or rather, which is actually, yeah, the funny thing about TB, come to the clinic and take it, or turn on your phone every time when you take your treatment so that we can see you take the treatment. DOT is a huge hurdle. It will never let us reach 100%. There will always be someone for whom DOT doesn't work. There will always be some Timor who will say, I'm not going to come to the clinic every day. There's always going to be someone who's going to say, I'm sorry, but you know, I can't do that. I cannot do that every day. There will always be people for whom, especially once they get rid of symptoms, who will say, I'm good now. I will go back to work. I will move to another country and continue my working and, you know, and do other things. So there will always be situations when this vertical approach, not supportive, but observing approach will not work. And what we need is to embrace the idea that every person with TB, and I emphasize person with TB, not a case. Case is something very standard. A person with TB is never standard. There is no concept of a person with TB who's the same as another person with TB. Everybody has their own personal challenges. Everybody has their own situations, has their own circumstances that make it challenging for them to either start the treatment or continue the treatment or complete the treatment. It can have to do with with side effects. It can have to do with psychological issues. It may have to do with the socioeconomic status of that person. There are plenty of things, plenty of factors which make every person with TB unique, which is why we cannot have approaches like, silver bullets. We should stop dreaming about silver bullets. Silver bullets do not exist. If we want a silver bullet, then we should just accept that we will never achieve 100, 100, 100. For achieving 100, 100, 100, we have to understand that our approach has to be individual based. We have to deal with every person with TB, every person living with HIV who has TB or who has latent TB infection. We have to understand that this is an individual with very individual characteristics and very individual personal circumstances. And we cannot just impose the same approach to everybody. That was a mistake with DOT. We thought like, we're gonna end TB now using DOT, even though WHO itself said, if we compare directly observed with self-administered, without any support, it's more or less the same. What makes the difference is not the fact that we're observing the person taking the treatment, it's actually what kind of support we're giving to the person. And this support may be more expensive than the treatment itself, unfortunately. For some people, it could be lack of housing. For some people, it could be lack of nutrition. For some people, it will be responsibility to take care of their family, to win the bread for their family. So it's very individual, and we have to embrace that. There are things which are actually common, and they have to be available to everyone. That includes counseling. How about giving people with TB good counseling so that they understand what diagnosis they have, what disease they have, how is it going to develop, and what is going to happen if they take the treatment, what treatment they are being given, how they should take it, where they can go if they have side effects, and what they can do if they have side effects, what they can do to address their other issues that may prevent them from continuing their treatment or completing their treatment. So when we address this in this very holistic manner, we will be able to achieve 100, 100, 100 by 2030. Believe it or not, we can. Yes, we can. And I think I should stop here. Thank you.
Thank you so much, Timur. I think people like you can never stop, because till we end TB and end AIDS for sure. And of course, then we will find another important priorities to focus on. So thanks a lot, Timur. You are so right that when you are saying with so much of conviction, it's so true that we can do so much better if we are really serious about ending TB. It's so surely about, you are right that in the last mile could be the most difficult mile. It may require more resources, and maybe more of the same may not probably work. We may need a whole different way of moving forward. And when you say person-centered, I think that is such a key word, person. And Dr. Paula Fujiwara opened the session today morning about 9 hours ago with this emphasis that we need to ensure that persons are central to the TB response and HIV responses. But are they truly person-centered? We heard this morning that people like in Delhi, for example, 90% of the TB in a presentation we saw are among the homeless and the migrants in Delhi, which is the highest TB rate. But even Shobha and I have spoken to about more than 50 now people who have completed the treatment, and they were within 100 to 200 meters of the best of TB facilities in the national capital of India. But why were they not able to go that 100-meter distance to avail of the free facilities? There are so many reasons for that, and we really need to look that. And the only reason why they could travel that distance of 100 meter, 200 meter, 300 meter, and in one instance it was just the back side of a chest hospital, it was because of the community worker. It was because of the frontline health worker. It was because of the community person who really took the pain to make sure that that person gets the diagnosis and care. And I think that is very important. I will quickly like to add, Timur, one very important conviction which I have. I feel that we really we are not doing good enough in using what we already have. We surely need new tools. We need better tools, more person-centered tools, more effective vaccines. But more than tools, we need a roadmap that how are we going to ensure that the best of vaccine, when it comes out tomorrow, reaches the last person in Uzbekistan, in India, in Africa. That has to be a priority. We do not want to repeat a COVID-19 vaccine scene where rich nations pile, vaccines many times more than their population, and people in so many countries in Africa did not had received a single shot of the COVID vaccine. We need to bring equity, justice, and so many other issues in this last mile. So maybe in the last mile, which could be the difficult mile, you are very right, you pointed it out so importantly, that we really need to make sure that not only there should not be no resource crunch, but apart from that resource, I think we also need to have a whole more intense focus on making sure that the person remains centered. And when the person remains centered, then probably the TB response will be better. And and if we are able to deliver the tools which we have today, then maybe tomorrow we will do a good job in delivering when new vaccines come up, new tools, diagnostic tools come up, new treatments come up. Because the reason why tools are diagnostics, treatments, vaccines are not able to reach the poorest and the most marginalized is because our response is not people-centered most of the times. This is, I feel there may be some differences, but I think, we really need to ensure that rights and person-centered approach are, we really walk the talk on that, and which means like from at all levels. And Dr. Tara Singh Baum was here in the morning. He was insistent that the difference comes when local actions are really walking the talk on on addressing TB, HIV, and all other risk factors which are associated to that. Sorry for taking so much of time. It was very insightful, Timur. No one would have was better than you opening this part of the session. Timur, we will move on and we will come back, Peter Oviti, to you. Peter, we need to listen to you too. But before I go to you, we need to listen to Charity Makona. Charity Makona is from the Charity. Are you there? Hi, Charity. Hi. So Charity is
Hi, yes, I'm here.
Yes, hi, thanks. So yeah, so over to you. Charity, thanks a lot for supporting this session also on behalf of the international community of women living with HIV, ICW. All our solidarity and power across to you for making such a huge difference in so many places over the years. Over to you, Charity.
Thank you very much. I hope you can hear me.
Yes, loud and clear.
Okay. So I'll take it from the last speaker, who has already taken us through a lot of issues. And I'm happy also to be part of this presentation as a speaker. I liked it when I saw it, it's about checks and balances, because simply it's just something that is reminding us of us being accountable and how are we going to reach the targets. We are good at setting targets, but really, are we getting to the targets that we're setting? So the last speaker started talking about it, and I've already talked about a lot of areas where I had to put in issues on putting people first and also ensuring we have one-stop shop, which will be ideal to us as we go further with our initiatives. So I'm taking it the perspective of women living with HIV, because I'm coming from the global network of international community of women living with HIV. So I'll take it to that perspective of women living with HIV and TB on how we're doing and how we're faring. So we are aware, of course, as women living with HIV, that we have a role to play and keep up the reality checks on both HIV and also TB, as the diseases still remain to be the most deadly infectious diseases that we're facing around. And to the sad and the burden to be even worse to women, because we are affected in several areas with TB, and especially when we are positive, HIV positive, simply because of the weakening of our immune system. So this has become a very, very big challenge, as we are seeing that now even the death roll of people who are dying of TB, most of them, they're also people who are affected with HIV. And this is really something, a concern that as women living with HIV, we are taking accountable, and we're making sure that we are leaving no one behind, to make sure that we have clear strategic approaches on our constituencies, and that also we're accommodating all people that matter when we're doing our things. So firstly, I would say we are aware that yes, this is leading cause of death among people living with HIV, especially women of the bearing age. It is very significant that it's a burden. Most of people are affected. And also we know that women living with HIV are particularly vulnerable to TB due to their compromised immune system, and also for the reason that we are vulnerable to drug-resistant strains of TB. And also studies have shown that women with HIV are up to 3 times more likely to develop TB compared to women without HIV. And also TB is leading cause of maternal mortality, particularly in high HIV prevalent settings. And also women living with HIV are at increased risk of TB, not only because they may experience limited access to healthcare, maybe stigma on gender-based violence, but due to the weak immune. So we need to pull up our socks and to stand up so that we are taking part, and we're making sure that we are contributing to the global approach on how TB and HIV issues are being handled and taken into our programming. And also amongst women, TB mainly affects those on the reproductive age, as I've already mentioned, because when the active TB disease develops during pregnancy or maybe in the last weeks of a birth, it is associated with poor health outcome for both the mother and also the baby. So this whole thing is really something that is really affecting us so much. And what are we doing as women living with HIV in our programming? Mostly what we are doing, we are making sure that we have to enforce and held accountable to make sure that we are having at least co and integrated programming and financing to make sure that most of these diseases were then being tackled and they are being taken care of. They should be tackled integrated together, so that all what programs are being put together are of a benefit to all of us, especially us women, because we are at a high burden. So we need to transform our response to TB on our programming, and we need a gender transformative, integrated, and also women-centered approach to TB care that responds to the unique needs of women living with HIV. And how are we going to do this? We need to pull up our socks and continue to ensure that to have stigma and discrimination-free environments that we have fought for so long. And also we should continue promoting and advocating for strengthened health systems integration financing programs. This is an area where we're seeing a lot of opportunities in order for us to continue fighting for TB together with HIV. And we also need to advocate, and we are still advocating for innovations in diagnostic delivery and any other innovations to ensure that increased access to TB diagnostics, treatment, as well as prevention, we are winning on that side. And also we continue to advocate for peer and psychosocial support. And this one, we need to go an extra mile, not just only reaching out to women who are struggling with TB, but also providing them support that they need as they're passing through this burden. And also women living with
Charity, I think we lost you perhaps. Yes, I think we have lost her. Hope she's able to join back. Maybe it's an internet issue. Peter, you wanted to say something? Peter Roveti from Vote Youth Development Project. Peter, are you there?
Yes, I'm there.
Yes,
Thank
hi
you very
Peter,
much.
how are you?
I'm fine, thank you. And
Great.
you?
So Peter from Bokeni, Kenya. Over to you, Peter, a long time HIV and TB activist, right space. Over to you.
Thank you very much. And I can see my friend Timur is growing a beard. I'm happy to see him again. Now, I wanted to ask one or two questions. One is the fact that we are having, as notification lowers and TB incidence has become lower, there is a drive to integrate TB services. So you find that TB and HIV are being handled at the OPD. The OPDs, outpatient dispensaries, and everybody's mixed there. And we have a feeling that this again would drive out the stigma, bring back the stigma that we had been battling with, that people are being handled at the same point, and also what Timur, who works or has experience in both HIV and TB, what would be his opinion about this integration? And if it's to be done, what's the best approach?
Bobby, can I respond?
Yes, please. Yes, of course.
Okay, Peter, thank you very much for the question. I don't see you. Maybe you also have more hair. I don't know. But thank you for the question. I think that actually this integration is inevitable, especially as the numbers go down. We will have more and more services provided at the level of primary healthcare. And this can be seen both as an unfortunate development, but also as the right way forward. Let's think about from this perspective. The TB infrastructure, the clinics, the dispensaries that we have, they're going to become too costly to maintain as the numbers are going down. At some points, they will be so expensive that it will just not make any sense to keep them. So this is a move that is inevitable. Maybe it seems a bit premature, which is why I think we should not be just replacing something with something. We cannot go away from the system we have now and completely transfer it to primary healthcare. This should not be happening. We should have as many options as possible, especially now that we're approaching this 90-90-90, 95-95-95, and as we're moving to 100-100-100, we still need to have different options available. For some people, it's actually more convenient to get to primary healthcare, and for the others, it's much more convenient when somebody is coming to them, as was pointed to by Bobby, because that's the only way they can be reached. But I should say that in fact we should not be just coming up with primary healthcare as the new silver bullet. As I said, silver bullets are impossible. And what you said about stigma, very, very important. We do need to make sure we tackle stigma, we fight stigma, because there is no way we will be able to reach 100-100-100 targets without beating stigma severely. This stigma has to be we need to really kick crap out of stigma. But otherwise we will not be able to achieve it. Stigma will always be a factor that will prevent some people. They will be actually actively hiding from services because of stigma. For them, it will be more scary to come out and get services than actually to just thinking about what can happen. The prospects, the dim prospects of, I don't know, losing health or even life, for them, it will not be strong enough a consideration to overcome stigma or fears. So yeah, you're absolutely right. We should we have to move that way, but it has to be done in a way that is not jeopardizing the gains we achieved so far. Thank you.
Yeah, thank you, Timur. Because in Kenya, there's a drive to close down the CCCs, the comprehensive care centers, and make it an open thing because of the other diseases. But we are saying no, we can't do that right now. The way you have said it, for reasons we can't take it that fast. Can I ask the second question?
Peter, can we just hold on to that question, the second question?
Okay, thank you.
Because
thank
Charity
you.
was speaking and her connection, she lost the connection probably midway. So let her finish and then we come back to you and Catherine. Okay?
Perfect.
Is that okay? Yeah. All right. Thanks, Peter. Charity, is it working now?
Yes, thank you very much.
Good,
sorry, we're having issues of power, so back and forth. Okay, so I think I was mentioning some of the things that we need to do in order to transform our response to TB as women living with HIV. So the other point is we are looking up to steady global political investments and firm commitments to end the epidemic of HIV and TB by 2030. Simply because we're seeing some recent data which is indicating that at national and global responses are veering off track, which risk reversing the life-saving gains that we have made so far. So we feel like women, we need to stand up and continue to make sure that we're taking part to make sure that TB infection is reduced through strong infection control measures, and also through timely diagnosis and also treatment, so that at least the latent infection is prevented from progressing to active diseases. And we also, as women living with HIV, looking much on the 3 I's for TB and HIV and early initiation of ART, because we still feel maybe on the 3 points, the 4 points of intensified TB case finding and also ensuring high quality and tuberculosis treatment. To us, we feel like at every encounter with a healthcare worker, people living with HIV should be screened for TB using the WHO recommendation for symptom screening algorithms. We still feel this is very important, that should be kept and be provided. I'll refer it to the issue where someone indicated, one of the presenters indicated that we really need to have one-stop shop, where if you go for one service, you have to make sure that you find the other service also being rendered at the same facility. And also on isoniazid prevention therapy, IPT, which prevents latent TB infections from progressing to active disease. We also still working on this, trying to promote and also advocate as people living with HIV, so that active TB has to be ruled out. We should continue to receive IPT for at least 6 months as part of a comprehensive package of HIV care, regardless of CD4 count and also the use of ART, and also even maybe despite history of previous TB treatment or any pregnancy. And also we are advocating and promoting much on infection control, where we feel integral to TB prevention among people living with HIV is sounding to be a policy and practice in TB infection control. So we strongly feel the administrative part, environmental and protective measures against the transmission of TB infection should continue and should be implemented in all health facilities, so that at least people, when they are being attended, people living with HIV, they should also be part of other congregated settings, and they should also have the access to this. And lastly, I would say we are also promoting and continue to advocate for early initiation of antiretroviral therapy, ARTs, because we strongly feel that it plays an extremely important role in both the prevention of TB and also reducing mortality of TB patients living with HIV. So in general, these are some of the areas that we are working on and we are looking on while we continue to at least have realistic checks and balances on so far what we are doing when it comes to HIV and TB issues amongst women who are living with HIV. So this is what I really wanted to share with you. And we continue to work together with all other portfolios, all other organizations who are working on HIV and TB to make sure that we win this journey so that we continue to achieve the 100 targets that we're aiming at. That's what I had to share with you. So thank you so much. Over to you.
Thank you, Charity. Thank you so much. Timur, you want to say something?
Yes, I put it in the chat, but I completely agree with everything Charity said. I just want to emphasize that in addition to IPT, we also need other TPT, other TB preventive treatment options, especially because IPT such a long it's a long journey, and given that we do not always have proper counseling, unfortunately, for people who are embarking on IPT, they just don't see the value. That was my story. I was given IPT, but they didn't bother explaining me that I should be taking it for months religiously, and I didn't. And then I said, like, hello TB. So the 3HP is a very convenient option for a lot of people. Because of side effects, a lot of people will still prefer IPT because it's not associated with some side effects, some strong side effects. 1HP also an option. And unfortunately, this, like, we had this conversation about new tools. You, Bobby, spoke so rightly that, you know, we were speaking about the new tools. And yet, for some reason, even the tools that we already have, they're not introduced properly. So this 3HP, 1HP is definitely among the ones which are unfortunately not really available everywhere where they should be available. So yeah, just wanted to point that. I hope that doesn't undermine what the importance of everything that Charity was saying. Thank you.
Not at all. I think that's a very important message, Timur. Thanks a lot. And Keitho from the Treatment Action Group, TB-CAP, had also reinforced this earlier today, that we really, all of us should be, you know, doing all what we can to push for 146 by in the end of 2024. And then, as Timur just said, like, you know, there is no excuse for not treating people with the best of medicines. It is not acceptable that rich nations or some people can get best of medicines, and while the remaining have to deal with longer, toxic, and less effective treatments. So today, we really need to push for equitable rollout of the best of diagnostics, best of tools in people and person-centered way, as Timur and so many other speakers have really tried to bring home the message. And I'm sure that message will resonate with all of us. I know we all are running. This is a long session. Thanks a lot for staying with us. Tariro, let us quickly move to you. Tariro Kutadza, I'm sure many of you will already be familiar with her. Tariro, are you there? Tariro?
Yes, I'm here.
Yes, okay. Tariro, the force for change on TB HIV, and making sure TB HIV responses are rights-based in Zimbabwe, sub-Saharan Africa. All of you probably will be already familiar with her. Tariro has led TB people, is leading TB people Zimbabwe, and doing wears a lot of other hats as well. So welcome, Tariro. Thanks a lot. And after Tariro, we will open this for brief, comments and interaction. Peter wanted to say something, and I saw a hand from Catherine also, and then let us see how it goes. Over to you, Tariro.
Okay, thank you so much. Can you hear me?
Yes, we can hear you. Yes.
Hello, can you hear me? Hello?
Yes, Madam Tariro.
You can hear me. Okay, thank you so much. My work was going to be very simple for this session. Unfortunately, there are a lot of people who couldn't make it and so forth. My work was to take you back where we started around 2 a.m. At night here in Zimbabwe and say those hard questions, where we are with TB and HIV and other pandemics, is we have to ask each other hard questions. When AIDS and TB death are preventable, and avoidable, then who is responsible for over 630,000 AIDS-related deaths and 1.3 million TB deaths as in the report of 2022? Who is responsible? This is a collective failure because we have the tools to avert every TB and AIDS death. Even one TB or AIDS death is a death to men. When we talk of figures, it's like it's maths, it's whatever. But we are talking here of human beings, loss of human beings and so forth. One death is a lot. For a village, for a community, for a constituency, it's a lot. So the deadly divide between what we can do and what we are doing must end. And think Timo and other presenters, since we started, they were all talking the same thing. What we can do and what we are doing must end. Yes, funding is very low, but what can we do? What can we do? Sometimes my heart bleeds when you say, Southern Africa is poor, this country is poor and so forth. But there's a lot of trails where man can be get and so forth, but it's only a question of priorities. So you have to advocate, let's advocate for domestic financing agenda to be a priority in countries. If we do that, yes, we can end TB. We can find all TB and HIV and treat them with the best of treatments and support people to finish TB therapy and remain viral suppressed. But are TB and HIV responses people-centric? That was the discussion over and over again. Every speaker coming in, going out, that was the discussion. People-centric. What do we mean? Unless we ensure TB and HIV programs are people-centered and people are fully supported to stay healthy and productive, how will we ever end TB or AIDS? And Timo said it all to say, there's no one person fits all. Every person is different. What is good for me is not good for the another person. As much as we use evidence, as much as we use mathematical modeling and so forth, there's no one model fits all. We need to have to use different models and so forth, and we don't need to abandon the old bridge because we've built a new bridge. If we do that, we will not end TB and AIDS. We need to ensure each person with HIV is viral suppressed. Undetectable equals untransmittable. U equals U. Science, you've spoken, must be a reality for every person with HIV. This is doable, possible, but not happening. Not happening. Most countries, if you talk U equals U, they'll bring the signs. No, there's some different. No, there's not enough. No. But we, people live with HIV, the people with who are living with the disease, we see it's doable. To us, it was it's a game changer. U equals U is a game changer. We are talking of figures that HIV, people living with HIV and AIDS, they contribute to 78% and so forth. In my country, it's 50% of our TB is about people living with HIV and AIDS. But there's a game changer for those people living with HIV and AIDS. U equals U. What are we doing? And why are we not fully embracing that U equals U a mantra? Similarly, we must ensure every person with HIV remains TB-free. Find all TB among people living with HIV and AIDS. TPT became a must. Let's invest in TPT, 3HP to be more specific. We have the best of WHO recommendation molecular test. We also have point of care and point of need molecular tests that are battle operated, laboratory independent, and decentralized. Science confirm that genes don't lie. So tools like TrueNut that can go very close to the community. We also have battery-operated and ultra-portable X-ray machines that can go at the doorsteps of communities for TB screening. Before I attended GOHA meeting, I thought we had to reach areas in my country, Zimbabwe, even South in Africa. But seeing the Philippine story, there's no, I came and said to my country, we don't have any hard to reach area. If bread can get there every day, if beer can get there every day, what is so impossible about people's health to get there on daily basis? Every area in my country, bread reach there, beer gets there, opaque beer get there from our Kamban Delta in Zimbabwe. Soft drinks get there. But when it comes to people's health, it's hard to reach. It's hard to reach. But now we are having those tools. They are there, they are here. So we don't want to hear this, we are missing people, we are there in our communities. We are there with our TB, with our children, just to bring these diagnostic tools closer to the people. This molecular test here can also test HIV, do viral load monitoring, test for sexual transmitted infections or other diseases like malaria, hepatitis, or HPV, which causes cervical cancer in a way. If we deploy these tools in people-centered manner, we can ensure people remain healthy and free of HIV, as well of many other disease conditions. Aging with the diseases should be aging is a human right. We have seen people aging with the HIV being pushed out of most interventions and so forth. This must stop. Aging with the diseases is a human right. We lived with HIV and AIDS, there was no medication. We grappled with HIV using herbals, whatever, hope. It was about hope and preparing for our death, using memory boxes and so forth, and we survived. The introduction of new ARV made us deformed. Some of us lost all their body shapes and so forth, but we survived. Now there are tolerable medications, we are surviving. And we are living with not less than 3 conditions when aging with HIV and AIDS. And programs are now splitting the aging. The aging is, we are like, it's about young people, yes. But remember, that young person is that's my son, that's my grandson, who I was talking to the support group with more medication, without medication, that's the son I was taking all over the place to understand my disease. Siloization of people, it has become a program. But what are the outcomes that are coming out of there? Hard question. We should ask each other hard questions. Are we chasing the disease? Are we chasing the viruses? Are we chasing people? What are we chasing? We need to reach the unreached and ensure all quality TB services reach them with equity and justice. Every person who gets diagnosed with TB must be initiated on TB treatment with medicine that he or she is not resistant to, care and support to help the person with TB finishing the treatment and reach the cure line is so very important. We have to translate the call of, yes, we can end TB. In reality, on the ground, when we find all TB, treat all TB, and prevent all TB among people with HIV and AIDS. Finding TB is the entry gate to TB care pathway, which is stop missing TB cases by taking labs to the people and by replacing microscoped with molecular tests as per the WHO guidelines. Every person who dies of TB or AIDS is a grim reminder that we failed in timely diagnosing the person and or providing treatment, care, or support with equity. Equity, people-centered approaches, and gender transformative programs can make a huge difference in ensuring latest WHO recommended tools reach the point in need. Yes, we can end TB. I thank you.
Thank you so much, Tariro, for for this moment of truth. We really need to ask these questions, and we all were trying to raise those issues, but you have really so strongly, put the spotlight on the core of the collective failure, which, as you rightly say, it's a collective failure. Thanks a lot for reminding us again that every case of TB or AIDS death could have been averted. It's a grim reminder. You are very right to use those words, and also that we could have done better in terms of the responses. And what the Timur said earlier, I think, it is really important to remember that we can do better. We have the tools. We know how to prevent transmission. We know how to diagnose. We have the best of tools. We have the best of treatments today. We may have better ones tomorrow, but we have things today, and we really need to make sure that we are deploying them in a way, as Tariro, Peter, Timur, so many speakers have repeatedly emphasized on the word person-centered, rights-based, as Charity said about gender transformative. It is so critically important to shift. We need a transformative shift in the way we are doing TB programming, as well as HIV programming, as well as nutrition programming. I will just remind you one thing, share with you one small little thing before we hear Nicolas. Nicolas, you can speak in French. Nicolas Vaco is from Ivorian network of people living with HIV, RIP+ in Cote d'Ivoire. So Nicolas, I don't know French, but I have huge respect for the work which you do. And I really hope there are people here in the room and also watching online and on the webcast related to the conference, etc., who will be able to relate to you. And I will definitely try to get a summary. Over to you, Nicholas. Thanks for joining.
If you want, I can try in English if there is no translation.
There is no translation, Nicholas. So if you can.
Okay, then I will try in English.
Unless some friends can help us summarize. All right. Okay. Thanks.
I'll give you some data to start. You should know that we have 407,000 people living with HIV/AIDS in Cote d'Ivoire. And I'll give you some data. For new cases of TB, we have in 2023, 21,458 people. We have a level of incidence of 123 cases upon 100,000 inhabitants. So you can see that the level is important. We have premises. We have 350 structures where people can go to make testing of TB. For the strategy, we will tell you that when somebody is tested HIV or is tested tuberculosis, he has the other side, meaning you have, for example, people who have tested HIV, there will be systematically tested TB. If they are tested TB, there will be systematically tested HIV. So there is this screening that is being also done at each consultation. At each consultation of people having HIV/AIDS, they will be asking if they are coughing, etc. Who goes for those consultation? Do you get me? Because I got a phone call. So those who are tested positive will be taken automatically into charge if they are in a structure where this is being done. If not, if they are tested for the TB and there is not the structure, they will be referred to another structure where there is TB. And they will be beneficiary of a follow-up on the two aspects. The majority of the sites used to do the two pandemics. So there is always a place to take care TB in each sanitary district. They will also, this insurance that they will be taken into charge, they will be taken, they will be followed, they will be cured. We can then say that 100% of prevention is assured by our technique testing treated. As soon as you are tested positive on HIV, as systematically there will be testing tuberculosis and the other side also. That means that for prevention, it is 100%. And also to take in charge is also 100%. Every 6 months, the patient will benefit all the benefits of a viral load every 6 months. And then the community workers activity will permit patients to be observant, and it will permit the patient to have a viral load suppressed or undetectable. For those who have a viral load detectable up to 1,000, they will have a very high follow-up on 3 months. After 3 months, they can come back to start with the viral load. That is what I can say for the meantime for Cote d'Ivoire, speaking about people having HIV and TB. Thank you very much for this time given to Cote d'Ivoire to participate. I will be at IAS in Munich. We can meet there.
Yeah, thank you so much, Nicholas. Thank you. And sorry for not translation in French, but maybe next time we can find help from some friends who can help us translate, perhaps Tibur or
no problem.
Yeah, thank you. But thank you so much for sharing. We see Dr. David Pagwesese. Dr. David, are you there? Dr. David, are you there? Anyway, so Peter, you wanted to say something. Can we move on to you then? Peter?
Yes, thank you again.
Yes.
Thank you once again for the opportunity. We saw the advocacy in HIV bringing the advocating and bringing down the price of ARVs from as much as from 60,000 US dollars, 60,000 Kenyan shillings to free. And a number of speakers have talked about diagnostics, and we have this issue of molecular diagnosis, and the $5 campaign is not bringing the prices down. What is it that we can do? How can we copy from the HIV community to bring the prices of molecular diagnosis down because people are enrolling when it is late and people are dying through relapses. Honest, in Kenya, the death rate moved from 5% to 13% during COVID. So what is it that the TB people are not doing to bring the molecular diagnosis to $5 from the J&J and company? Thank you.
Yeah, thank you. Timur and Tariro, please. Thank you.
Yeah, I should say we are doing, we're just not doing enough maybe. We do have some recipes. One thing that we have for TB, which we don't have for HIV, is GDF. And GDF actually helped bring prices down significantly. So that's an achievement. We're not there yet. The recent project that was supported, I think, with USAID and led by TAG, it's basically supporting the proliferation of community advisory boards. We had a lot of community advisory boards for HIV. They played an instrumental role on putting pressure on pharmaceutical companies, on the industry, to bring prices down. And I think we will see the rise of that pressure in TB as well. So there is no one solution. It's a range of different tools, but I agree with you. We should be doing more. We should be more adamant when it comes to prices. We shouldn't be like, oh, so good, we reduced the price by 20 cents. No, this should not be, the reaction. What I like about HIV is like a lot of pressure, prices are going down, and then the community says like, yeah, you think it's good enough? No, it's not. You need to bring prices down more. So instead of like saying thank you, instead of saying like, oh, good job, no, they're saying like, this is not enough. So this is we should be this grumpy people who are never satisfied, because you see, as you said, it's the best price is when it comes for free. And of course, it's not coming for free because it's still paid by the donors. But as long as it's coming for free to the end user, that's very important. And also, as long as there is continued pressure to bring prices down, because after all, in TB we have considerably more domestic spending. So and we know how governments don't like overpaying. So basically, the lower the prices, the better access we're going to get. So I agree with you. We need to be more adamant. We need to put more pressure. We need to use different tools and different platforms to do that. And I already see the change in the TB community. I just hope it will continue. I hope we will continue moving forward and putting pressure on the industry, but also not just on the industry, but also on the domestic regulators, because it's natural for the industry to do their best to keep the monopoly. And it is the problem when the domestic, when regulatory authorities in countries, they allow evergreening the patents. They allow extending the patents when there is literally no novelty there. They just come up with a new salty formula and like, yeah, let's do that, or a new formulation, and they just go for patenting. So it's not just putting pressure on the pharmaceuticals, but it's also putting pressure on regulatory authorities in countries, on their authorities that are giving patents, so that they do not give patents for something that is lacking novelty, which is also very important. And when we stop this epidemic of evergreening the patents everywhere, well, that's also going to be a huge victory as well. And let's not also think that generics are always a good solution. It was such a textbook example when GDF got a better price from the originator than from generic. Generics are as greedy as the originators. They want as much profit as they can. They are not like these saints, you know, with a name over their heads. No, they're greedy. So we just need to treat them as such. We need to understand that generics and the competition, we need to understand how the market works. So competition is the solution, not generics. It's the competition which is the solution. Generic companies will be forced to bring prices down when it's not just one generic company and one originator company in the market. When it's more, that's when the change is coming. And to have more, we need to get rid of patents, at least to make sure they're not being extended without proper ground for that. So thank you very much.
Yeah, thank you, Timur. Totally echo and totally support what you have just said. Absolutely. The corporate greed is not only limited to diagnostics, not only limited to treatments, not only limited to vaccines, but it is all around the sector. And until the day we give up, we die, you know, like it's like the people need to really push for affordable, accessible, quality assured medicines. What Timur reminded us is very important, that the quotation from the originator of the medicine was cheaper than the generic manufacturer. We really need to keep this context in mind while we push for all essential health services and tools should reach all the people, regardless of where they are, regardless of whether they have money to pay or not. Tariro, we see your hand.
Okay, thank you so much. I'm so blessed. I'm so empowered seeing my mentors, my leadership around here. And I just want to say to my leader, Peter Owiti, this is the beginning to where we want to go. The most problem about TB is it has been medicalized in countries, NTPs. They sort of don't want to let it go and so forth. So once that happens, we don't have information. You can't advocate if you don't have correct, consistent information about even the tools, about vaccines and so forth. But once we have the information, then the role can go. That's why we started this and launched this Find All TB, and we want to applaud TB people for TB people and partners to come up with this. This is why we are striving to get as much information as possible. For example, this event, we had got a lot of information from different sectors, private sector, from everywhere, so that when we plan now as advocates, we plan and now shape our advocates and prioritize our advocates, then we can get what we did with HIV and AIDS. But thank you so much for the support, and thank you so much for bringing that.
Thank you, Tariro. Thank you. Catherine, the last word, if you have, because we are running behind time. Do you want to say something, Catherine? I saw your hand. All right. Okay. So
no, it has been addressed. Yes. So thank you. It has been addressed. Thank you.
All right. Okay. Thank you, Catherine. Thank you. So thanks a lot, friends, for joining us in this part of the session. A very energizing session, very thought-provoking session. Thanks for waking us up. Also, it was a kind of a wake-up call too. And let us hope this energy continues as we journey to today, but also beyond today. That is when it will really matter. What Timur, what each of the panelists, Tariro, and everyone has said, Charity, and everyone. So, so thanks a lot for joining us. Over to you, Shubha, for the next part of the session. Thanks, Timur. Thanks.
Thank you, Bobby. And I feel honored to invite today once again Dr. Tara Singh Bam. We all know he's been with us consistently today with us since early morning. And but just for the unversed who have joined later, Dr. Tara Singh Bam is Asia Pacific Tobacco Control Director for Vital Strategies, He's also the board director of Asia Pacific Cities Alliance for Health and Development, or APCAT as it is called, and former Asia Pacific Director of International Union Against Tuberculosis and Lung Disease, or the Union. And above all, he's a passionate believer in the power of local action at the ground level to achieve global goals. Dr. Baum is the keynote speaker for how and what can we do better to stop the spread of both TB and HIV. Over to you, sir.
Good. So thank you so much. I don't know my slides. Can you see my slides?
Can see, yes.
A bit different.
Yes, we can see it.
You can see it. Just I'm going to highlight some key things. I'm not going to repeat any things that we know. So there are already several things already raised from early this morning until now, and it's really great learning. And we have such a the mix of the stakeholders here, bringing the issues from the different perspectives. So what I'm going to do is a bit different, but most of the things I think already discussed. But what can we do differently to really eliminate tuberculosis and prevent the HIV? Just if you look at my second slide, I just see this slide not moving. Yeah. So this morning, the GAMA, he highlighted some key points. The GAMA is the union, the president, and in his presentations, there are some the points that I have noted here also. So he mentioned in his slides it's really important to break the chain of the TB transmission in a community. Yes, that is true. That's why we are here. That is our end goal, to completely break the chain and stop the transmission. So what we need to do is it's really important to have the early mass screening, early diagnosis, and early treatments. Of course, all of these things needs to be also sustained over the time. So therefore, at the same time, we need to also look at the different perspective. How can we really manage these issues and implement at the community levels? With this, and also Dr. Paula and many other speakers, they also highlighted the key risk factor for TB, and also these risk factors also related to any other the disease or any other health issue as well. So yeah, in this slide you can see that I just put some the high burden TB burden countries. There's some slide that the WHO has put in the report. It mentioned that there are 5 key risk factors for tuberculosis. That includes HIV. Of course, smoking, the nutrition, alcohol disorder, diabetes. So these are the 5 key risk factors. If you look at as per the context, I think someone has really highlighted this morning. It should be more contextual. The strategy, the activities, our policies and programs should be more contextual. So if you look at in this slide, for example, in Vietnam, smoking and the malnutrition are the key determinants or the key risk factors for tuberculosis. Of course, HIV, diabetes, and alcohol is also there. Like in Myanmar, if you look at it on the right side, so the HIV is a key risk factor for for TB. So it depends on the countries and the context. Like for example, India is also the malnutrition is a major issues. Followed by the alcohols and then the HIV, diabetes, and smoking. In Indonesia, smoking is the major risk factor for tuberculosis, following like the malnutrition and then HIV and diabetes. So in this case, I think it's really important to have a holistic approach to address this at the various levels. So in my next slide, I'm going to speak. Actually, this is the last slide. And I'm going to speak a bit more about what we need to do differently. I'm not going to repeat any statistic here. So what I'm going to say here is we need to really make the tuberculosis and HIV a local political priority agenda. That is very, very important. All the implementation, all the actions, everything that happens at the local level. So we really need to prioritize. This should be the political priorities at the local level, and local action should be also should be the political priorities for the national governments and also international governments or the partners and the community as well. So why we need the local action? Who can take a key roles? I think in the lesson that we have learned from many other public health intervention, especially from the tobacco control, the mayors, the local leaders, the city mayors, the provincial governors, or the state, the ministers, they are the key people to really manage any public health intervention at the local level. So therefore, what we need to do, I put, you can see the 4 boxes. The first thing is the building leadership. So leadership, there are different types of theory and all these things. Some people say leadership is a by birth, or some say it can be built. So from my perspective, leadership can be built. Of course, there are some characteristics of the leadership by birth for some, but mostly it can be built as well for the agenda. So the mayors or the political leaders at the local level who manage any development issues at the community levels, I think that's the leader. So what is really needed is, when we say the local leadership, the agenda needs to be integrated with the local health and development plan. So TB, HIV, and all the health intervention, they are not only the health program, health challenges or health issues, but it's more on the development issues. And the local leaders also focus more on the development side. So it can be really prioritized as the development the issues in their local plans and the policies. I think that is really important. For example, when I say the local development issues, the TB-free the city, or TB-free community, or smoke-free the cities or province or state, something like this, we should really come up with the development themes so that all the sector can they bring together. The second is the strategic plans and action. That, as you also mentioned several times during today's meetings. So we need to, local leaders, they have the capacity, they have abilities, they know what is about their community, of the communities. So any plans and program or strategy that is developed, it can be more on the local context. So then if the program and plans is the local context, and that can be implemented and well accepted by their communities. So local leaders also can have a really the influence to build the local the network with the different civil societies, community, the community groups, and there are many other organizations, including the faith-based organizations, who can play a major role at the community level to influence the people's behaviors. So the leaders, local leaders, the mayors, has a power to the communities. And then accessibility. Again, we talk many things about this. The local leaders, they know their geography, they know their population dynamics, they know the economic and social context at the community level. So they can come up with a different the strategy to make the service available near to the service the users. So now we have a new technology. The technology can be used to screen the tuberculosis or the HIV, and it can be used for early diagnosis and treatments. Moreover, I think it's also important that I think the previous speaker talks about the one-door the service by the providers. So the local leaders, since they know their context, they can come up with the unified or integrated the healthcare the services from the one health center or from one room to everything. Like for example, in this case, TB and also the HIV care and services. So another point is really important, like that we learned from the many, especially from the COVID, the mobile clinics. So mobile clinics is another concept that can be also used at the local level if we really build their leadership of the leaders and the politicians. The second block is the accountability. I think that is really important. So what I mean by local leaders accountability, and local leaders always we can build their accountability to practice the best practices or implement the locally locally suitable best practices to offer the TB, HIV services and other services or whatever they need at the community levels. And the leaders needs to make them more accountable to offer the community-centered solutions. I think that's, as I mentioned earlier, only I don't know what is about the local context. And since the local leaders, the mayors, they are the local policymakers, local decision makers, they know their community, so they can offer the community-centered solution that includes more on the individual or person to person, the services, or they can also come up with a strategy to provide the people-centered approach. So data-driven is also another approach that that is needed to build the accountability of the local leaders. So there should be a mechanism, or the leaders can build a local mechanism to track the outcomes and evaluate this and identify the local, the lesson learned, and also improve the services accordingly. I have seen in many documents, WHO documents and others, and some of the presentations, we talk about the reduction of the stigma. I don't believe it. What do you mean by reduction? We need to go for the zero stigma. It's not a reduction of the stigma. We don't want the stigma in our community anymore at all. So therefore, the local leaders, they can play a big role to ensure a zero stigma about TB or about HIV or about any other issues. So that is really important to mobilize the local leaders to eliminate the stigma from the community by building the different the contextual public awareness campaigns, by mobilizing the different groups at the community levels. I think that is really important. So rapid response, that is another key area that local leaders can act immediately so that the things can be tackled quickly. So managing the conflict of interest, that is also one of the key things globally and also locally as well. So when I say the managing conflict of interest, there are many issues. For example, like the harmful industry, for example, tobacco industry, alcohol industry, or there are other type of industries that produce the harmful products or services. So that's sometimes what happens, they offer the really some donations for the public health program. I think there are several. They made several donations during the COVID as well. Actually, their vested interest is to make the profit. So we really need to make our leaders, especially the local leaders, and also, of course, the national leader as well, to be more accountable, and they should also manage the conflict of interest in the public health programs. The third one, building the sustainability. I think that is key. Once we don't do the project. We don't do like, we achieve 85% cure rate, for example, and then we don't do. No, there should be a sustainable mechanism established at the community level, at the local level. Only when we talk about sustainability, then only it's an issue for the local governments. So the local governments the local leaders can build a mechanism to have the whole of government approach to address the issues of TB, HIV, and smoking, or any other the public health issues at the local level. When I say the government, all of governments, it's not the different departments of the health, but it's all the government beyond the health. So they to really make sure, like the TB eradication, for example, from the city. So there must be a whole of government approach. And then another most important part is we do the planning. So there are like the global plans. There are global strategy there, but and the national strategy very beautiful. It's so beautifully written, but there is no resources. I think the strategy or the plans that is developed, it must ensure that there is that activity is costed and budget it and ensure the budget source as well. So yeah, I think this is something that can be done when we go at the local level. So we can really tailor the the locals the contextual the strategy and the leaders and the local politicians. They can ensure the local the resources and the local budget whatever they can do, and they can also go further to find out the resources from the national and the international or bilateral donors as well. But the point is any strategy that is developed must be costed and budgeted. Another important point I would like to point out here is we need to build the motivation, the mechanism, the empowerment for all the health providers who works at the community level, who works in a difficult situation. I think that should be sustained, and also we need to empower, of course, the community as a whole. That is also important, and local leaders, they know how to what type of incentive or the motivational the activity can be carried out for the health provider and the community at the local levels. So another important part, I think again, is a meaningful engagement of media. So everybody they wants media. Okay, so thanks CNS, I think leading this all the big issues and bringing everyone from everywhere. But what we need the really meaningful engagement. The leaders, the donors, the partners, the community, everyone, they have to engage media in a meaningful way, not to just publish their name and their or their fame. No, that definitely not. It should really targeted to the issues of the TB, HIV, or any other health issues. The last but not the least, I think this is really important. We need to come up with from the box. Like we need to building beyond the box. That is some innovative action that needs to be developed and implemented. I think we are now still talking about the numbers, but I think we need to go in a whole societal approach, the community approach. So therefore, mass screening, whether for TB, for HIV, or any other disease, I think mass screening is really important, and we can start from the local levels, so under the leadership of the local politicians. That can be mayors or any other. There are different types of the leadership at the local level. Under the leadership of the locals, the governments, we can really go for the whole city or whole districts or whole province or whole state for mass screening. I think that is something we need to really push and advocate. And the second one is the health, beyond the healthcare system. It should not remain anything that we talk should not remain within the health sector. It should go beyond that. I think the families is the very important partners in a whole healthcare the system. So it should be officially the family should be engaged in a meaningful way to provide the support in a whole health service and healthcare. Another point that I would like to highlight under this is engaging TB and non-TB population to safeguard their health rights. It is really important. So it's not only the TB community at this point. Is highlighting the issues, sharing the difficulties, and sharing their also the demand, what they need. But we need to also promote, engage the non-TB population as well, because to ensure the support to the TB population and to ensure the building the advocacy at the different levels to eradicate or eliminate tuberculosis from the community, or provide the better, the services and something for both TB, HIV, and other the health programs. So therefore, it is really important to engage the non-TB population in all initiative of the TB and HIV control and prevention. So finally, it is also it's not the out of box things, but again, I put this one intensely in this managing the comorbidity. It's not only the TB program or HIV programs to talk about how to manage all comorbidities. can be TB smoking, or TB HIV, or TB diabetes, or TB alcohol, or TB nutrition. No, this everyone should talk. It should be like a development agenda. That's why all these the risk factors should be put under the umbrella of the development, the plans, so that they can be managed more effectively and more comprehensively. Therefore, I think it's really important to build the capacity of the local leaders and mobilize the local leaders for TB eliminations and the HIV prevention programs. So you can see there are two pictures that I put here. One is the CNS published this one, the news last year. It's about the local leaders, the engagement in Bangladesh for TB, tobacco, NCDs, and dengue, and there are many other issues have been discussed during that meeting. So they all are the local leaders, the mayors. They are committed to really do something different that they usually do. So the upper part of the on the right side of upper part, you can see the picture. That's the mayors of Magelang city in Indonesia. He was trying to deliver the message to his community and engage the community by saying, you can see that he broke the cigarettes, and then he conveyed the message like no more tobacco, and also his vision and is to make his city, that is the Magelang city, a tobacco-free city. Of course, so this type of models we can really implement at the local level for TB and HIV, the elimination. I think I stop here. Over to you, Shobha.
Thank you very much, Dr. Baum, and you have really impressed upon the importance of, from what all you have said, local action, which involves socially equitable and ecologically sustainable interventions and actions. And that is what development justice is about, where we say we are not leaving anyone behind. And you so very rightly said that what is the meaning of reducing stigma? There should be no stigma. And for that, engaging the non-TB community is important. I always felt, if as a person, I'm part of the community. And community is consisting of many people with many health issues, many comorbidities, or healthy lives, but I am part of that community. HIV or no HIV, TB or no TB. So I thank you for insisting upon that, and thank you for putting the importance of local action and local leadership at that political level, and that will translate into national goals and national targets and achievements. Thank you very much, sir. Thank you for being there with us the whole day today. It has been really inspiring for us. And thank you. And now I invite Professor Koji Naidu, who's one of South Africa's leading scientists. She's Deputy Director and Head of the TB HIV Treatment Research Program at the Center for the AIDS Program of Research in South Africa, or what is more commonly called CAPRISA. So over to you, ma'am.
Thank you very much, Shobha, for your introduction. And thank you very much for inviting me to present at this wonderful forum. I deeply appreciate it. Thank you. I just want to make sure my slides are projecting.
Yes, we can see it. Yes.
You can see it. Is it in presenter view?
No, not yet.
Not yet. Okay, fine. Can you see it now?
I can't see it. Yes, now, yes.
Okay, fine.
Perfect. Yes.
All right, wonderful. Thank you. Good day, good morning, good afternoon, colleagues. I have a few slides to share with you, describing what I know about and what the evidence tells us around preventing TB for people living with HIV. I will cover very briefly, and I know this audience doesn't really need an introduction, to the intersecting HIV and TB epidemics. I will place for you where TB prevention therapy strategies fits in the landscape of novel technologies and strategies that have emerged for combating tuberculosis. We will reflect on evidence from clinical trials that support the various TPT strategies that we now have available, and I'll end with some summary and concluding points. So it is no surprise to us that TB and HIV overlap in the global map of the world. South Africa is number one for HIV. We hold about 0.9% of the global burden, the global population. However, 17% of people living with HIV reside in South Africa, 17%. We also hold about 3% of the global population of tuberculosis. When we look at India, the global burden of TB is around 27%. And HIV prevalence globally, India is ranked number 2. And similarly, you could see in the top 10 countries of the world by HIV prevalence, there is a substantial number of patients that also have tuberculosis. In the global landscape, just under 10% of all new cases of TB occurred in people living with HIV. However, in my part of the world, in sub-Saharan Africa, approximately 60% of all patients are co-infected with HIV and TB. From 2010 to date, we've done extremely well with respect, not extremely well, we've seen some progress in the reduction of new TB case notifications in people living with HIV. We've also seen a reduction in TB deaths among people living with HIV. However, the reduction in incidence and the reduction in mortality is not at a rate that will enable us to meet the SDG targets or the NTB strategy targets for tuberculosis. So while we see these declines, they're not substantive enough for us to be on track to end TB in our lifetime. We know that TB remains the leading cause of death in people living with HIV, that those living with HIV are 16 times more likely to fall ill from TB compared to those without HIV. So even though among the 10.6 million people that are notified with TB each year, the proportion living with HIV globally is around 10%, right? So the fraction of people living with HIV and TB in the global level is small, but the contribution of people living with HIV that also have tuberculosis to mortality is 16 times higher. And I think that is the main issue driving us towards more effective strategies to prevent tuberculosis in HIV because of the high risk of mortality for TB in people living with HIV. And globally, we know that the deaths from TB, about 60% of those are still linked to individuals with HIV. And people living with HIV, we know, have compromised immune systems. Hence, their risk for developing active disease from latent infection is significantly heightened. The last 15 years has seen much progress in the TB diagnostic and therapeutic and TB prevention landscape. We've seen emergence of better diagnostic technologies embracing molecular tools. We've seen shorter therapies for drug-resistant TB, for drug-sensitive TB, and for TB, pediatric TB, where we can now use a 4-month regimen for treating tuberculosis in children. We've seen about 11 novel TB vaccine candidates emerge in clinical trials that are currently being evaluated for the prevention of TB infection, for the prevention of progression from infection to disease. Some of these technologies, TB vaccine technologies, are being evaluated in people living with HIV. So there's been many gains in the TB vaccine landscape that we've seen recently. And in all of these, right, we've also seen novel TB prevention strategies, novel therapeutic strategies to prevent TB. So I'm going to spend the next few slides reflecting on some of the clinical trial evidence that has emerged and what they support in terms of our strategies for TB preventive therapy. I think the most compelling data that has emerged is the use of 1 month of TB preventive therapy to effectively prevent new episodes of tuberculosis. The brief TB trial evaluated a 2-drug combination using isoniazid and rifapentine to prevent HIV-associated tuberculosis. This was a phase 3 clinical trial, a randomized study that looked at whether it is efficacious and whether it is safe for patients to take 1 month of INH and rifapentine and compared this to patients that received 9 months of isoniazid alone. Approximately 3,000 people living with HIV enrolled into the study and were followed up for 3.5 years. The scientists looked for new episodes of active tuberculosis or patients that demised during the course of follow-up as the primary endpoint of the study. And so in front of you, I am presenting various graphs. And you can see that the 1 month of isoniazid and rifapentine, a line in the dark blue, follows the similar pattern as the dotted red line that represents 9 months of isoniazid. And for patients, when we evaluated death or incident active TB, you can see both regimen performed equivalently. They performed in exactly the same way in preventing death or active tuberculosis. When we went on to look at patients with CD4 counts less than 250, and that's the graph in the middle, and in patients with CD4 counts above 250, that's the graph at the end, they performed very similarly. Importantly, the toxicity rates or the side effects were very similar in patients that took either the isoniazid and rifapentine compared to those that took isoniazid alone. And the completion rates of the regimen, which is something that we all grapple with in all our programs across the world, people are very motivated and enthusiastic at the start of TB preventive therapy, and the pill fatigue sets in, and then they discontinue therapy for preventing TB because it's just one more pill to take. But here they found extremely high completion rates of about 97% in patients that took TB preventive therapy containing isoniazid and rifapentine. So the study has been published a few years ago. The data has been around for a while, and it's basically telling us that for 3.5 years of follow-up, after an initial regimen of 1 month of TB preventive therapy, that the regimen was highly effective in preventing new cases of active TB disease. We go on now to look at, so how often should we offer patients a course of TB preventive therapy? Is a once-off sufficiently protective, or do we require to repeat the course of TB preventive therapy every year? So this trial that was done in several countries in sub-Saharan Africa looked at whether we administer patients with either annual or once a year repeated over 2 years, or once off TB preventive therapy, and they compared the use of 3 months of isoniazid and rifapentine with daily isoniazid for 6 months. just over 4,000 people living with HIV were enrolled into the study. And again, patients were followed up for 2 years, and investigators were looking at TPT completion rates as well as the incidence of active TB over 24 months. So how many patients had new episodes of TB that were notified during the follow-up period? I'm presenting again 2 graphs for you. The first one is telling us about how many patients, A is telling us about how many patients developed new episodes of TB. And we're comparing a single round of TB preventive therapy versus annual repeat. And you can see that the regimen in a single round protected as well as those that received it annually ×2. So a single annual course of TB preventive therapy here was found to be sufficiently protective against new episodes of tuberculosis. And then the authors then compared the efficacy of the 3 months of isoniazid rifapentine against 6 months of isoniazid only, and they found that the TPT completion rates were extremely high, 90% for the short course versus 50% for the 6-month course of isoniazid alone, and they found similar incidence rates of tuberculosis across both study arms. So the next big unanswered question, now that the WHO recommends integrase strand transfer inhibitor, notably dolutegravir, as first-line antiretroviral therapy, so how well will we do now with this new regimen that contains rifapentine when co-administered with dolutegravir? Because we know that rifapentine is a potent drug. It augments the activity in the liver to clear out the dolutegravir. And so we're really concerned whether it is safe to co-administer the rifapentine with dolutegravir for the drug-drug interactions. So the first question is, could we actually co-administer the 3-HP regimen, which we've discussed already with dolutegravir, in people living with HIV that have an undetectable viral load? So these are patients that are already on stable antivirals. They are virologically suppressed. And so this study evaluated the pharmacokinetic interaction between the rifampicin and the dolutegravir. And what they found is that when you added the rifapentine, the dolutegravir, the drug interactions were not sufficient to cause a viral rebound. Patients maintained viral suppression throughout the dosing of 3-HP. And even though the dolutegravir drug levels were reduced in the patient's plasma, the levels that were achieved was sufficient to maintain viral suppression. And there was no requirement for a dolutegravir dose adjustment when patients took 3-HP. And there was no significant side effects or toxicities that were moderate or severe or life-threatening to be related to the 3-HP regimen. So, this is very promising, providing us information on drug tolerability, on drug-drug interactions that basically support the co-administration of 3-HP in patients taking a dolutegravir-based regimen that are already virally suppressed. So the next question that needed to be answered is, so you are now initiating a dolutegravir regimen, and so your viral load is going to be high. Is it safe then to prescribe a 3-HP regimen? Is it safe for patients to take a 3-HP regimen if they're not virally suppressed? And so the findings of the Dolphin 2 trial was presented earlier this year in CROI 2024, which was also a pharmacokinetic study evaluating 3-HP in patients that were ART naive with high viral loads. And the key findings was that even though there was a decline in plasma concentration of dolutegravir, it was still sufficient to maintain viremia in patients, and that those that took the 3-HP achieved a rapid suppression of viral loads to less than 50, which was maintained during 3-HP, and the proportion of patients that were virally suppressed at 12 months were the same in those that received a 3-HP that was not virally suppressed. And so these findings are important for global public health in that they support the use of 3-HP in patients to be initiated on 3-HP when they initiate ART, even though they are not virally suppressed. So this is one step forward in helping us to get safe, short TB prevention regimen options for people living with HIV that are taking a dolutegravir-based regimen. We have to talk about preventing drug-resistant TB in patients that have HIV and in communities affected by drug-resistant TB. 2 trials released their results in the Union Conference in 2023. The first trial was done in South Africa called the TB CHAMP trial, and they enrolled patients regardless of HIV infection, 0 to 4 years, regardless of TB infection or HIV status, and then 5 to 17 years if they had evidence of TB infection, and regardless of HIV positive status. And the study basically supports the use of levofloxacin, fluoroquinolone, for the prevention of TB amongst these children that are exposed to multi-drug resistant TB within households. And I think this is an important finding given how vulnerable children under 5 are to acquiring TB from a close household family member. And this is one step forward for the prevention of multi-drug resistant TB amongst childhood contacts of index drug resistant TB patients. There are several MDR TB prevention studies underway in the field at the moment. The other 2 trials worth mentioning is the VQuin trial that also generated their results last year, showing that levofloxacin did extremely well in preventing household contacts of index drug-resistant TB patients from acquiring multi-drug resistant TB. And there's a large study currently underway called the Phoenix trial that's assessing whether delaminid or isoniazid given for 26 weeks would be effective in preventing multi-drug resistant TB, regardless of HIV status. So we need to watch that space. The WHO guidelines recommend the options that I've outlined: 3-HP, that's 3 months of isoniazid and rifapentine given once a week. 3 months of isoniazid or rifampicin given daily, 6 months of daily isoniazid or 12 months of daily isoniazid, and basically recommend shorter options where it is available and where it is feasible. The WHO goes on to recommend TB preventive therapy for children where TB has been excluded, as well as for household contacts, childhood contacts of index pulmonary TB patients. So in summary, we know that we've had several gains made in TB prevention, in better diagnosis, and in better therapeutic options, but unfortunately, TB mortality still is high, and TB incidence is still unacceptably high. People living with HIV face a disproportionate risk, 16 times higher risk for mortality compared to HIV uninfected patients. That there are multiple new strategies in TB prevention that are undergoing evaluation, that our guidelines are now offering shorter regimen for both adults and children, and there are several other trials underway evaluating TPT regimen. I do think we need to watch the TB vaccine space because it does seem to be promise both for adults and children with different vaccine technologies. And we are all here to realize a TB-free world. So thank you very much to the hosts for having this really important dialogue, and thank you again for inviting me to participate. Thank you.
Thank you very much, Dr. Naidu, and thank you for making us aware of the researches regarding TPT and the research results. The next step is that once it is approved and scientifically approved, when does it reach the people who need them? I think that is the most important next step. And the same thing, I think, will go for vaccines. We are looking for the vaccine, which will be the silver bullet or golden bullet, you can call. But vaccines lying in boxes are not going to do. I think this has come up repeatedly today. And it is vaccination which is going to help, and not just the vaccines. Vaccines are there. The TPT treatment is there. So scientists have done their work. But now to carry that forward, to take it to the people who need them, I think that is an equally important step. Otherwise, of what use is that 1 HP treatment or 3 HP treatment? But thank you very much for being here today. And now we will listen to a video recording of Dr. R.K. Sood, who's a District TB Officer of Kangra District in Himachal and Program Officer of National Health Mission. And he is rolling out the 1 HP TPT treatment perhaps in his district. He has sent his video recording.
I am Dr. R.K. Sood. I am a District Program Officer from Kangra, Himachal Pradesh. I come with a very exciting news that TPT for PLHIV is now a shorter regimen, and this 1 HP regimen is shortly going to become a reality. Within a fortnight, we'll be rolling out the 1 HP regimen of TPT for people living with HIV. We have been given this TPT to PLHIV traditionally as a 6-month regimen, but adherence to a 6-month regimen remains a very, very big challenge. Completion rates are low. So we are hopeful to start the shorter regimen of TPT, and all the new cutting-edge technology breakthroughs, as they roll in, they bring us closer to the goal of ending TB and HIV. So there's a lot of excitement among our teams that how we really get better technologies, get access to the shorter regimens. So this is one of the new things on the cards, because recently the Indian TB program has seen a lot of new innovations, new interventions. We have TPT rolled out for adults, and we have adult BCG also coming in. So all the new interventions will help us reach the goal of NTB, accelerate our efforts. So it's a really, really very, very good proposition. And I think we are looking forward to the results of this 1 HP, which should be very, very encouraging. And like in Kangra alone, we get around 100 patients of HIV every year on treatment. So we'll be able to put them on the shorter regimen of TPT. So I think that's a wonderful proposition for all of us. And with this, we'll be moving closer to the goal of NTB.
Well, that is really exciting news, and I wish Dr. Sood were present here, and so that we could share our gratefulness and also our excitement with him. And he said he himself is very excited, but let us hope that this becomes a reality in other parts of the country as well as in other parts of the globe soon. We will now listen to Dr. Rekat, Professor and Head Respiratory Medicine, King George's Medical University, and former President of Indian Chest Society, National College of Chest Physicians, and Indian College of Allergy, Asthma, and Applied Immunology. He could not be present here because he's out on duty travel, so he has sent his video recording.
Friends, namaste from India. I'm Dr. Surikant from King George and CNS for the wonderful organization of this virtual event. Tuberculosis is a major health problem of not only India, but it's a problem of all developing countries. And this is not only an infectious disease, which is one of the biggest killer in the world and in our country, as India is suffering the burden of tuberculosis in form of about 5 lakhs deaths per year. So India is the highest TB burden and having a lot of significant health problem impact on the economy of the India, on the health burden issues of the India. And if you see globally, since 1993, tuberculosis has been declared as a global emergency. And for last 40 years, this global emergency is going on. I don't remember any disease has run such a long global health emergency. So I think we have to concentrate on so many things on tuberculosis and moreover beyond the box. For example, if you want to really eradicate tuberculosis, eliminate tuberculosis or control tuberculosis, whatever you know, the SDG goals have set the target of 2023 to end TB from this world. But in India, it has been decided by Honorable Prime Minister Shri Narendra Modi ji that we want to end TB by 2025. But really are competent enough? But really are prepared enough? We really have the preparedness and capacity building of the infrastructure, of the healthcare workers, and so many other things. Now I can highlight you that what are the other problems which you have to address other than the diagnosis and treatment of tuberculosis. Now if you think of that you want to really eliminate tuberculosis from the world and from India, you have to take care of first thing, that is malnutrition. Because malnutrition has 10 times of risk developing tuberculosis. Now, if you think that you want to eliminate TB from India and from the world, you have to address the issue of malnutrition. Number one. Number two, if you really want to address the elimination of tuberculosis from the global map and in India and in developing countries, the second important thing is the air pollution. Because air pollution is also one of the biggest problem, not only in our country, but it's a global problem. And recent Global Air Report 2024 says that out of the 10 people, 9 are not taking the healthy breath. This is impure breath. So air pollution is the second factor. Third, if you really want to address the issue of elimination of tuberculosis, you have to take care of the tobacco cessation, smoking cessation. We have done a wonderful study in 2009 in our Department of Respiratory Medicine, King George Medical University, Lucknow, India, and we have shown that bidi smoking, which is the traditional smoking of the India and developing countries, and it is not known rather what is bidi smoking in the Western world. Western world knows only cigarette smoking, but bidi smoking is more harmful than the cigarette smoking, number one. And the smoking having 2.5 times of odds ratio for developing tuberculosis means the smokers are having 2.5 times higher chances for developing tuberculosis. And these smokers have higher mortality also. Briefly, if you want to have, so this is the third important point. The fourth is so many other non-communicable diseases as a comorbid condition and which are decreasing the immunity of the body. So main important non-communicable diseases are the diabetes is one, and cancer is two, and so many other diseases, chronic heart disease, chronic liver diseases, chronic kidney diseases, the chronic lung diseases. They are all the non-communicable diseases but having vulnerability for tuberculosis because of the decreased immune response. So I think we have to address all these comorbid conditions. So you cannot even imagine to eliminate tuberculosis if you don't address these non-communicable diseases. Another thing is that is correlation of HIV tuberculosis. We have done a wonderful study in 2003-04 that shows that around roughly 3% of tuberculosis patients, they having HIV incidence also, and roughly same 2.8% or so HIV patient, they are having incidence of tuberculosis also. Latest report also shows 4 to 5%. So I think we have to address, whenever we are addressing the tuberculosis, we have to address HIV also. And that's why Government of India has issued the bi-directional order for the important diseases, like when you are testing the tuberculosis, you should also HIV. You should also test HIV. When you should test HIV, you should also screen for tuberculosis. Whenever you are screening for tuberculosis, you should also screen for the diabetes. And whenever you should screen for tuberculosis, you should also screen for the tobacco and smoking. So I think these three components, now they are part of the India's National TB Elimination Program. And I would appreciate, as the chairman of the North Zone Task Force of TB Elimination Program in India, so I'm looking after the 9 state affairs of the TB Elimination Program in India. And I'm confident that these three components, which are doing routinely recording in our National TB Elimination Program of India, they can be a role model and can be a very important, you can say, advisory steps for the other countries also, important countries, that whenever you are addressing the tuberculosis, you should also think of three things, that is tobacco, diabetes, HIV. And also I would suggest fourth component is the nutrition, as well as fifth component as comorbid condition. So thank you very much for this wonderful opportunity, and I'm really congratulate again Shobhaji and the CNS for this wonderful, great.
Thank you. I think Dr. David Pagwesese is there. He's president of Society for AIDS in Africa, which is official secretariat of ICASA, Africa's largest AIDS conference, and is former Minister of Health, Zimbabwe. Sir, are you there? So please, we would like to listen from you. Dr. David. All right, we will move on to our next session. The launch of Goa Declaration and call for 100-100-100 to end TB and AIDS. And for this, I invite Tariro Kudatsa, whom all of you know very well, but I will just repeat that she's founder of TB People Zimbabwe, member of Community Advisory Panel of the Union, and Find All TB Global Call leader. Over to you, Tariro, to chair this session. Yes, Tariro.
Hello, Shobha.
Yes.
Thank you so much. Yeah, I always say when I grow up, I'd like to be Shobha. So the Chinese philosopher Lao Tzu said, I quote, "A journey of 1,000 miles begins with one step." He wasn't wrong, because you won't get anywhere unless you start a journey. CNS, through leadership of Shobha and your team, Bob, we appreciate you for the step you took, not alone, but with others, for us to reach that journey. Let me go to my remarks. Yes, we are going to validate the Goa Declaration. Dear friends, I present to you the Goa Declaration, endorsed by people from 34 countries for accelerated action to meet SDG target to end TB by 2030. And the UN high-level meeting on TB 2027 targets. To meet SDG target of NTB, we must find all TB, treat all TB, and prevent all TB through people-centered and rights-based approaches. We, the delegations from 34 countries in Asia, Africa, and Latin America, who participated in the United Against TB accelerated action towards achieving SDG on tuberculosis meeting held in Goa, India, 15 to 17th May 2024. Recognize that ending TB by 2030 is a public health and human rights imperative, as well as critical reminder to everyone on other UN Sustainable Development Goals, SDGs and targets. Let me remind everyone that what were the promises made in SDG 2030 and UN high-level meeting on TB 2027 targets. Our world leaders have committed to TB related SDG targets, which include, number one, achieve at least 80% reduction in TB incidence by 2030. Number two, 90% reduction in TB death by 2030, and zero catastrophic cost for TB affected families. In the political declaration on the 2023 United Nations General Assembly high-level meeting on TB, our leaders committed to deliver on a range of targets by 2027. These targets include, again, reach 90% of TB patients with diagnostic and treatment services and health and social support. 100% of those tested for presumptive TB to get an upfront WHO recommended diagnostic molecular test. 100% of people with TB get health and social benefit packages so that they do not face any catastrophic cost. Treat at least 45 million people between 2023 and 2027 global, including 4.5 million children and 1.5 million people with the drug-resistant tuberculosis. 90% high-risk populations, those eligible for TPT, to get TB prevention therapy, integrate TB response with other health programs like HIV, tobacco control, NCDs, mental health, alcohol control, nutrition. It is the one-stop shop that was being echoed over and over again, and many more. People from different countries will share what the Goa Declaration recommends. Over to you, Shoba, as we unpack the Goa Declaration to the participants. I thank you.
Thank you very much, Tariro. And we have a few delegates who had attended that Goa meet in November last year. And we will just read out the entire declaration and the recommendation thereof, which were endorsed by all the participants. And I think there were more than around 100 delegates who were there present on site. So we would begin with Samantha Tinse, Philippines. Samantha, we've enjoyed seeing your video in the morning, the video recording. And here you please do the honors of starting the presentation of the Goa Declaration.
Okay, sure. So while the wider scale-up of pilots of introducing new tools project, or INTP of Stop TB Partnership and USAID have shown impact in terms of finding more TB cases, and linking them to care in a time-bound manner. Prioritizing taking WHO recommended point-of-care TB screening and diagnostic tools to the people's doorstep, over optimizing existing centralized or semi-centralized or lab-dependent tools or models, which often have access barriers, result in diagnostic delays, catastrophic costs, and drop out people from the care cascade.
Thank you. You are the heroine of the day, Samantha, and you initiated what you have said just now.
Yes.
Yes, you did. We have Catherine Murambedzi from Zimbabwe.
Good morning, everyone.
Good morning.
Thank you for this beautiful meeting. I'd like to share the beauty of the Goa Declaration, what it emphasized, and what it brings to us all as people who are passionate about ending TB. I am a signatory to the Goa Declaration as a person, as a survivor of TB from Zimbabwe, and as a journalist living openly with HIV too. We have to effectively engage communities in the response to TB at every level. TB survivors and communities, the health workers, they bridge the deadly divide between existing services and most at-risk populations. Community-led monitoring is another evidence-backed method to engage communities in TB programs for meaningfully and improving the service uptake of TB services. We must listen to the people and the communities they serve. Community leadership is pivotal for demand creation and for equitable access to the full range of TB services. Phasing out upfront use of microscopy, replacing it with the WHO recommended molecular tests is the way forward. We have to increase TB testing for children with samples that do not depend on sputum only. We have to take on the other methods, these stool methods, since we know that children are not able to cough up sputum. We have to effectively integrate TB programs with other health and development programs, such as those from the HIV and the NCD community. We have to amplify harm reduction. We have to even urge those who smoke to stop. We also need good nutrition if we are to fight TB. The community-led monitoring is evidence-based because the communities are the people who feel the pain of living in TB or taking care of a person taking TB medication. The Goa Declaration emphasizes the need to listen to and involve communities in the TB response. TB is not a disease to be managed in the hospitals alone. It has to be taken care of in the community, in the home. We have to recognize that critical role in bridging the gap between the services of people who are most at risk. By that, we have to be bringing the service to the people. With the new diagnostic tools, this is possible to bring the hospital services to the people. So the Goa Declaration speaks on the impact, speaks on the implementation, speaks on the activities. It speaks on how we can work together collectively in our diverse backgrounds to end TB. Thank you.
Tarit Chakrabarti from India.
Thank you, Shovaji. So before going to my point, before going to my speech, I must say, good afternoon, everyone. I want to begin by expressing my sincere gratitude to President Mona and Secretary Daksha of TB People India. They asked me to attend to the Goa Declaration program in May that was United Against TB, Accelerated Action Towards SDG Targets which was a tremendous honor to me. This has not only allowed me to learn from so many accomplished individuals, but it also gave me the courage to stand before you all today as a TB survivor from TB People India, as well as the people living with HIV. Yes, I am co-infected. I am grateful to Shobhaji for this opportunity to deliver my speech with such a distinguished audience. Now let's allow me my speech to you all. Screening everyone for TB regardless of symptoms in high burden settings with an alarming number of TB prevalence surveys showing that a large number of people with TB are asymptomatic. It is imperative to find all people with TB early enough by deploying evidence-based tools like ultra-portable X-rays for population-wide screening and confirming those with the presumptive TB on molecular test upfront. Linking all of them to care with all help stop the infection spread. Increasing use of mobile outreach clinics for population-based screening with help. Where appropriate, intensified TB screening of everyone should be done in private sector facilities too. Making same-day test and treat a reality of everyone with TB, including key and vulnerable population. Optimally leveraging upon public-private mix approaches to engage all healthcare providers in TB response should be prioritized. So from my speech, the key points that emerge from my speech: ultra-portable X-ray machine is necessary to be used for mass screening through which everyone can be screened for TB. A rapid diagnosis. Those who come out suspicious will be confirmed through a molecular test. Improve access to care. It is those who are diagnosed by TB are immediately connected to the TB care. Spreading of TB will not be happen then. Public-private partnership, it is very much required. If government, healthcare and public facilities work in collaboration, then a large number of people can be reached for TB screening. So thank you for your time and consideration of this approach to TB screening. Thank you so much.
Dr. Tin Maung Thwe from Myanmar.
Hi everyone, I'm Dr. Demetri from Myanmar. In Goa Declaration, we also emphasize on the drug accessibility text, that is ensuring that universal and upfront drug susceptibility testing, that is DST, is a reality for every person diagnosed with TB. Doing universal DST will also increase diagnosis of drug-resistant forms of TB, prevent the spread of drug-resistant strains, reduce human suffering and untimely death. It will also reduce diagnostic delays and catastrophic costs. We appeal to the world leaders who will meet at the United Nations General Assembly high-level meeting on antimicrobial resistant AMR to scale up response to drug-resistant TB. Following up with those who are cured of TB or who have completed their treatment with regular screening as per the guidelines. Tapping into extra budgetary resources to fill the funding gap so that the response to find all TB, treat all of them, and prevent transmission is fully funded, along with the TB research and development for new, safe, and effective tools. Thank you very much.
Thank you. Nurul Islam Hasif from Bangladesh.
Thank you, Shobha. First of all, I apologize that I am not in a proper place to speak from because I had programs from the morning and I could not go to my office till now. So, but thank you again for inviting me. Now I will read out part of the statement. Just 1 minute, okay. So, People-centric, rights-based, and gender-transformative pathways are a bedrock to roll out TB-related screening and diagnostic tools, treatments, social and health support, and prevention services. Ending all forms of TB stigma and discrimination is vital, as it is a major access barrier and violates human rights. TB stigma, intersectional stigma, and self-stigma, and all forms of discrimination must end. Engaging journalists and other media actors in TB responses as equal partners is important. Communication between media, TB scientists, researchers, survivors, advocates, program managers at all levels, other stakeholders will help to keep them informed, involved, and supported. Media should help increase accountability and transparency in TB responses on the ground. Simplifying TB science and TB response in a language and manner which connects with message is important. Thank you.
Thank you, Nurul. Kalpana Acharya from Nepal.
Thank you, Shobha Madam, once again. I'm going to present declaration number 6, preventing all further transmission of TB. TB treatment is prevention as possible as people with TB of the lungs who are on effective treatment soon become non-infectious. It is also equally important to make the entire range of TB prevention methods accessible to people, such as TB preventive therapy, TPT, tobacco cessation, quitting alcohol or other addictions, preventing and controlling NCDs, nutrition, infection control, among others, making TB preventive therapy available for all eligible people, such as contacts, people living with HIV, among others, in whom active TB disease is bacteriologically ruled out. Leveraging contact tracing through intensive screening among household and other close contacts of bacteriologically confirmed cases vital. TPT must be made available along with full support, including counseling to complete the therapy, ensuring infection control practices in healthcare settings, communities, and homes are fully implemented. Thank you. Thank you so much.
Thank you. Zarina Jilo from Zambia.
Hey, greetings, everyone. This is Zarina from Zambia. I attended the GOA meeting. I also signed up to the declaration. One of the resolutions was dealing with the biomedics of TB treatment. And the GOA declaration has some statements on this. It talks of reducing delays in translating scientific achievements into public health gains, roll out of the existing latest TB screening and diagnostic technologies, latest treatment regimens, TB prevention methods, among others, must reach everyone in need everywhere without delays. Eliminating delays in converting scientific breakthroughs, such as point-of-care molecular diagnostics, ultra-portable X-rays, new treatment regimens, into public health gains is vital. It will also create a pathway for rollout of upcoming health technologies, such as new TB vaccines, if found safe and effective, supporting governments to roll out latest treatment regimens, such as 1-month therapy for TPT, 4 months for drugs acceptable TB, and 6 months for drug-resistant TB. I submit.
Thank you. That was the Goa declaration. But along with the Goa declaration, we also had the call for 100, 100, 100 to end TB and end AIDS. And I'm just reading out that call to you, which came with the Goa declaration. If we are to end AIDS, we have to ensure that along with 100, 100, 100, that is 100% of people with HIV know their status, 100% of people with HIV are on life-saving antiretroviral therapy, and 100% of them are virally suppressed. We also have to ensure that no one suffers or dies of TB. We must ensure that 100% people with HIV know their TB status on an ongoing basis. 100% of those with active TB disease are treated with medicines that work on them, and 100% of them are using a full range of appropriate combination prevention options to stop further spread of TB and HIV infection. Also, 100% of those people with HIV who do not have active TB disease must be offered TB preventive therapy, or TPT, what we call, to reduce the risk of latent TB to convert into active TB disease. Treatment is also prevention in case of both TB and HIV, as it stops the spread of infection soon after initiation of treatment if medicines are effective. Additionally, we must advance stronger action towards end hunger, end tobacco, end alcohol, prevent diabetes, prevent NCDs, and other risk factors associated with TB. Zero catastrophic cost, zero HIV and TB stigma and discrimination must be a reality for all. So that is the call for 100, 100, 100 to end TB and end AIDS. We would now hear a video recording from Sriram Natarajan, CEO and co-founder of Molbio Diagnostics, on taking Goa Declaration forward to accelerate action towards ending TB. Sriramji is traveling at the moment, otherwise he would have been there online right now.
This is Sriram Natarajan, Director and CEO, Molbio Diagnostics. I was privileged to be part of the 3-day-long intensive deliberations by participants from over 30 countries who discussed about finding all TB to end TB. Clearly, the need for point-of-care diagnostics was spelled out, and the experiences of various countries was discussed using platforms like TrueNat from Molbio and GeneXpert from Safid. The need for primary and community level engagement, especially for giving access to diagnostics and to treatment, was also discussed extensively. This has resulted in a consensus document called the Goa Declaration. I strongly support taking this declaration forward towards ending TB. Thank you.
Thank you. Tarino, is Dr. David there? Dr. David, former health minister of Zimbabwe.
Hello, Dr. Pare, are you in?
Dr. David Parirenyatwa, sir, are you there?
I'm here. You are in fair now, but it's like he's
Okay.
dropping in and out. He's
All
in.
right.
He's in. I can
Okay.
see him.
Dr. David, please unmute yourself. Dr. David is the president of South Society for AIDS in Africa, which is the host of the largest AIDS conference in Africa, International Conference on AIDS and STIs in Africa, ICASA. ICASA and SAA are also the co-hosts of this AIDS 2024 affiliated independent event today. Dr. David, we really want to hear from you. Just in case if you come back online, please do let us know. So, meantime, we wait for Dr. David. We have Michelle Warren. Michelle Warren is a known person who has been advocating since several years, my friends. Those who have known Michelle Warren and AVAC, they know that Michelle Warren has been the force behind the argument that we need to convert the scientific outcomes of research, of prevention research, into public health gains. So, for instance, when I met him first about 25 years ago, he was working with female condoms. Female condoms were approved by US FDA in 1993. This is 2024. Have they translated into reduction in HIV, STIs, unintended pregnancies in our countries, in our communities? Those are the questions which Michelle Warren has been asking in context of pushing governments to eliminate the delays, which take so many years of, when scientific outcomes happen, when molecular diagnostics came in, when portable, ultra-portable or battery-operated molecular diagnostics came in 2017. This is 2024. Have we really translated those outcomes of 2010 when Gene Expert was there, 2016-17 when TrueNAT battery-operated thing was there, you can take it to the communities, ultra-portable X-rays came up with so many other, approved by the WHO. Have we really taken those to the community? Why is there a delay? And he has been a real big force in calling for combination prevention, so that there is a range of things we can do to prevent HIV. Treatment is also prevention. Along with that, there is a whole range of prevention options, and we need to continue to expand that range and make it accessible to the people. Same goes for tuberculosis. We heard that treatment is prevention, first of all. Secondly, obviously, there is a lot of things we can do to TPT, the TB preventive therapy, as well as we heard about tobacco control, nutrition, ending hunger, ending alcohol use, so many other things which we can do to prevent the risk of TB as well. So with these words, Dr. David probably is finding it difficult to connect as of now. We will listen to Michelle Warren. Just a minute. Sorry for this technical glitch. I hope it works.
Good afternoon or good morning. My name is Mitchell Warren, the Executive Director of AVAC, and I so wish that I were with all of you in person to meet and talk and debate and plan for the future together. But unfortunately, I'm not, and I'm not even able to join remotely in real time. So you're getting a recording. But I'm so grateful to CNS and my dear friends there to organize this meeting and to bring everyone together to talk about the future of HIV and TB. I'm going to focus mostly on HIV, but so much of what we know and do and think about HIV is informed by TB. It was once said that history may not repeat itself, but it rhymes a lot. And I think many of the issues I hope to discuss in the next few minutes relate as much to HIV prevention and treatment and ending that epidemic as they do to TB and ending that epidemic. We have targets in this world for TB, for HIV, for malaria, for pandemics, and very often, most often, if not always, those ambitious UN targets don't get met. They hopefully drive policies and programs and investments, but they rarely actually achieve the success that we seek. Here were targets that were established back in 2014, 10 years ago, for where the world needed to be by 2020, to be fewer than 500,000 new infections per year. And we missed that target terribly. And you can see above some of the ambitious desires within the model to tell us we could end the epidemic and what was actually implemented. And the gap is huge, and it gets larger over the last 5 years, generally and particularly because of the SARS-CoV-2 or COVID pandemic. And yet, UNAIDS rightly put out more ambitious targets in 2020 for where we needed to be in 2025. The good news is these new targets do recognize a much greater centrality around policies and behavior change and the individual at the center of the epidemic, as you can see in this graphic about people living with HIV and communities at risk at the center. that was not the case in 2020. But we still have a long way to go to come even close to what are now these 95, 95, 95 targets. But importantly, the recognition that it's the numbers we leave behind, the 5s and the 10s, that are our biggest problem. This is a slide, and Bobby knows it well, that I've been working with for 20 years, where in HIV we seek to develop a method mix in HIV prevention, not unlike what's happened in contraception. And you can see that up until 2006, we had done very poorly. We had male and female condoms and behavior change, but not much else. Unlike contraception, where you see a very robust set of methods in the mix. The good news, 15 years later, we now have a much more robust method. And you can see a lot of activity in HIV. The tech marks are products in black that are actually approved, oral PrEP, of course, voluntary medical male circumcision. We now know that U equals U, that undetectable in treatment is untransmittable, and other things in red that are in development. And I'm going to talk a bit about some of these coming up. But I want to make one really important point here. We may now look as robust in HIV as we do in contraception, but when we developed this graphic originally in 2006, the idea was to do even better than contraception, because although contraceptive research and development has brought dozens of methods over many years of investments, many people walking into a clinic are only given 1 or 2 of those options. They don't actually get that full method mix. So our task in HIV is not only to develop all of these additional options, but to deliver them at scale, with speed, and most of all with equity to actually have impact in the epidemic. This gives you a quick snapshot of what's emerged as we now have this range of methods available. The vaginal ring and injectable cabotegravir now moving into implementation studies and programs. And of course, next generation products, and I'm going to spend a little time talking about those. But I want to first do a quick language check, because we talk all the time about biomedical options. And I want to make the point that options are critically important. They're the fruits of science. That's what R&D, the research and development process, does, developing additional biomedical options. But translating those into choices for people is what our job is as public health practitioners, not just to develop, but to deliver. And we need to make sure that those products reach people as viable choices. And that's when things get messy. It's about policymakers and donors and governments and implementers to make that mix available, accessible, and affordable. That is the challenge ahead of us as we get more and more of these methods in the mix. We have more options, but are they actual choices? And why does that matter? Well, we know in contraception that choice matters because when we actually increased contraceptive availability in the clinics, in the community-based programs, not just the R&D pipeline, you can see that contraceptive prevalence actually went up. But what about HIV? Well, the important news is that we have voices for choice. These are graphics from 2 partners that we work with, a women's group in Southern and East Africa who have focused on the Choice Manifesto, and a global key population group who have made these demands, because the voices for choice are real, wanting to translate what we see in contraception into what we can see in HIV. And we now have data to back it up. Many of you may know from the retrovirus meeting, so-called CROI, that happened in March. There's a study that's been going on for a number of years in rural Kenya and Uganda that looked at a study called SEARCH that first looked at expanding testing and treating, and then introduced PrEP. And PrEP was seen as lowering the incidence in the communities that had access to PrEP in addition to treatment. And this was data from 3 years ago. But what's most exciting is what came out at CROI this year, 3 years later. After expanding treatment in PrEP, they then began an additional study to randomize people to a dynamic choice arm. And in blue, you can see the uptake of any prevention product, any coverage, in the arm of the study that was given a choice between oral PrEP, injectable PrEP, and oral PEP, compared to in orange, the group that was just the standard of care, which was basically PrEP in the clinic. And what you can clearly see is that more people chose something in blue than in orange on that top left. On the top right, you can see that when people were given the choice, there were no infections in the dynamic choice arm, and an incidence rate of about 2% in the standard of care arm. Clearly, choice mattered. But perhaps the most important thing from that study was what's in the bottom slide, and that is that not everybody chose cabotegravir. While injectable PrEP was chosen by well over half people, Many more people also began to choose oral PrEP, and they add up to more than 100 because people could switch between methods. That compares to only 20% of people who used PrEP in the standard of care. Clearly, choice matters. So how can we make that real? Well, one way to make that real is to recognize that no biomedical option is only biomedical, whether for prevention or for treatment, whether for HIV or for TB. These products exist in behavioral and structural context. And if we don't address the behavioral and structural context, then the best biomedical product goes unused. We have all lived through 4 years of the COVID pandemic. We know what happens when great products get developed, vaccines, COVID therapeutics. If they don't get used, they don't have impact. And one of the polio vaccine developers many years ago now said, a safe and efficacious vaccine that sits on the shelf is neither safe nor efficacious. So biomedical products that sit on the shelf don't actually have impact if we don't deal with the behavioral and structural issues. So while my talk is very much around the around the biomedical, I don't want anybody to think that any of these methods, whether HIV PrEP, TB drugs, which is actually getting far easier now, thanks to advances, a future TB vaccine, none of that can happen if we don't address behavioral and structural issues. And one other piece to highlight, of course, is that we live in a parallel universe very often between the providers and health systems and users. The idea is that, health systems and providers want to know who's at risk or who's infected and how do we get them treatment or prevention. And it's all about finding those people. But that's not how individuals operate. Individuals, particularly in HIV, but I would argue in TB as well, are thinking about, what do I want? And very often that's about their relationships, their safety, well-being, their pleasure, their sexuality. And it's only later that they begin to navigate in, hopefully, to thinking about HIV prevention. Our job is not to help individuals fall into our system, but rather we need our systems to adjust to the people. And importantly, you'll see there are two elements of choice. Choice both in product, but also choice in terms of where I want it and from whom I want it. So choice matters on multiple levels. And I will just say that while we developed biomedical products around the pathogen, around the HIV virus, or around the spike protein in COVID, or around tuberculosis as a pathogen, we need to design the programs around the people. That's what matters. And that's how you get to impact. We actually did a study in South Africa over a number of years, looking at user-centered design with young adolescent girls and young women to understand their thinking about sexuality, about HIV prevention. And perhaps not surprisingly, they're not thinking about their risk or about adopting safer sex behaviors. They're not thinking about HIV. They're not thinking that I'm demographically a young woman in South Africa. They're thinking about what's relevant to me. What habits fit into my life? What relationships do I want? What are my needs? What is the ecosystem in which this works? And what are the options that I want? And that's how we need to design programs going forward. Of course, over the last 12 years, we've begun to learn a lot about HIV prevention because of PrEP. And you can see here very limited uptake of PrEP. And I'm sad that India, which still could benefit so much from PrEP, is in one of the colors that show very low uptake of PrEP. But it's growing, and you can see that just in the last 3 years, it's beginning to grow. But only 7 million people in the world have ever even initiated PrEP at some point. That doesn't mean they've continued to be PrEP users. And it's important to note that the global target for PrEP is about numbers of users of safe and effective products, not how many people initiated it once and maybe didn't continue. So we have a lot of work to do. And while we do need to scale up oral PrEP, we need to also think about this pipeline of products. This is the timeline that shows products, the vaginal ring and injectable cabotegravir in the first half of this, and you can see a lot of activity to move these products into programs. But just 2 weeks ago, you will know that Gilead Sciences, the company that makes a number of antiretrovirals, has been studying lenacapavir, this other injectable, this one every 6 months, as opposed to cabotegravir every 2 months. And the Purpose 1 trial of cisgender women in East and Southern Africa showed a remarkable result that the group that got lenacapavir had no infections in the trial. Now, we don't yet know the Purpose 2 results. They'll come later this year. And it will still be a year or more for the data to be analyzed, to be reviewed in peer review, to go through regulatory guidance. But it tells us that we may soon have another very potent product. At the same time, I want to call people's attention to this lighter purple of a product called MK8527. This is a monthly oral tablet that Merck is developing. It's in a phase 2 trial, and it could next year go into a phase 3 study. And then I'm very excited by a product that we work on called the dual prevention pill. This is the combination of oral PrEP with combined oral contraception that we know many women want a product that meets both of their sexual and reproductive health needs, HIV prevention and contraception. We certainly have it in male and female condoms. We may soon get it in the dual prevention pill. This could come into the market sometime next year. So this is a very dynamic and exciting place. But we have typically moved far too slowly in moving science into impact. And you can see at the top oral PrEP where we got the evidence in 2010, and more than 10 years later, we really only began to see the scale of the program. You can see with the dapivirine ring, we knew in 2016 that it was safe and effective, and you can see how long it's taken us, not much better than oral PrEP, years post-efficacy to move into recommendations and to product introduction. The world has moved faster with cabotegravir. In the midst of COVID, we got results of cabotegravir, and you can see that approvals happened more quickly, both the first approval as well as African approvals. And I'm very happy to say that generics right now, there are 3 companies in India that now have licenses for generic cabotegravir. They will only get to the market around 2027. So we still have a few years to wait. But you can see that it is happening faster than it did with other products, but it's not fast enough. It is not fast enough to keep pace with an epidemic that does continue on despite global targets, despite our desire to be done with HIV and AIDS. And again, I would say the same thing about TB. We had one of the newest regimens with TB, with the advance of Protominate a few years ago, but it's still moved too slowly into the real world. How can we go faster? This just zooms in a bit on lenacapavir, the product that just 2 weeks ago, we got that nice green star of super high efficacy. But how can we make these other icons go faster? And that's the work that a number of us are involved with funders, with civil society, demanding and driving change. I said earlier that no biomedical product exists on its own. It's all about the behavioral and structural issues. And I want to just make the point here that no one product is going to solve for all of the challenges. And we need to think about these products across a number of considerations. You know, yes, we saw in the lenacapavir study just 2 weeks ago, very high efficacy and great dosing and duration. But how are we going to deliver an every 6-month injection? Do people want it? Is it discreet enough? What are the side effects? Do I have to train providers? How do I create demand? No one data point is the answer. And while I certainly am very excited about the lenacapavir result, clinical trial results don't end epidemics and prevent infections. It's when we address all of these in combination that we do that. And no one product can do it. It's about building programs that can deliver condoms still because we need them. And remember, they provide triple protection: HIV protection, contraception, and STI protection. We need different products. We ultimately need a vaccine. Every product needs to fit in and be considered across this range of issues. And we certainly, most of all, don't know the cost yet of lenacapavir. So a lot of unknowns and a lot of things we need to consider in the months and years ahead. And as we do that, again, this is related to both TB and HIV. It's not just the user at the center, although that's most important, but it's often about those who choose, those who use, and those who pay the dues. And very often the people who use don't get to choose. The program or the health provider, the physician, the Ministry of Health, they decided. And very often, particularly in countries that rely on donor assistance, they can only do this work if funders invest. And if the funders don't want to invest in lenacapavir or the dapivirine vaginal ring, then we don't actually get a user those options. So it's those who use, those who choose, and those who pay the dues. And we have to know that we have to balance across all of these issues. So what do we have to do? And again, across TB, across HIV, we have to continue to fill the product introduction gap, accelerating time to impact, creating demand for products, and differentiating how we deliver products for both treatment and prevention. But even with the advances of Pritominid and the BPAL regimen, even though the first phase 3 study of a TB vaccine in the M72 vaccine trial is taking place right now, even though we have some glimmers of hope, our product development gaps remain. We still need additional methods for TB prevention, for TB treatment, for HIV treatment, for HIV prevention. And we've got to work simultaneously to fill the gaps in both areas. If we do one and not the other, we're not going to create the sustainable, durable end to either TB or HIV. That's what combination treatment and prevention has to look like. There are a lot of resources here. I'm going to share the slides with CNS. I want to thank you all for taking time to be part of these conversations, because we know that it takes a global community to move this work forward. Advocates, researchers, policymakers, funders, and we really want to work with all of you to make that happen. I have a lot of acknowledgements, a lot of thanks to a great set of colleagues and donors to make this work possible. And I look forward to seeing some of you in Munich at AIDS 2024 and to work with some of you in other settings outside of Munich. But thank you all so very much and have a great meeting.
Yes. Thanks to Michelle Warren, and thanks for reiterating that it's through cooperation we can achieve a lot. And before we move to the concluding session, I just want to take a pause. Today, 700 people logged in over a period of 12 hours for which this event went on in this affiliated event of AIDS 2024. That is the power of 35 organizations joining hands and coming together in the spirit of collaboration and partnership to make this happen. Thanks to each one of you. Together we can. And now we move on to the concluding session, the way forward. What needs to change to keep the promises? Let's think. I think I mentioned this earlier today also. Do vaccines save lives? Or does vaccination? When we talk of vaccines, we talk of a product sitting on the shelf or inside a box or inside a fridge. When we talk of vaccination, we talk of the vaccine getting into the body for which it was made. We talk of the entire journey or process from research and development, from getting the product vaccine, and its equitable and socially just rollout, ensuring that no one is left behind when it comes to vaccine preventable diseases. We talk of accountability. We talk of everything we should when we focus on converting scientific breakthroughs into public health gains without any delay. I think Michelle Warren has mentioned this several times in his presentation, and rightly so. If every life matters, if all lives matter, then we should better ensure equitable rollout. That is why I believe vaccines may not save lives, or biomedical products may not save lives, if they are sitting on the shelves of rich nations and getting wasted when expired and thrown away. That is what happened in COVID vaccine, when expired vaccines had to be thrown out. Why did these vaccines not reach the arms of people in low and middle income countries? Same questions challenge us in TB and HIV context. Firebrand HIV and TB activist, excuse me, Tariro Kudatsa asked us earlier in this session, what about accountability for 10.6 million people who suffered from TB disease in 2022? Why did 1.3 million people were newly infected with HIV in 2022? Why did 1.3 million people die of TB in 2022? Why did 630,000 people die of AIDS-related diseases? Why 167,000 people died of TB among those who were co-infected with HIV? Why, and why? Let's just explore how we can convert all scientific breakthroughs in TB and HIV context into public health gains and in an equitable and socially just manner. We will hear more from our three keynote speakers for this concluding session of the day. I first invite Dr. Raman Ganga Khetkar, the CG Pandit Chair of Indian Council of Medical Research and former head of epidemiology, ICMR, and director, National AIDS Research Institute, ICMR. Over to you, sir.
Yeah, Dr. Ganga Khetkar, yeah, you are.
Yeah, I forgot. I'm sorry. One second.
Yes, sir.
Yeah, what I'm going to, one thing which we have to realize today, we had a rich discussion. We had different kinds of thoughts, some that made us think that the future is very bright, some that tended to reflect on where we are and perhaps ask us as to what we should be doing. Now, if we try to look at HIV TB interaction, one thing which becomes very apparent, I don't need to explain more to this learned crowd, that incident infections of TB perhaps would be reduced with the ART coverage, but fostered by the proportion those who fail on ART. The vulnerability of TB, even if we control AIDS, the vulnerability of TB continue to exist even if we achieve 100% detection coverage in HIV programming. Now, when we think in terms of TB that is occurring, whether globally or in India, we realize that the HIV TB incidence is fairly high, mortality is also high, and also that the number of people who are already on ART with HIV, who are HIV positive TB patients, that also is fairly high. Now, if you look at what has India, one second, I'm trying to, 1 minute. Okay. What India has achieved. We say that our achievement in terms of HIV TB screening, the screening that tends to occur in ART clinics, is extremely high in terms of proportions that you could look at. You also see that whether it is ATT initiation, whether it is CPT that is provided to them, and the ART initiation, all of them continue to be higher. And we say that 4S screening is done every month, but we don't know certain things. What is the impact of those who are receiving multi-month suspension under differentiated care? So the person is going to come every 3 months. Now, if he develops TB, we would perhaps detect it fairly late. That's something which we have to remember. And we do not know its impact on TB also. Oh. Then you look at the trend of, the trend of retention, ART initiation, retention, and LFU that you see in India. What does it tell you? It tells you that retention is improving, loss to follow-up is also declining.
का है मतलब वो ठीक है कि वो
There's something I'll have to do to that anyway. When you look at ART uptake, certain interesting points emerge. If you look at ART uptake, currently we have in India close to about 1.7 million people who are receiving ART in the ART centers. But you look at new case contribution, that disturbs you a lot, because if you look at that, you suddenly find that is 9.6%, which means the number of new cases is also significantly high. And one has to probe those areas as to why HIV is spreading still in a significant way in a country like ours. The situation may not be different elsewhere as well. When it comes to 12 months retention rate, our retention rate is 81.2%, which means I'm losing a larger proportion, like almost 18 odd, 19 odd percent people at 12 months after initiation of ART. If I take out that number, what does it show you? It shows you close to 9% of people also appear to be lost to follow-up from the original pool which was receiving antiretroviral therapy. Now, of them, most of them may have gone to private sector because the cost of ART has come down dramatically, but we don't know that proportion. But if it is not, then what is its impact on TB? I don't know. We have no idea, because some of them may have already failed, some of them may have died, but TB continues to remain a major cause of death among those who are HIV infected. And therefore, we also need to focus on these populations and try to prevent occurrence of these events per se. Now, prioritizing intervention to diagnose and link to ART in a concentric epidemic of HIV as we see here in India, it sounds relatively easy. But for effective virtual approaches to detect and link them, those that are high-risk groups, those who perhaps are part of that concentric epidemic, you will find it difficult to link them. And if that is the case, intensification of strategies to reach them are going to become important if we want to reduce the load of new infections that continues to be challenging for us. It needs multi-component prevention. And like Michelle said, if you talk of multi-component prevention, you find that we had PrEP, we wanted to start PrEP, but the investment that is required is also considerably higher. And the result is you find lesser emphasis is given towards provision of such activities where finances are largely required. And this may remain as a major issue post-COVID, because our expenses on health went up dramatically high during COVID. But all this together, looking at the coverage of ART, the likelihood of improving or enhancing the strategies, you will find that it raises a specter of elimination of AIDS as a feasible target. But still TB will continue to daunt, because if TB is present, these cases, these persons who are receiving ART are likely to continue to be at risk given their adherence levels. Now, if you look at TPT initiation, you suddenly find in India that intensification, if you look at different states, there is a diversity or heterogeneity that you see in terms of the proportions that have been put on TPT from the ART center. We need to look at this little differently. We have to try and intensify the focus on state performing below par. And that's an important issue. The program has to be dynamic. If we want to even globally adapt to every situation, every country has to look within, try and look at the evidences coming and try to rectify the strategies as soon as possible. The better way for TB to be controlled is to detect more TB cases. What is it that it will require? It will require intensified active case finding, house-to-house surveys using the symptoms, portable X-ray and AI tool for diagnosis, molecular test using GeneXpert or TrueNat, which is currently being proposed, and the initiation of those activities have begun in India. But the limitation will be those who are asymptomatic, extrapulmonary TB, and the challenges, especially to reach all those who are in urban slums or urban areas are going to be immense. Mainly because you will find that people would have competing, they would prefer certain things like earning money over, eating at home to get these kind of x-rays or whatever done, mainly because they may not think that is a major priority for them since they don't have any symptoms. You also probably need a machine learning tools to detect individual vulnerability for screen, and when you use it, it could be useful for screening for tuberculosis. And these could be put in handheld machines like mobile, where people could just check whether they are vulnerable, what is my score, and then they could at least come to you without being reached by the system per se. Now, we need higher proportions of people who are suspected to have TB and detected to have TB and to anti-TB treatment, but their adherence will continue to be a challenge. Now, if this is the case, we need to understand certain things from HIV. We need more of client-centered or individualized approaches if we want to improve on adherence. Now, one of the things which we used to try during treating the HIV-infected individual, especially when they were being put earlier on NNRTI-based regimen, there the risk used to be that for nevirapine, they would perhaps develop some kind of a rash, and it would tell you that it could be Stevens Johnson's. Now, how do you make? And there used to be a lot of side effects which would influence the decision whether I should continue with the treatment or not. So, what was it that we were doing? We used to call these patients in first 2 weeks to develop trust. By yourself, you take their phone number and call them and ask, how are you? It makes a lot of difference that we think about. When it comes to counseling, don't counsel only the individual, but the family that surrounds him, and identify a caregiver, explain to that caregiver well. Perhaps it makes a lot of difference in adherence. Because one must remember that whatever TB outbreak, TB epidemic that we tend to face is an outcome of the past and nothing else at this juncture. Now, if you look at numbers put on TPT in India, you find the numbers are increasing really well in recent past. Now, you use this opportunity. Now, when people come for TPT, you use this opportunity to tell them, counsel them on importance of TPT, the symptoms, the adherence. Even if you have 1 month's 1 HR package that you are going to provide to them, you should not lose this opportunity to try and talk about adherence, timely administration of this drug, bringing them in those in families. They should also come and try to discuss things with them. And even 4S can be done by the family member on exposed individuals. Why can't we involve them? Why can't these people themselves become ones who will detect perhaps suspected cases far better? Now, when it comes to LTBI management, one thing which I feel is if we are going to go for active case finding, when I go to active case finding, can I not test them for latent tuberculosis so that perhaps it will build community's trust into whatever approaches that we are adopting through health departments. Now, what is also important for us to understand? This is a slide which has been shown often today. Now, one of the things which we understand is about the risk factors. There are multiple risk factors that are there. They will require comprehensive services, these factors, if we want to provide them to the comprehensive services will have to be provided to those who are infected by TB. Now look at TB alcohol use and smoking. In India, one of the things which is happening is these people who are found to have TB, their proportions are found out, what proportion of them are using alcohol. And if they are using alcohol, they are referred to alcohol anonymous cases. But when it comes to alcohol use or smoking, we must realize that the relapses tend to be very common since these are lifestyle related behaviors. Now, in those circumstances, we need to be careful whether we will have to continue to look at these people separately through intensified service approaches per se. When it comes to TB diabetes, same thing is being seen. All those who are diabetics are at least now being referred for providing treatment for diabetes as well. Now that's something which is important. But what does this tell us? Now, if there are multiple risk factors that are there, we will have to develop some mechanism or a tool to find out vulnerability among these people and find out which are the vulnerable population groups, and they could perhaps be offered periodic active case finding services so that even if they develop at any point in time, not only at one point, you would perhaps pick them up and link them to the services. One of the redeeming things that has been done is these kinds of strategies you will not be able to apply everywhere. No, it all depends on how do you classify tuberculosis in a given area and try to look at what strategies will work. In Government of India, we have used high notification and low presumptive, and then that kind of a 2x2 tables approach, and try to look at what kind of approaches we will have to use in all these circumstances. But we perhaps also have not recognized one thing. We need to look at the maturity of healthcare infrastructure that is available in such areas. It needs a due consideration to be made. And quality provision of comprehensive services should be there in all these areas, at least for diseases or conditions that are found in the region which are associated with tuberculosis. That is extremely vital. Now, if you look at active case finding, we need to go for house-to-house surveys. But when we think in terms of going to house surveys, one question which should vex our mind: why even symptomatic people don't come to us? The demand generation is a key to enhance the quality of services. And perhaps this demand generation, which continues to be low in tuberculosis compared to HIV or for other diseases. Now, one thing which we must remember, that community mobilization, the level of community mobilization is something which is important to be done. If we increase it well, this will not happen. That's something which we have to realize. And one thing which I strongly feel, that community monitoring of programs can enhance advocacy, and it would be extremely useful because it brings in equity in power that has to come if we are to improve our own services. One can add TB to the expanded role to PLHA groups. And this is something which is feasible now at the backdrop of COVID, because they started learning those NPIs, non-pharmacological interventions, which have been best practice during COVID period. And if we include these people, perhaps you will find that the things will be far better. So to me, involvement of community is going to be the key, even for TB and for other diseases which are targets for disease elimination by 2030. Though advocacy in HIV of late is declining, but what we need to do, can PLHA groups strongly advocate together for HIV-associated diseases that include TB, hepatitis B, hepatitis C. Now, if that starts happening, perhaps they have some experience of doing advocacy strongly, and if they expand their mandate from HIV to other HIV-associated diseases, the improvement that might be seen would be dramatic. Now we go to we detect a patient. The patient is living in the family. Now, if that is the case, one thing which we need to do is this family should undergo counseling, and that's something which was important in HIV. In HIV, everybody used to get counseling if they themselves wanted it, and the importance was spelled out to them through the index case at the beginning when they were told about in post-test counseling. Especially, this would become important to remove misbeliefs that may be present. Because we have to remember, when you find a case of TB in the family, even the family reacts negatively to a larger extent because they have their own fear that I might acquire this infection. But today, as I said, COVID is a boon in disguise. We can always tell them that, like in COVID, we were using masks. You can protect yourself, but don't stigmatize, don't isolate that patient unnecessarily. And why does this become important? This becomes important because it has a potential to increase stigma over generations. Because if I learn the wrong thing, that these people can pass infection to others, I would more stigmatize them more in my mind, and that may come out in the later generations as well. Most people, we remember in HIV, we used to have one monitoring indicator, what proportion of people know about HIV and how many reject the myths and misbeliefs, which are incorrect kind of notions. But here in TB, we don't do that. If you look at TB, most of the people have heard of TB. But beyond that, do they know as much about a TB? Do they know how long the person can be infectious if he is put on AKT? Do they know that you don't need to worry about TB as much as to go to an extreme and try to isolate that individual? There are many options that are available. And if we periodically assess, like we did in HIV, we will be able to use this in communications package, and this will reduce the stigma that tends to surround tuberculosis, which can be easily handled. Now, lastly, availability of progress of implementation of all services, the numbers that we hear, they should be in public domain and should be accessible to all. This brings in transparency. This involves people into giving suggestions, and things can improve. Newer interventions in drugs, shorter drug regimens, long-acting drugs, diagnostic tests, and vaccines may come. But what is also important is that we need to focus at this point in time on enhancing quality and rigor of implementation of what is known as effective today. Thank you.
Thank you very much, Dr. Ganga Khetkar. Thank you for giving a very comprehensive update on the TB HIV situation in India, also the challenges that beset our programs and their implementation and the efforts to overcome them. And you have spoken so right to the point about patient trust, developing that trust of the patient, and counseling, including family counseling, which can go a long way in addressing treatment adherence and linkage to care. Also, demand generation through community mobilization and involvement of and using community monitoring. I think these are some very important take-home messages which we got from your presentation. Thank you very much, sir.
Thank you.
And we will now listen to a video presentation by Dr. Mario Raviglione, former director of WHO Global TB Program and currently serving as Professor of Global Health at the University of Milan, Italy, where he is the founding director of the Center for Multidisciplinary Research on Health Science. And he is also honorary professor at the Queen Mary University of London, UK.
Good afternoon to all of you. And first of all, apologies for not being live at this moment, simply because I am traveling. I'm recording this literally a couple of hours before the event. So what Shobha asked me to do, and I thank her for that, is to speak in the context of this very, I would say, very timely webinar, to speak about, as you see there, the way forward, what needs to change to keep the promise. And let me tell you that I will not just speak of TB HIV or the association between TB and HIV, but I will speak about tuberculosis in general. And before I begin, I think it's correct to just look at the current situation for tuberculosis. This is the global burden of TB, the latest estimates by the World Health Organization. And what you can see there is that there are today more than 10 million cases estimated to occur every year, with 1.3 million that are estimated to die because of tuberculosis. That's a huge number. We are talking about thousands and thousands every day. You see also the row that corresponds to the HIV-associated TB, where I would say, fortunately, 6.3% only of the 10.6 million people are people living with HIV, but they are there, and they constitute still today a major tragedy of the AIDS epidemic, a consequence of the AIDS epidemic. And as you can see there, 167,000 are estimated to die because of tuberculosis when they have HIV infection. So that is literally a big burden. And once you see this slide, you can immediately understand where the burden is particularly heavy, and that is in the African continent. You see the rates per 100,000 here in the African continent, in Southeast Asia, in India, in Mongolia, actually, in Indonesia, etc. And once you start putting these rates per capita into absolute numbers, you find what is illustrated in the pie there, so that nearly half of the people that have tuberculosis emerge in Southeast Asia, and another 18% in the Western Pacific region, with 23% in the African continent. The rest is distributed, as you see over there. Now, this is a huge burden, and if I look at the TB HIV association, that's the kind of map that WHO has produced 6 months ago, the latest one. So what you can see here is very clear, is the prevalence of HIV infection in people with tuberculosis, and that means how many are seropositive, right? HIV seropositive among people with TB, and that is what you find. You find, first of all, that those nearly 700,000 new cases in 2022 are particularly affecting the African continent, where the estimate is that about 3/4 of these cases are in fact in Africa, but and with particular, I would say, peaks in Southern Africa, in that area, so in South Africa, Lesotho, Swaziland, and so on. But that doesn't in a way spare another part of the world that is particularly affected, and that is the former Soviet countries, if I still want to use this terminology. In essence, Russia, Ukraine, and some other Central Asian area. Now, international targets have been set in the context of tuberculosis, and they have been set in a variety of different forms. So the international targets that we have today are still those of the NTB strategy, which was approved by the World Health Assembly exactly 10 years ago, and I will go through them. And then you have the same type of philosophy of targets in the Sustainable Development Goals framework, but then the high-level meetings came. One was in 2018, the second one was just 6 months ago or so, in September, actually, of 2023, at the UN General Assembly, where new targets were proposed. These are the targets, I would say the official targets of the Sustainable Development Goals, that simply speaks about ending the epidemic of tuberculosis, as well as that of AIDS, malaria, and so on, as you can see there. In the context of the end TB strategy that we, as WHO, when I was at WHO, that we took to the World Health Assembly for approval, you can see the other target that were set. An 80% reduction of TB incidence by 2030, a 90% reduction in the number of deaths by 2030, and importantly, no household that affected by TB that should suffer what we call catastrophic cost due to tuberculosis. That is more than 20% of your income that is lost because of the disease. Where are we in terms of targets? We are far away. That's the point. We are really off track. This is the incidence. So what you can see is that the incidence was coming down, incidence rate, I must be precise, was coming down very slowly at about 1.5 to 2% per year until COVID. When COVID came, then the incidence started going up, linked to, it is at least estimated, linked to the disruption of services, simply like that. And the same happened with the number of deaths that you can see on the right here, coming down a bit more quickly, like about 3%, major success in a way in the TB epidemic story. And then again in 2020, we have this increase. So the decline of both incidence and number of deaths that was promising, although slow, right, was completely interrupted in the COVID era, and we are still recovering now. We don't know yet if the incidence keeps growing. We will see in the next few months for 2023, while we know that deaths have resumed a decline. But that essentially means losing, as you can see here, losing a number of people due to tuberculosis in this period of time, and losing also 2-3 years of decline. And this is the overall picture about all the targets. So on top left here, you see the NTB strategy targets, the ones I just mentioned, far away from the targets themselves, off track, as you can see. Even the one on the percentage of people that are facing catastrophic expenditure remains at about 50%, 49% to be precise. It means that half of the families and the households affected by TB actually get impoverished because of the disease. And here you have the 2018, the rest is all the 2018 UN General Assembly targets. And what you can see there is that not one single target has been achieved, with one exception. And that is the good news, the only good news I would say in this, which is that people living with HIV have been offered and administered prophylaxis, preventive treatment for tuberculosis. And that exceeds, and far exceeds, as a matter of fact, the target that was established in 2018. So these 5-year targets by 2022 have been not reached, essentially. That's the point here, with one exception, as I mentioned. Okay, so where are we in general once we examine the situation in this way? Well, the TB burden is extremely high. TB remains the top infectious killer now that the COVID pandemic is essentially reducing dramatically, fortunately, its burden. COVID-19 had a major impact on the incidence and death trends, as I showed you. The global targets, part of the NTB strategy, are simply not on track. They are off track by far. The UN General Assembly targets established in 2018 for 2022 essentially were not reached, with one exception. The only good news really is the preventive treatment among people living with HIV. HIV-associated TB remains a challenge, although is in a declining mode, and this is good, and this is largely thanks also to the progress in the antiretroviral availability. And finally, multi-drug resistant TB, I did not speak about it, but is stable globally, and that has to be clear, is stable globally. It goes around 3 to 4% of all cases, but it represents a major burden, up to even 1/3 of cases in some parts of the world. That's a picture. Now, this is, I think, essentially undisputable. So the question is really what is holding us back? And I have been showing this slide for a number of years now, and the bottlenecks to NTB are fundamentally two: financial and political. And the two, of course, are closely related. Let's start with the bottleneck of financial inadequacies. These are the data from the WHO Global Report that show to you that out of the expected, at the time, $13 billion to be available in 2022, effectively 5.8 billion were de facto available, which leaves a gap of more than $7 billion. We are running at less than half of what the need is. If we look at research, the same report of WHO shows, essentially taken from the Treatment Action Group, shows essentially this kind of picture. Essentially half of the 2 billion, which is a very modest request actually, out of the 2 billion part of the plan, of the Stop TB Partnership Plan, out of this 2 billion, only 1 billion is available, leaving a gap, therefore, of more than $1 billion. That is the kind of situation in economic terms and in financial, I should say, terms. And here is the new global plan to end TB that finally became more ambitious. And what you can see here, the targets by 2030 in terms of financing available will go to something that is in the area of nearly $20 billion per year. So the ambitions have grown. And the same is for research, $5 billion. I mean, I always actually contested the $2 billion of the previous plan because that is a fairly small amount once you compare it, for example, of what has been made available for HIV/AIDS, or even recently what has been made available, which has not yet been estimated precisely, for COVID, or whatever has been made available for other diseases that have after all, an impact on society that is inferior to that of tuberculosis. So now we are going to 5 billion. I do believe that if we had 5 billion, we could actually progress in a much quicker way. Although my claim is that we should actually approach the $10–15 billion per year that in principle are spent for other diseases that have an impact on society that is inferior to that of TB. And what is this the result of? Why do we have this situation? We described that back in 2010 in the Lancet here, as you see. And we spoke of what is precisely in this particular paragraph. So what is holding us back, essentially? Why do we speak about political indifference? Well, it's very clearly expressed there. Funding for tuberculosis is not sufficient, is neglected, we were saying at the time. We had much less money at the time than we have today. Nevertheless, we think it's insufficient because this is not a special program of the World Bank, has never been. It's not a named priority among any UN agency leaders, okay, including the World Health Organization, does not have a special United Nations program. It is not like, for example, AIDS, right? It is not in UNICEF portfolio, has never been visible in UNICEF portfolio, although it kills mothers, children. It's not a special presidential initiative in the USA. We have had a major presidential initiative on AIDS, even on malaria, on TB, never. And does not have a strong support from the pharma industry that is crucial when we think about the development of new tools, compared to other diseases, which we listed there back in 2010. And I would say that one of the testimony of what I'm saying is that it was not even in the formal title of MDG 6 of the Millennium Development Goal number 6, which spoke only of combating HIV, malaria, and other diseases, when tuberculosis was actually one of the indicators with malaria and HIV, but they didn't even name it at that level. So 20 years ago, the situation was much worse, 24 years ago, much worse than it is today. At least this the fight against tuberculosis is visible and is now a recognized priority. I spoke about all of this, of the difficulties on about having tuberculosis much more visible in the agenda, much more politically charged, in an article published back now 5 years ago, where I said no accountability, no results. And I explained why it is difficult to advocate for tuberculosis solutions. We don't enjoy communities that are visible, that are outspoken, in the media, in the television, in the radios, and every single day put pressure on politicians. We just don't enjoy that. There are attempts, obviously, and they are laudable attempts by many community organizations to make tuberculosis more visible, but we are not yet at the level we should be for a disease that is the #1 killer. That is the point here, and that's what I expressed in this article. So what should we do? Well, I think we should go back to history now. In the last few years, when I was still actually at the World Health Organization, we organized this conference, the ministerial conference in Moscow. We came up with certain priorities, the top outcome areas of this event. And you can see there, one is advancing the response, obviously, so that is the response to tuberculosis. The second one is ensuring sustainable financing. And the third one was increment, intensify research. However, if I have to say what was the most important outcome of that conference was the recognition that we needed at the time to develop a multi-sectoral accountability framework. Tuberculosis is is probably the best example of a social disease, a disease that depends really on the societal weaknesses of the problems. It affects the marginalized, the poorest people. We cannot just face tuberculosis with in mind that we will develop the new fantastic magic tools. That's not sufficient. It's essential, but it's not sufficient. We have to act at different levels of the society. That kind of philosophy was then used for the UN high-level meeting in 2018, the very first one that was in a way conference. And this was the declaration. Declaration came the ones I mentioned before, and then with a number of different initiatives, activities, improving policies and systems, enabling multi-sectoral collaboration, the important one, if you like, promoting an end to stigma, advancing research, etc., etc. Was it successful? That is the real question. Was this big effort, unprecedented effort to raise tuberculosis at the level of major other scourges of humanity, right, including HIV/AIDS, including antimicrobial resistance, which had their own space at the UN General Assembly before tuberculosis? Well, not for a reason. If I look at what, for example, the Lancet editorial said, you can see it there, right? United Nations and tuberculosis, a missed chance. UN high-level meeting to NTB, disappointing. That was the kind of sentiment at the time, because there were some new initiatives, but not enough. We are far from having had, I would say, what was in the mind of those people who organized and planned to have tuberculosis at the highest possible political level. Now, there was another event like this, obviously, the second high-level meeting on TB on 22nd of September of 2023, so nearly 8 more so months ago. And this is what the major commitments are. So again, a new set of targets, even perhaps more ambitious. As you can see, they are 90% TB treatment coverage, right? Coverage of preventive treatment, 90% by 2027, which is only 3 years away. Coverage of rapid diagnostic tests of 100%. Coverage of social benefit and social protection, 100%. This, by the way, is a fundamental aim, that of social protection. Universal health coverage, which is the big mantra nowadays, is not sufficient for tuberculosis. We have demonstrated that still at my time, and more nowadays with cost surveys, that people that become poorer because of tuberculosis actually become poorer mainly because of lack of social protection, which means that they are not, in a way, their situation is not buffered by, for example, additional money, nutrition, and so on, that are part of social protection packages in countries that have them. And once you have tuberculosis and you are obliged to stay at home for months and you lose your little income, then of course you become poorer the next day. So without social protection, we are going to go nowhere. I think we are fooling ourselves if we believe that without universal health coverage everywhere and without social protection, we will ever get rid of this disease. So here are all the sort of commitments. If I can summarize at this point of my in a way provocative speech, well, in essence, TB reached an unprecedented political visibility. That is no question, but it is obviously not sufficient. So what should we do? I listed a few things that came to my mind yesterday night when I was preparing this. Keep pursuing commitment by governments at all levels, and I will go back to this. And make governments accountable to their citizens about a disease like this, and as part of a package, if you like, of diseases that need attention by politicians and need adequate financing from, notice this, domestic, I put it in bold, domestic sources, because most countries affected by TB nowadays are middle-income countries, and they cannot depend just on external money. So we need really to push governments to allocate their own domestic fundings. If we don't do that at national level, there is no international meeting like this one that can actually buffer or arrange in such a way that this will happen. It's really activism that has to be developed within each country. And again, as needed, external sources. So there are the poorest countries in the world that will never be able to mobilize the necessary domestic resources in the next few years. So that is where the focus on external sources should be. Pursue a whole of government and whole of society approach. So these words that sound sometimes fiction words, in reality, are the ones that we need for tuberculosis. It's a whole of government issue here. Tuberculosis depends on so many determinants, on so many other factors, that if these other sectors, like poverty alleviation, like nutrition, like, I don't know what, air pollution, etc., which are all favoring tuberculosis, if these other sectors don't reach their own targets, then we will not have a solution to tuberculosis. And we need to develop creatively new forms of activism. What we have today is not sufficient everywhere. In many countries, it is not simply there. So the community engagement remains fundamental to maintain political pressure, to argue in such a way that politicians that are at the government can actually do what they need to do. We need to also put all of this in alignment. We need to align it with sustainable development and with the SDG philosophy. It's a multidisciplinary, multi-sectoral approach that we actually need. And of course, at the end of all, is build this multi-sectoral accountability that I have been talking about and monitor rigorously what everyone does, and not just what, for example, the Ministry of Health does, or internationally what the World Health Organization does, but everyone is responsible because there are so many sectors that are determinants of tuberculosis, and they need to know that if they improve, they reach their own targets. For example, in poverty alleviation with social protection, 100%. For example, in SDG 11 on the metropolitan areas to provide proper housing to people. If they reach their own targets, then the benefits will be for tuberculosis as well as for a bunch of other diseases linked to poverty. That kind of mindset has to be developed. We wrote about this also very recently. This is an article published in March together with colleagues in the Southeast Asia region, as you see on top right there. We said more is needed to end TB. We commented in a way on the United Nations high-level meeting on TB and said what is underlined there: establishing high-level multi-sectoral bodies that report to the head of state is fundamental. This, in a way, we have to learn from the AIDS community. We have to learn from the COVID lessons. We have to learn from some other, malaria itself in Africa, for example, some other interventions that were really fundamental in raising at the highest political level the issue at stake. We need to do exactly the same for TB, but that can only be done if we develop committees, we develop commissions, you can call it the way you like, but bodies that can respond directly to the head of state, and therefore include the highest authorities in different sectors where there is need for action. We cannot just do it for TB all the time, just only for TB. We will not go far. We will be in alignment, country by country, depending on the situation, with other priorities in health and in social affairs in such a way that then we can build that kind of force that will eventually push governments to act in different sectors. And I think this is a fundamental principle that we need really to pursue. If we mobilize parliamentarians, these parliamentarians have to be given the tools in such a way that they can push for the development, for example, of these, as I said, high-level multi-sectoral bodies, commissions that report directly to the head of state. This is what happened in Africa in the response to HIV/AIDS many years ago. And we see that the results of that kind of intervention are effectively very prominent. So, I've been speaking about politics here and what needs to be done in political terms, but what about our strategy? Let's speak more about strategic approaches of more, in a way, even technical nature. Well, let's recognize, first of all, that the NTB strategy was approved by the World Health Assembly, as you can see in this document, on 21st May 2014. So we are talking about just a bit more than 10 years ago. It was developed between 2012 and 2014. So it was developed starting 12 years ago. So are we doing the right thing, right? It was then named the NTB strategy, of course, and this is the strategy that you all know. Are we doing the right thing? Is this sufficient? We have these three pillars, one devoted to the care of people, one devoted to the systems and the policies, and the third devoted to innovation and research, based on 4 principles that you can see listed there: government stewardship, engagement of societies, protecting human rights, ethics, and equity, and adapting the strategy. And we have all the targets that we have been discussing. Right. What is my meditation on that? Is the NTB strategy therefore delivering the expected result? No, it's not delivering. Simply not delivering at the moment. And the question is, why not? Is it wrong? My guess, I would say my reading is the strategy itself embraces essentially all possible strategic approaches that we have available today. It was built 10 years ago, as I mentioned, where we did not, at the time where we did not have all the molecular testing that we have nowadays. We did not have good regimens even for multi-drug resistant TB that we have today. We did not have a vaccine. We still don't have a vaccine, but there is a promising one, at least in the pipeline. But it is the intensity, the implementation, the in a way, universality of NTB that are not sufficiently pursued in any country. And we know the reasons. It's a political issue, it's a financial issue. So the question is really what to do next. Well, first, I believe we need to recognize that reaching any target in the case of tuberculosis requires the full involvement of the health sector. National programs must do what they need to do, embark, for example, on a full universal access to new diagnostics, to new treatment, etc., and having health systems that are conducive to this. But also, we need a multi-sectoral engagement, as tuberculosis, once again, has deeply rooted determinants that cannot be targeted only through the health sector. So having the illusion that by improving national program activity will put an end to TB, I think it's wrong. A national program have the responsibility to care of people, to care for people, to actually prevent death, but they cannot do it all. They need other societal improvements that will create a situation where transmission is reduced, where there is no more factor that in a way allows reactivation or activation of a latent infection into a disease. We need that, and that has to be done outside of the health sector. And second, we need, as I mentioned already, to mobilize the highest political authorities in each country, in every part of the world, to ensure what I've been calling a whole of government response to tuberculosis. So that, I think, is a fundamental type of work. This has been well understood, particularly in 2 regions of WHO, the Western Pacific and the Southeast Asia region. The Western Pacific region has a new framework, and I had the fortune of chairing the committee, the advisory committees that eventually developed the regional framework in the Western Pacific. You can see that they recognize there that we must pursue TB-specific interventions, okay, which are the essential national program functions. Within the health sector, we need to pursue the foundation of the health system that are conducive to good TB care and control and elimination, if we want to use these terms. So it's really policies that have to be TB sensitive. But also there is in green there the layer that we can call beyond health. Health beyond health, reaching health beyond health, improving the condition of people, the housing, the nutrition, and so on and so forth. So this is clearly recognized in the Western Pacific. It is equally clearly recognized in the Southeast Asia region, where the new regional strategic plan speaks the same language. As you can see here, we have activities to be done, priority activities that we all understand within TB programs. We have other activities that we all understand within the health sector, responsibility of the ministers of health and not just of the national programs, but then we have to go beyond. And to go beyond, whose responsibility is that? Is the responsibility of those at the highest level. That's why we need to convince them, and we need to create these commissions that in the end will be putting enough pressure at the level, at the highest level, at the head of state level, at the Minister of Finance level, so that allocation of resources can go. It sounds like a dream, but there are many people who think the same way, right? I can remember John Lennon's famous song, right? You think I'm silly to think this way, but in reality, there are many people that think that way. And we know that it may happen because the HIV/AIDS, for example, is a good lesson. And in more concrete terms, is the global NTB strategy still adequate, or we need to rethink or think about it or revisit it 12 years after we started thinking about the NTB strategy? And my latest kind of thinking is this, is that if we have the strategy as it is, we don't need to change those pillars, those principles. They're still very valid, but we need to make it more visible at certain level. And I would just call it at the NTB version 2.0, where we add a fourth visible pillar that speaks about the multi-sectoral contributions in a very concrete way. Some of this was included in Pillar 2, in this pillar of policies. If you look at that, there were 4 elements there. The 4th element was speaking about multi-sectoriality and therefore the need of that kind of approach. I think we need to extract that element and make it a proper pillar with very concrete type of recommendations that national program themselves could contribute to, but particularly ministers and those who are at the highest level. Fight poverty, fight for better nutrition, find a solution for the slums and the settings where tuberculosis transmission is rampant, right? Give better conditions to workers. Think about the miners and so on. Make prisons reasonable and human in such a way that there is no more transmission there, etc. All of this involve different sectors of society and of activities. And I believe this is the way to go in the future. So frankly, if I had the possibility to do it, I would just add at this point a real 4th pillar, very quick, very directly addresses these issues. And with that, I thank you all for giving me the space, and I hope that we all together can do more for this disease, because we are not there, we are off track, and we need action. And thank you so much for listening.
Thank you, Mario. And last but not the least, I welcome molecular biologist Dr. Tim France, who is a noted global health thought leader and managing director, Ennis Communication. Over to you, Tim.
Thank you very much, Hilma, and thank you to you and to the CNS team. I'm going to use some slides if you don't mind, but thank you very much for the invitation for speaking today. Let me just get my slides ready. 1 second. I think you should be able to see my screen now. Good.
Yes.
There was a session earlier which I couldn't attend called Reality Check, and I'm hoping that's what I'm going to be able to do today. To some extent, I'm using this slide, this quote, to kind of remind me that sometimes it feels like we're having the same conversation again and again. I don't mean to sound negative, but sometimes to see the way forward, to see the future, you do have to look back. So I'd like to take a little step back to look at the big picture and then to give a few options for what I think are opportunities for the way forward. If we look back at the way we've kind of looked at health in the context of development, and much of what's been talked about today in terms of TB, HIV, public health is kind of influenced at both the international and the country levels, of course. And I'd like to put kind of TB, HIV integration into this broader context, if I may. It's instructive to look back to remind ourselves how the development thinking, if you like, has been evolved over the past 30 years. And it really is 30 years. And it's worth recalling, for example, just as back at the Millennium Development Goals, which was started in 2000, that was very much about kind of framing a donor agenda, if you like. It was, the things that a lot of the bigger donor countries, the G8 in particular, really wanted to do, and that gave them a framework to do that. But these milestones over the last 30 years or so really reflect several key kind of trends and changes that I think we're we're still living through now, and it's kind of an increased focus on reduction of poverty and human development away from infrastructure type development, which was what came before that. A kind of a greater emphasis on aid effectiveness and results. A more comprehensive and integrated approach to development, as we now see with the Sustainable Development Goals, where you've got these 17 areas where we're trying to kind of address them all, the challenges in an integrated way, and a kind of efforts to include a wider range of actors, including emerging donors, as well as the private sector. But this kind of evolution was an intentional kind of way to move away from a kind of a donor-recipient model towards more equal partnerships, I think, between donors and countries, and an emphasis on really building and focusing on country-driven priorities and health responses. And we use terms like, we're going to put countries in the driving seat, we're going to focus on results and mutual accountability. In a way, for me, having watched this over the last 30 years, it was more like it felt more like a kind of a deliberate, a systemic pulling back and allowing countries to be more self-reliant. So what happened to health during this period? Let's just have a quick look at that. And I'm only going to use one chart and I'll explain it in a minute. But before I do, let me just say that obviously, we've made globally, really historic progress in terms of improving health over this entire period, and people are living longer than ever before. Child mortality is lower than it ever has been. But as Mario was saying in his presentation just now, and we've been hearing during the day, we know that we're really off track and making significant progress towards universal health coverage and other health-related targets by 2030. And we hear numbers about this, but I just think I really want to emphasize one that just keeps coming back to me. And this is according to the WHO and the World Bank's latest universal health coverage monitoring report, which says that about half of the world's population, or 4.5 billion people, are not even covered by essential health services. And I think we forget that half of the world doesn't even have access to essential health services. And partly kind of something that Mario also mentioned just now as well is that every year about 2 billion people, so let's say a fifth of the world's population, experience financial hardship as a result of out-of-pocket spending on health. So we were just looking at progress against TB targets. We've not actually done very well against some of the health targets in general. Let's just look at this graph, because I think this really reveals a lot. Let me just grab my mouse. So across the top here is, from left to right, is increases in universal health coverage. So basically moving to the right is better. And on this side, on this axis, we've got the proportion of people who suffer catastrophic health spending, poverty as a result of really large health spending. And this axis is reversed. So it's the smaller proportion as you go up. So it's better moving up. So ideally, we want the world to be moving in this direction of this green dotted line. Well, since 2000, and that's the entire period, more or less, of that development evolution that I was just talking about, we've moved in the right direction in terms of universal health coverage. That's the proportion of people who have access to essential health services. But we've actually gone backwards in terms of the number of people who are impoverished as a result of out-of-pocket health spending. And since 2015, since we started the Sustainable Development Goals, it's basically stagnated. And the proportion of the population that faced catastrophic health spending has gone down slightly. So, what we have to ask ourselves, why is this? Why is it that health services, even though we're expanding universal health coverage, we've still got half of the world's population without access to essential services, and the amount of poverty that's caused by ill health is going up? Well, there's a word that's commonly used, or has been commonly used increasingly in the last few years, a word called polycrisis. And in 2015, when we started the Sustainable Development Goals planning, or started embarking on the plan to achieve the SDGs, we really did not see, or maybe we didn't want to see, that what was just around the corner. We kind of thought that the global financial crisis of 2008 was that was it, that was done. It was in the rearview mirror. But the pace of geopolitical, economic, technological change just kept accelerating. And we entered a time, we all know, protracted conflicts of climate impacts, economic strains, mass displacement of people, and new disease outbreaks, which all placed really extreme demands on countries and on health, development, and humanitarian responses. And then, of course, in the middle of that, just after this 2019 time point on the graph we're looking at, we had the first global pandemic in 100 years. So COVID thrust, I'm just going to go to the next graph. COVID kind of thrust the world into yet another crisis on the back of all the things that were going wrong. And when the pandemic hit, borrowing money was really the only lifeline that many countries had, countries of all levels, and allowed governments to provide food, very often, housing, medical care to supplement incomes, and also help countries to roll out the COVID vaccines when they became available. So let's just have a look at this chart. How did that borrowing and the subsequent increases in interest rates affect different countries? Well, if you look at the green line, this graph shows starting in 2019, around the just before the pandemic, and projects forward by about for the next 10 years. What is the change in interest that countries are going to have to pay on the money that they borrowed? And you can see the green line, that's the low-income countries. The biggest impacts of this borrowing and the kind of economic strains that have come since then through higher interest rates are on the countries that are least able to pay. So at the very time where we're asking for more domestic funding for health, for example, we're right at a point where countries are not able to do that. So countries are paying back their loans, their interest payments have increased sharply. Well, what does this mean for health budgets? It means that kind of greater government debt and shrinking development assistance. I'll get onto the development assistance graph was the next one. Let me show you that. We'd seen a kind of a flattening of development assistance for 10 years before the pandemic, and there was a spike, but that is now increasing. This is a graph of overall total development assistance for health. That's decreasing quite quickly now. And so these kind of combined effects really kind of the risk to health and prioritization of health systems are kind of growing. They're getting worse. They're not getting better. So let me give you an example of, and I think we've got some participants from Kenya. I would like to use an example from Kenya. Because of its growing GDP, it's kind of it's getting up into the kind of the upper middle income categories for annual income for GDP. Kenya triggered the kind of transition from Gavi, the global immunization support group. So they will no longer be eligible for Gavi support. Now, there are 14 commonly used vaccines in Kenya, and almost all of them are imported into the country. So but in 2016, the subsidies for Kenya's immunization and the purchase of those is going to end, and Kenya will be expected to pay for that itself. It will not only have to fund their own vaccines, though, they will also have to compete for procurement on the open global market. And we know how well that went or didn't go when it came to COVID vaccines, that some countries find themselves last in the queue for buying the things they need. But even with the support of Gavi over the last, let's say over the last 20 years, Kenya was only able to reach, it wasn't actually able to reach the 90% coverage target for immunization. So imagine, just fast forward to 2016, and the country is expected to now fund its own vaccination program, even though it has to import everything that it needs to use. There's only one way that coverage is going to go, and that's going to be downwards, I'm sure. So at the very time that we're reaching for these targets, so for the universal health coverage and other health-related SDG targets, the risk to health and prioritization of health systems are actually growing. Those risks are growing. And I think we have to see the introduction of new health technologies and specific health programs like TB and HIV programs in this light. There's also another blind spot, and remarkably, before that timeline that I showed at the beginning even began, we kind of knew, we knew that there were, as Mario referred to just now, there are many factors that influence health that are actually outside of health, as we know, that we call the social determinants of health. And they really, health, we knew in 2008 that health was really impacted by the way that we live. And we know that most of the kind of sustainable development challenges that we face, including those impacting health, share common underlying causes. But we find it so difficult to think in integrated ways about this. We've been talking about integration of TB and HIV for 25 years. And sometimes I just think that it's just something we can't get our head around, just like we've been watching since 2008 when the Marmot Commission published this report on what we needed to do and recommendations, what we need to do to decrease the impact of social determinants. And yet we seem to have done so little about it. We're still talking about individual diseases. We're still talking about, and ignoring many of the biggest health impacts that we have. And I think that we can't think like this because we've been conditioned to think in a certain way. If you think about it, our institutions, the way we're all educated, it's all founded on thinking in silos, and we just find it completely, well, it's just it's insurmountable, this challenge of trying to think in new integrated ways. We really kind of, everything that we do is divided and subdivided into different areas of specialization that are very difficult to escape from. And I think that responses to TB and HIV are exposed to exactly the same constraints and realities. Thinking that we can make progress against TB and HIV in silos like this is just not realistic. And we have to, it's not the case that it's TB or universal health coverage, or HIV or universal health coverage. We have to think in truly integrated ways. I don't want to be all doom and gloom, and I think it's really important to look back and learn from some of these lessons, but to maybe just kind of finish off, and maybe it'll be 3 points that could help promote a discussion. Let me offer 3 possibilities and what I see as opportunities that not only make me more hopeful than I've just explained, but that I also believe are really essential parts of the way forward. And Mario alluded to this a little bit. When it comes to integrated whole of government, whole of society approaches, I really do hear and sense a growing momentum towards a more holistic and positive vision of health that integrates physical health, mental, psychological, and actually social well-being, and thinking about well-being societies that that promote health. I hear a lot of countries and organizations now and over the last few years talking about the shift from preventing and treating individual diseases to a kind of a health promotion focus on tackling the determinants of health through empowerment, through inclusivity and meaningful participation. And it's this, sometimes we call community mobilization or community participation. But it's really about giving people the opportunity to meaningfully participate and be literate about their own health and promoting their own health. And definitely that hearing more and more that health is not just the business of the health sector, but requires a whole of government approach. So that's one opportunity that I think we should really capitalize on and try to add to and build this momentum. The second one is and I'm just using this photograph to remind me of what I want to say, I really hear encouraging developments in terms of regional cooperation and South-South collaboration. I was going to say, particularly in the African region, particularly in the Caribbean, and Mario just reminded us about the kind of the regional progress there's been on TB and Sero and WIPRO. It's getting so difficult to really support countries properly from the global level that doing this at the regional level is becoming more and more important. And I mean in areas such as, you know, regional approaches to local production of health technologies, or regional approaches to harmonized policies, you know, whether it's regulatory policies, whatever they are. Countries that find themselves either geographically together or in the same situation vis-a-vis health issues can really help one another in ways that nobody else can. And of course, sharing experiences at that regional level. I would particularly, I've had more experience of seeing what the Africa Centers for Disease Control, and this is a new building in Addis, I would particularly commend their work, and just say that I don't think a regional focus is an option, but I think it really is becoming increasingly clear that it's essential. It's a cornerstone of the way forward for in all areas of health and well-being, including TB and HIV. And my final, that's my second thing that I think is an opportunity we really need to capitalize on. And my final one, many people are afraid, or they fear artificial intelligence. I don't. I see our inability to think about some of these complex adaptive issues around health priorities as a kind of a limitation of the way we work, of the way we're educated, the way we're taught to think about these things. But it may also be, and I'm quite happy to kind of admit this on behalf of everybody, that maybe it's just impossible. It's a limitation of our human minds to kind of think about things that are so complex, so multifaceted, so, you know, with so many factors influencing something, that it's actually really difficult for us to see how to put all of these things together. But I do believe that one day soon we will bring together the kind of the huge processing power, the search and retrieval capabilities, and the large language abilities of some of the supercomputers that we're all hearing about now, with the kind of the ingenuity and vision of people, so that, and it's not something that we'll ask artificial intelligence to do, but people together with those tools will be able to just kind of frame the questions and the, you know, to set the questions that will help us to identify these integrated solutions that we need. I don't think it's, I think that the solutions exist, but they're fragmented, and we just can't get our heads around how to combine them to address today's, but more importantly, tomorrow's challenges, and take the opportunities that present themselves. So that's my third opportunity, and overall, these three kind of options for the way forward really kind of must include, I think, as a priority, this holistic view of health and a whole of society, a whole of government, an integrated way of thinking about health. All right, let me stop there. I hope that's given you some food for thought. Shoba's deliberating. Can you hear me, Shoba? Are you okay? Bear with us a second. I think the back room is just organizing a discussion.
Yeah, I think hi Tim, this is Bobby,
Hi.
and yeah, maybe there is some issue there. But anyways, this is now we have really come to the very end of the long day. While Shubha comes back, So this is a space where we had intentionally requested Tim. He was very busy, and we really pleaded that please come, because we really wanted to end the session with some thoughts and some challenges. We saw that Mario also probably helped provoke some questions, some thinking. Tim too, thinking differently, if I can say that. Dr. Raman Ganga Khetkar sir was also very grateful. He was the first one to join in the morning 13 hours ago. So thank you, Dr. Ganga Khetkar, for staying along, and a very important analysis given his experience with the National AIDS Research Program, but also he was at the hem of affairs when COVID pandemic had hit us, till his superannuation from the Indian Council of Medical Research. Yes, please, Nelson. Nelson Otvoma, please. He is from NEPHAK, from the HIV network of the people living with HIV in Kenya. Nelson, please unmute yourself, and if you feel comfortable, you are welcome to use your camera as well. This is a space for discussion and space, so please be welcome. Yes, Nelson. Sorry.
Yeah, thank you very much for having me in this discussion, and I really appreciate the last three presentations and the commitments that are given, and I hope that with those, if countries really take the actions, particularly the last presentation, then we are going to say bye to TB and HIV. The comment I wanted to give is in the context of from the perspective of HIV and from the perspective of people living with HIV, we still think that it is important to emphasize the point that once you know your HIV status and are on lifelong treatment consistently, and you achieve what we call U equals U, then there is that power in warding off unnecessary TB that may come to you. It is not sufficiently evident, but if you are on ARVs consistently and correctly, then chances of you developing active TB disease is minimally reduced, or reduced generally. And we think that because that is already evidence enough and is what we know, we should not be having countries with high burden HIV also having high burden TB because of that effect. So we still need to go back to the roots of the integration and ensure that people who have HIV really can prevent and can treat TB if it occurs to them, and that then it's done very quickly. I'm saying this because in countries like Kenya, we have advanced HIV disease, and the greatest biomarker is TB apart from crypto. And this is really not very necessary, because we have the tools, we have the knowledge, and we have the medication, both TB and HIV, and that can help us then reduce the burden of TB among persons living with HIV. And in as much as we know that TB is the leading cause of sickness and death among persons who have HIV. So that window of strengthening collaboration still must exist, and it can only exist through stronger collaboration and commitment in financing for both. Thank you very much.
Yeah, thank you, Nelson. Thank you. Yeah, very important, absolutely. And whatever you have said was also echoed in different contexts from different nations. Yeah, so let's hope. But one of the issues with what Dr. Tim France and Mario, Dr. Ganga Khetkar, and many other people have said along the, I should say, since this morning, is that if you look at a long-term HIV care outcomes, they are often not what we really expect. This is what you and I all should, of course, demand and want and desire, that U equals U should be a reality for every person living with HIV. Then the evidence, the WHO guidelines got revamped, I think maybe 10, 11 years ago. The UNAIDS 1990 was based upon that. So, which is, I think, 2014 probably. So there's a lot of time, what Michelle Warren was saying, has passed since the evidence has come in place. And by the time it becomes a reality on the ground, that has taken an awfully long time. This is not acceptable. And probably some of the answers may lie in the presentations of Tim. Tim, please feel free, and others also, to chip in. Yeah. So thanks. Anyone else will like? This is a good space. Peter Oviti, you were saying, referring to Kenya and the loan repayment. If you are still around, Peter. Peter, are you there? If you can hear me, please unmute So use the camera, speak. Peter Witty had responded in the comment box about the when Tim was presenting about the loans and the impact of loans during the pandemic. And Dr. Dari Vianka, anyone else who will like to say, or if you like to share what you are doing at the upcoming World Conference, the 25th International AIDS Conference, those who are going, those are not going, joining virtually, please be welcome. Peter, yes. Peter Oviti, as those who have joined us late, is from VOTE Youth Development Project and a very noted TB and HIV activist in Kenya.
Yeah, sorry, you wanted me to ask the question?
Peter, you had commented about the Kenya loan repayment in when Tim was presenting. So if you can just tell us more context, that will be good.
Yes, for the last 6 months, starting last year, December, we haven't been having vaccines. And there was an outcry, the mandatory vaccines for children. So we ended up that there was no vaccine and we were approaching the budget. When we were approaching the budget, there was no allocation for vaccine as well. And so we were worried that children are being born and they are not getting vaccinated. And therefore, and the reason why we did not have the vaccine is Kenya had a debt of $2 billion US dollars, 500 billion for Gavi, for UNICEF, and 1.5 for Gavi. They were not able to pay, and therefore Gavi and UNICEF was not able to give the mandatory vaccines. And we were now trying to see measles coming up again in some regions of the country. So when we put pressure and we started Twitter and we had a Twitter storm to the government, then they paid the debt so that we can get the vaccine from Gavi. So right now we are doing the catch up that we want. During that period, we had about 1.5 million children were born and they were not vaccinated. So we are doing catch up now with the available vaccines to vaccinate those children, those zero-dose children. But the question is that the money that was paid was for catch-up. We don't have a budget again for the children that are being born after June. So that is a big problem. And that is why I was excited about the issue that when Kenya is classified by the World Bank as a middle-income country, and it can still not afford its own vaccine because middle-income countries now don't have the support from Gavi or UNICEF for subsidy or for assistance. That's where the problem is. And that's what I wanted to highlight. And I'm sure I'm very happy that it was also mentioned in this platform.
Yeah. Thank you, Peter. Thank you. Yeah, anyone else? So any comments, reflections, thoughts?
Bobby, this is Tim again.
Yes.
Thanks, Peter, for the extra information. I didn't know about the vaccine shortages. It was something I was actually anticipating, but you kind of reinforced the point I was trying to make by using.
So already, of course, you guys know there's an issue, but
you kind of reiterate the point I was the very point I was trying to make, Peter, which was that debt that Kenya had built up to Gavi and UNICEF was actually over the last, I think it's 8 years or maybe 6 years of the transition period. So countries, when they reach a certain GDP category, are supposed to transition into paying for their own vaccines over a period of 6 years. But Kenya wasn't able, for whatever reason, wasn't able to make that payment and in effect built up a debt with Gavi and UNICEF. So I just think that it's typical, or not typical, it's going to be repeated as countries are expected to transition out of this kind of international support, that these are such expensive interventions. They just won't be able to either afford it or prioritize it over other things that have to be spent. And that may be a political question, it may be a financial question, but it's only going to have one impact on some of the health metrics. And for example, you said 1.5 million children that went unvaccinated. So thanks for repeating that point. When I mentioned it, I thought it was just kind of almost kind of a random thing I was mentioning, but by the sound of things, it was actually more important.
Thank you, Tim. Dr. David Parirenyatwa is here. Dr. David Parirenyatwa, if you can hear me, you're welcome to speak. Sorry we missed you earlier in the day. As most of us will be knowing him, Dr. David is the former health minister of Zimbabwe and president of Society for AIDS in Africa, the host for ICASA, the International Conference on AIDS and STIs in Africa. Dr. David? Okay. Please. Anyone else, if you have any reflections, thoughts, please be welcome. We'll share the link to the recording for sure. The YouTube recording is in 2 parts because we were told that you.
Hello.
Yes.
Hello.
Yes, Dr. David. Yes, please, sir. Please.
Oh, no, thank you very much indeed. I must apologize because I was supposed to chair a session earlier on, but we had problems here with network. But looks like your whole program moved well. And I think the highlighting of tuberculosis vis-a-vis the factors that make it worse, I think has been really elaborated so well. Poverty is one of them. The issue of HIV has always come up because they are twin problems. And I think funding, where now the poorer countries are saying, well, we can't afford this, we can't afford that. I think now, because of the emphasis on domestic funding, it is important for each country now to look into its own coffers and see how they can use their money effectively into the health sector, including into TB. And now that you have had this particular huge webinar, which has been over so many hours, and I see so many ideas have come up. And if countries can summarize it, and we hope that at the International AIDS Conference and also at our own ICASA, we should be able to summarize this and articulate it so that more people can hear of these new, very innovative ideas. Sometimes we repeat the same things, but there are a few points, especially the issues of community, that the emphasis should be on the community. The emphasis should be able to say to ourselves, what resources are we putting in as countries? And also to be able to make sure that our own heads of state are familiar to the issues of TB. Often we fear to talk to them about this. And I think it is the issues that we must articulate. But I must say, really, this was really a brilliant webinar, which has benefited those who have been listening to it. And at IAS and at ICASA, we must carry this message through particularly. Thank you so much.
Thank you so much, Dr. David. Dr. David Pagwesese, as we all know, he is the former Minister of Health of Zimbabwe. And in his tenure, a lot of very important work was done to advance TB, HIV collaborative activities despite challenges in the context of Zimbabwe. So thanks a lot, Dr. David. And special thanks to Dr. David and ICASA and the Society for AIDS in Africa for co-hosting this whole session. As we all know, 35 organizations came together in the spirit of partnership to host this. One of the first few, we'll talk about it later, but it is really important that so many organizations from different parts of the world joined hands. Thanks a lot, Dr. David. Your points are very, very important, sir, especially as you have been here in the session for at least, I think, 6-7 hours. So thanks a lot for giving us this much of time, sir. Thank you, Dr. David. Thank you.
Thank you. Thank you.
Thank you. And your point about domestic financing, I think Dr. Tim France and other presenters had also referred to that, but it is important that it resonates with the person like you who has direct experience, such a long tenure experience with the how with the governments and HIV and health programs.
Thank you so much. Thank you.
Yeah. So let's hope. So if anyone wants to speak, please be welcome to raise your hand. And otherwise, we will be on. We're wrapping it up in next few minutes. We are really hopeful that we can't lose hope. First of all, because this is not acceptable that that people continue to die of a disease which is so preventable. Dr. Mario Revelione had told us in 2014, 10 years ago, that not doing drug susceptibility testing for before starting someone on TB therapy, not knowing whether these medicines will work on that person or not, is clinical malpractice. In 2024, in March, in a session, he said that it's almost a crime in today's age, in 2024, if we continue to do that. Dr. Michelle Warren's message, and which was also echoed in some different manner by so many people, that we have the tools to prevent the transmission of TB. We have the tools and evidence on how to find more TB. We have the WHO recommended molecular diagnostics. We have the WHO recommended only point of care, lab independent, battery operated, decentralized molecular test. You can take it to the field. In Nigeria and DRC and so many other countries, they are using it with solar power. Amazing to see that kind of technology is there. But where is the gap? Is it going on scale? We are still not able to find all TB among people living with HIV and in the population. And obviously, there is a huge gap if you see the full cascade of TB HIV care. We see a lot of gaps. People drop out of care. I was reading a study from 2010 to 2021 about what happened of those people who were put on antiretroviral therapy. And it is so shocking. Out of almost half of them were only retained in care. Only half of them are at the end of 3 years. At the end of 3 years in different countries in Africa, some in Asia, some in Latin America, only half of them were retained in care. And out of those half, only about 2/3 were virally suppressed. So if you compare it with those 100 who started on treatment, only about 25 to 30 were virally suppressed. We can do so much better. This is not acceptable. Even so program long-term HIV care outcomes need to improve. We have to, there is zero excuse. We have to find all TB. We saw how important it is to go out in the communities. And we cannot go out in the communities if we do not adopt and trust and let communities lead. We have amongst us Nathakorn, Ray. Ray had presented so powerfully what happened in Thailand when community-led interventions took the responsibility, and government trusted them in a way to do this and roll out so many cascade of services, including pre-exposure prophylaxis, HIV prevention services, treatment services. We saw the kind of impact which it had. And no other country in the whole of Asia Pacific, apart from a few exceptions, has been able to do so. Even in the country where I come from, India, programmatically, I am not sure PrEP is PrEP. Rather, I do know that PrEP is not part of it. This is not acceptable. PrEP was approved in 2012. Female condoms were approved in 1993. Have they really translated into HIV the impact for which they were created? We have somewhere, we really need to do way more better. Let us hope that we are able to find all TB. First of all, if we have to end TB, we have to find all TB. And as we heard from Timur of TB People Global, that the last mile, the problem is with the last 5-10%, we just say that we have covered 90%, but the real challenge is the remaining one. And maybe the more of the same may not work. We may need a whole new way of thinking and approach, what Tim was also pointing towards, to reach out to those people with services in a way that is sustainable, that they can trust, that they can access, and whether it is TB, HIV, or nutrition. I will tell you a very powerful experience which I had maybe 2 months ago. A homeless person where I live in Delhi, is now, and he got cured. So I went to speak to him with the Humana, and Humana people may be here in the room. Humana People to People India frontline healthcare workers are doing amazing work. Humana People to People India in their meeting room. This meeting was being conducted in person. So thanks a lot, Humana. So their frontline health officer went with me to meet this person. So this person was no longer receiving food after getting cured of TB. So the point here is, on one hand, governments recognize that it is important to give nutrition during the TB therapy. There is so much of evidence, so much we know that we need to give. If food is a problem, then food is the best vaccine to protect people from getting TB again, from putting other people in the contact so that they don't get TB, and other things. Hunger is also a promise that governments have committed to. So let us hope we are able to do more than just NTB. We cannot just handpick goals of SDG goals and targets and progress on them. We have Lisbeth Arup from Humana People to People India. Lisbeth, thanks a lot for doing this work. I have personally not come across any organization so far that has been doing such an important piece of work in a population which is so difficult to reach. And friends, you will be very surprised. This is in the heart of India's national capital, Delhi. Lisbeth's team also works in many other cities, like urban cities like Kolkata, Hyderabad, peri-urban Mumbai, and the kind of work which they're doing is really is a very strong reminder that how important are the frontline health workers and the systems that support them. Lisbeth, if you can hear me, please be welcome to speak.
Yes, I can hear you very well. And I would say thank you for your very kind words and big support. And very much thank you for doing this initiative today. I think that recently we discussed about our program created in Humana People to People, not in India, but in our federation many years back, where we say total control with the epidemic. That was our initial program in the late 19th. And there we created a sentence saying that only the people can liberate themselves from HIV/AIDS, the epidemic. And I think that this session that we have had today has contributed enormously to this, because it is not a task for one person, it's a joint task for all of us, and today has contributed with a lot of good knowledge, for some new knowledge, and we will use many of the sessions we have had today to share with other colleagues who could not be part of this session today. So I would thank all of you who have contributed to the presentations. It was really very useful, and we are also very happy to be part of this global network that CNS has created by bringing us all together. So thank you very much for today, and looking forward to the next session you organize in this manner. It is really very useful for all of us to be part of it.
Yeah, thank you so much, Lisbeth. Thank you again. And again, friends, a special thanks from all of us. Now, Ray, if you are here, please help us take a photograph. While Ray is coming up, let me please again remind everyone that Lisbeth and Humana group was the first one where we discussed this idea. It was at the idea stage. Should we even attempt to apply for an AIDS 2024 affiliated independent event? And Lisbeth's support really made this happen. Thanks a lot, Lisbeth. And also her office was fully ready to have this meeting in person in their meeting room. So thanks a lot for their support. And my sincere gratitude to each of your workers, each of your frontline community health workers, as well as the team in Humana, which supports them, so that people, homeless people, migrant people are found with TB. they're taken to the public services, they get best of care, and they're handheld, supported all through the process, and are able to tide through the treatment towards cure and long-term care. So thanks a lot for making that huge difference. A very difficult work. Friends, I have spent some very small time with them, and my heart is so full of gratitude and respect for the work which Humana has been doing. So thanks a lot. It's a real inspiration to see, and it's a real inspiration, but it's also gives me a sense how difficult the last mile was. Elizabeth, I'm not saying just to praise you, but with all sincerity and all responsibility, I'm saying, before I had gone to the field visit, I had really had not full sense of how difficult the last mile could be. So this is if it is a last mile. So, but it is really one of the ways to end TB is to go and find TB in the populations which have are likely to have very high incidence. And not just TB. There are a lot of other issues which coexist because the human beings face so many more issues.
Yes.
So thanks a lot for that.
Thank you too. I would like to add one thing, and that was I was absent for the webinar for a few hours because we went actually to talk to the Central TB Division, our national program here in India. And the discussion was about how can we scale this up, the intervention to reach out to the marginalized people in the big cities we have here in India. So that is a task we will work together with the Central TB Division and also specifically Delhi government on during the coming year. So we will report back to you and let you know about how we move forward in that task, because that is a very important task that many of us will have to work together about. So thank you again.
Yeah, thank you. And all the best, and really hope for the best. There's a long comment from Dr. Dari Vianka Lalu. Hello all, prioritizing taking WHO recommended point of care TB screening and diagnostic tool to the people's doorstep. Over-optimizing existing centralized or semi-centralized or lab-dependent tools or models which often have excess barriers, result in diagnostic delays, catastrophic costs, and dropout of people from the care cascade. This is a need. We need to make same-day test and treat a reality for everyone with TB. Let's join hands to work in collaboration to be able to reach our SDG goal of TB and HIV elimination by 2030. Thank you so much, Dr. Dari Bianca. This is so true. We all have heard all through the day how important it is to take services to the people, because it at least removes some of the barriers which Tim, Mario, so many others pointed out, other people pointed out experientially that which are there for the people to go to the services and access them. So thanks a lot for mentioning that. So yeah. Over to you. Maybe it is time for Ray to take over. Ray is from, as we all know, friends who have joined us late, leads MPLUS in Chiang Mai in northern Thailand. So welcome, Ray. Apart from doing amazing work which you do with the communities, here you are going to end this session on a special note. Over to you.
Hi, Ray. Thank you so much, Bobby. I think if anyone doesn't have any further question or one question to ask the chair, if you would like to turn the camera on, it depends on you. If you don't feel comfortable, it's okay too. So this is the first time that all meetings that hosted by CNS, and thank you so much, Bobby, for the host today and all the co-hosts. And I'm really grateful to be here. And also, you know, this kind of like ending HIV and TB, it's not an easy job, but at least we put ourselves so hard to like work and progress in our future. So I would love to encourage everyone to keep in touch with each other and also help each other and getting together like this. All right. Bobby, you have to do it. Bobby, can you like
So, sorry, please educate me how to do it. Just take a screenshot. How do we
I'm
do
a
it?
low-tech person too.
Okay, so let's take a screenshot. Okay. Thank you. Thank you. So
You
thank you
good?
so yeah, we are good. Thank you so much,
Thank
friends.
you.
Thanks,
Thank
Ray.
you.
Thank you, Ray, for
Thank
making this
you.
happen. Thank you. And thanks to each of the people who have joined us and tolerated us for so many hours. So thanks a lot. And next time we promise we will be a better plan. Thank you. Thank you so much. Thanks a lot for trusting in us and staying on for such a long period. But it was really invigorating. It was really made us think. Thank you, Tim. Tim has been a personal inspiration, a friend, guide, colleague, mentor. So thanks a lot, Tim, again for jolting us, for making us think in a very positive manner. Thank you, Dr. David. Thank you,
pleasure.
Elizabeth. Thank you. Thanks, everyone. Thank you.
Thanks, Bobby.
Thank you. Thank you.
Bye, everybody. Bye-bye.
Thanks a lot. Bye-bye. We will share you the link of the recording. There will be 2 YouTube links because we can't, YouTube doesn't allow recording of 13 hour plus something. So we have divided it into 6 hours and 7 or 8 hours. So, but we will send the recording and presentations of all the presenters who have consented us to do so. Thank you. Bye-bye.